Alright, hi guys, very good evening to all of you. Welcome to our today's NEET PG PYQ series discussion. And this is going to be at least 3 to 4 hour session, non-stop session where we'll be covering PYQs and I'll be starting from more latest than backward, like latest से लेकर के और पीछे की तरफ जाएंगे. So what I'll be starting will be NEET PG 2024 एंड देन 2023, 2022, 2021. तो जितने भी हाई यील्ड टॉपिक्स हैं जो जो आ चुके हैं उन सबको डिस्कस करेंगे और साथ में ये भी देखेंगे कि व्हाट इज द पैटर्न, है ना. इसमें कोई टॉपिक की सिमिलैरिटी आ रही है क्या नीट पीजी का जो पीवाईक्यू कर रहे हैं उससे हमें क्या बेनिफिट होगा एंड व्हाट कुड बी द नेक्स्ट पोटेंशियल एमसीक्यू जो आपके एग्जामिनेशन में आ सकता है, राइट. So please let me know if I'm clearly audible and visible to all of you guys, all the students, those who are live right now. Definitely this session is equally important as I have also mentioned on my इंस्टा पोस्ट कि नीट पीजी क्वेश्चन आपके एफएमजी में भी आते हैं. सो दिस इज गोइंग टू बी इंपॉर्टेंट फॉर नीट पीजी ऑल्सो, दिस गोइंग टू बी इंपॉर्टेंट फॉर एफएमजी ऑल्सो. दोनों के लिए ये सेशन इक्वली इंपॉर्टेंट रहेगा. क्विक कंफर्मेशन प्लीज, इफ एवरीथिंग इज फाइन आई विल क्विकली स्टार्ट विदाउट मेकिंग एनी फर्दर डिले. और एफएमजी स्टूडेंट्स के लिए तो एक गुड न्यूज़ है, मैंने पहले भी बोला था कि एफएमजी मैराथन मोर लाइकली 6 से स्टार्ट हो रहा है, 6 जुलाई से. तो उसके लिए भी आप लोग तैयार रहिए. वर्कबुक बेस्ड सेशन रहेगा. वर्कबुक का पीडीएफ पहले से ही आपको प्रोवाइड कर दिया जाएगा. यू कैन प्रिंट, यू कैन राइट ऑन योर आईपैड. आप सभी के लिए वो अवेलेबल होगा. तो 6 से 7 दिन का क्विक रिवीजन सेशन होगा जिसमें थियरी पोर्शन को क्विकली हाई यील्ड टॉपिक्स और प्रीवियस ईयर टॉपिक्स के बेसिस पे रिवाइज कराया जाएगा आपको. तो एफएमजी के लिए वो भी आने वाले समय में सेशन रहेगा, राइट. स्टार्ट करें, चलिए मज़ा आने वाला है. तो प्लीज़ जितने भी तकलीफ़ें हैं, परेशानियां हैं, दिक्कतें हैं कि फार्मा को लेकर कैसे रिवाइज करना है, थोड़ी देर के लिए प्लीज़ साइड कर दीजिए और मेरे साथ बस जुड़े रहिए. अगर आप लिखना चाहते हैं तो लिख लीजिए, नहीं तो पीडीएफ एट द एंड ऑफ द सेशन विल बी अवेल्ड टू ऑल ऑफ यू गाइस. पीडीएफ मिल जाएगा. पीडीएफ के लिए बार बार मत पूछिएगा, परेशान बिल्कुल मत होइएगा. पीडीएफ आपका है, मैं इस पीडीएफ को कभी दोबारा मुड़ के भी नहीं देखता, है ना. ये उस मेरी ब्रेकअप वाली गर्लफ्रेंड के जैसे है जिसने मेरा दिल तोड़ा था, जहां मैं मुड़ के भी नहीं देखा. इस पीडीएफ की तरफ भी हम कभी मुड़ के भी नहीं देखते, है ना. ये सिर्फ आपका है, आपको मिल जाएगा. तो आप बिल्कुल भी परेशान मत होइएगा कि सर ये पीडीएफ कहाँ आएगा, ठीक है. स्टार्ट करिए, फिर देखते हैं कि ये देखिए लास्ट में ये पूछना कि इज दिस गोइंग टू बी एनफ रिवीजन के लिए. डेफिनेटली पीवाईक्यू के लिए डेफिनेटली इट इज गोइंग टू बी सफिशिएंट बिकॉज एग्जामिनर 3 से 4 एग्जामिनेशन को ही रेफरेंस लेकर के चल रहे होते हैं हमेशा, ठीक है. तो देखते हैं, आप कंटिन्यू करिए, लेट्स सी हाउ इट गोस, ठीक है. आपको खुद अंदाजा हो जाएगा कि हाउ गुड या हाउ इंपॉर्टेंट इट इज, ठीक है. चलिए, सबसे पहला जो क्वेश्चन बार बार आता है, इस क्वेश्चन का मतलब मैं बता दूं एफएमजी में, नीट पीजी में, एनआईसीटी में रिकॉर्ड बीट है कि क्वेश्चन आता है बीटा ब्लॉकर दैट हैज शोन टू डिक्रीज द मोर्टालिटी इन पेशेंट विद क्रोनिक कंजेस्टिव हार्ट फेलियर. क्योंकि क्वेश्चन 100 से भी ज्यादा है और मैं बोल रहा हूँ 3 से 4 घंटे में, क्योंकि मैं कंट्रोल कर रहा था कम क्वेश्चन डालो, लेकिन मैंने कहा नहीं, बच्चों को पढ़ाना है ना. तो उस चक्कर में थोड़े क्वेश्चन ज्यादा हो गए, क्योंकि मैं कोई क्वेश्चन छोड़ना नहीं चाह रहा था. किस क्वेश्चन को छोड़ूं, किससे क्वेश्चन आ जाए. तो मैं मोस्ट क्वेश्चंस को लेके आया हूँ 21, 22, 23, 24 को, ताकि आपका कुछ छूटे नहीं, ठीक है. तो इसलिए 3 से 4 घंटे के लिए प्लीज अपने आप को पूरी तरह से अनऑक्युपाइड रखिएगा. खाने पीने का चीज चाहिए तो ले लीजिए, मंगा लीजिए और लेट्स स्टार्ट. नाउ इस क्वेश्चन का जवाब आई थिंक सभी को आता होगा. मोस्ट ऑफ द स्टूडेंट्स आर ऑलरेडी अवेयर अबाउट दिस. नाउ आर कार्डियो सेलेक्टिव बीटा ब्लॉकर इफेक्टिव, आर बीटा ब्लॉकर इफेक्टिव, यस. बट अगर बोला जाए कि कार्डियो सेलेक्टिव, क्वेश्चन बोला है कार्डियो सेलेक्टिव, क्योंकि सारे के सारे तो लॉल हैं, लेकिन कार्डियो सेलेक्टिव बीटा ब्लॉकर दैट वी हैव, all the cardioselective ish. Okay, sorry for that, I'll take care of the language issue, don't worry about that. Cardioselective beta blocker that we know that has got approval to be utilized in a patient with a chronic congestive heart failure is going to be BMC. Now what is BMC stand for? BMC stand for your bisoprolol, metoprolol, bisoprolol, metoprolol and carvedilol. Out of all of them, remember carvedilol as a drug that is known as your third generation beta blocker, and it is the carvedilol that is one of the third generation beta blocker. In one of the examination, examiner asked what is the mechanism of action of labetalol and carvedilol. So usme you should know that this is going to be a beta blocker with alpha 1 blocking property. That is point to be noted, number 1. Next potential MCQ ये derive हो रहा है ना. Next अगला, it is also having antioxidant property. It is also having anti oxidant property, it is also having antioxidant property. Now these are the three important. So we got our answer already. Now you might be wondering, sir kya yahi question puchega? No, no, not at all. Do not think ki this exact question will be asked or maybe asked. Majority times में the topic is going to be asked. So what could be the next potential MCQ? Let me derive that for all of you guys. Next potential MCQ examiner के mindset से देखते हैं, है ना? This is also going to be third generation, है ना? This is also going to be third generation, same like carvedilol. So these are the drugs that is decreasing mortality in a patient with a chronic congestive heart failure. And I always say that if you want to decrease the mortality, you should have apps, 4-pack apps, not like us, the single apps. No, single apps will increase mortality. If you want to decrease mortality, you should have the apps, at least 4-pack wala apps. Okay, let us see what is the meaning of 4-pack wala apps. आर्नी आज के टाइम पे सबसे बेस्ट है आर्नी. Overall it is the best one, although it is going to be a combination drugs. Combination may be the best one. Then we have ACE inhibitors, all the prils, ARB, all the sartans, aldosterone receptor blocker, that is going to be spironolactone, beta blocker that I have told you already, and then we have SGLT2 inhibitor, empagliflozin. SGLT2 inhibitor, remember, is having lot of benefit. So there is no examination nowadays where they do not ask question on SGLT2 inhibitor, because you go to any conference, you go to any CME, any symposium that is happening, there are people who are talking about SGLT2 inhibitor. Hi, this is SGLT2 inhibitor. ये है मेरे सपनों का राजकुमार, दिल के लिए, किडनी के लिए, डायबिटीज के लिए, जिसके लिए बोल दो, है ना? There are a lot of studies that is going on SGLT2 inhibitor right at present. तो nephroprotective property है, anti diabetic property है, remodeling process, I mean cardiac remodeling के लिए भी है, mortality reducing property है. It has a lot of property, right? तो SGLT2 inhibitor is one of the high yield topic that is definitely going to be asked in one of the examination, right? एक में तो सिर्फ side effect भी पूछा था 2023. You must have seen what is the side effect. I'm pretty sure you guys are aware. Most common side effect of SGLT2 inhibitor is going to be UTI. 3 बार UTI? नहीं, UTI है ना, ये याद रखना है, ठीक है? Now one more question that is stuck in the examiner's mind and can be asked at any point of time, that which of the following drug will actually reverse the remodeling process? See, reversing the remodeling is not seen by any other drug except the beta blocker. Beta blocker is the only group of drug that are shown to reverse the remodeling process. ठीक है? Reverse the remodeling process. Yes, I will continue English. Don't worry, you will not miss anything. English, I mean, whatever the topic that needs to be discussed with all of you guys, it will be taught to you in English. Don't worry about that. I am not leaving anything. Hana? Language will not be a barrier for you. Sit back, relax, and enjoy the flow that we have. Okay? All right, so these are the 4-pack apps that we know that is going to decrease the mortality. इसके अलावा, in addition to that, what else I have taught you, that SGLT2 inhibitor का role that is there in almost every condition. Apart from that, what is ARNI overall best? It's a combination of ARB. It's a combination of ARB and neprilysin inhibitor. Right? Do you guys know that what is this neprilysin inhibitor? In our body, we have multiple peptides. One of the peptide that I wanted to discuss with all of you guys is called BNP, brain-derived natriuretic peptide. You see, brain-derived natriuretic peptide, the name itself is having natriuretic. Natriuretic. They will be causing loss of sodium and water, and they will also be associated with causing vasodilation. Like any other peptide, this peptide will also be metabolized with the help of enzyme neprilysin. The other name of neprilysin is called your neutral endopeptidase. So neprilysin is abundantly present in the body, causing rapid breakdown of the peptide like BNP. If you want this excessive sodium and water loss, that means fluid loss out of the body, vasodilating action that is utmost important in a patient with the chronic congestive heart failure, we have to give something called your BNP analog. We have to give something called your BNP analog. BNP analog, brain, BNP analog, and the name of the BNP analog that we know is called your nesiritide. The name of the BNP analog that we know is called your nesiritide. Nasha. Nasha. Brain say you develop nasha. है ना, नेसीरीटाइड, ब्रेन से यू डेवलप नशा, नेसीरीटाइड, रिमेंबर दैट, ब्रेन derived natriuretic peptide, नेसीरीटाइड. Now that is a different level question. I am pretty sure it could be there at any point of time in your examination, but my in heart failure we are using that also. In addition to that, you can also give your patient something called your neutral endopeptidase inhibitor. If you see, if you block neutral endopeptidase, automatically you can see that BNP level will increase, the level of BNP will increase. The name of the drug is going to be icardotril and sacubitril, icardotril, sacubitril. So we take ARB plus one of the trill, that is sacubitril, and we make it as a ARNI. Overall, it is the best drug. But remember, this is not a single drug. It is going to be a combination of the drug. ARNI is a combination of drug. If they ask you single best, then the single best will be ACE inhibitor as always, right? Single one, it's going to be ACE inhibitor that will have best result, best outcome as always. Okay? So from this question, we have quizzed down multiple important information. I'm sure you guys will be able to cover that and you'll be able to put it as it is, as I have given to all of you guys. Okay? Pushing for the next one. A patient with mild to moderate renal failure requires reversal of muscle relaxation induced by vecuronium. Vecuronium, rocuronium, remember guys, agents like vecuronium plus agents like rocuronium. These rhonium agents, what are these? These are actually considered as a non-depolarizing muscle relaxant. All of you, as soon as you see the question, start giving the answer already, है ना? छप्पर फाड़ दो, है ना? रिप्लाई का, है ना? अपना छप्पर नहीं, रिप्लाई, start giving the reply immediately. Now you know already that these are muscle relaxant, non-depolarizing muscle relaxant. These non-depolarizing muscle relaxant, what do? They will be acting by blocking your NM receptor. Post-operatively, you have to give the reversal agent. For the reversal of these, what do we always give is something called your neostigmine. Reversal of these, what do we always give is something called your neostigmine. In addition to neostigmine, we also add atropine. Now that is a whole level different question. Why atropine is added, that will be covered in upcoming question. But do remember, this is what we use for any of the non-depolarizing muscle relaxant, not necessarily this, but a specific agent for rocuronium and vecuronium. A specific agent for rocuronium and vecuronium. In दोनों के लिए the specific agent that we know is called your Sugamadex. Sugamadex, right? Sugamadex is one of the chemical antagonists. Sugamadex is one of the chemical antagonist, right? They are going to bind with rocuronium, vecuronium, bind with them, rocuronium, vecuronium. I have taken the first letters, rocuronium, vecuronium. They will inactivate this compound and they are going to promote their excretion. So this is how they are actually going to work. We are not going to use succinylcholine. Succinylcholine in itself is a depolarizing muscle relaxant. Please remember, in a T and D form or in a PYQ that we do, exact question is never important. What is important is everything that is discussed around that is important. So you have to be careful about the options. Next, in the upcoming examination, the examiner will simply do some changes in the question. Sometime option remains the same and answer will change because there are some changes that has been done in the question, right? What is the physostigmine? I'm pretty sure all my students are already aware about the fact that physostigmine, it is one of the reversible acetylcholine esterase inhibitor. Physostigmine being a reversible acetylcholine esterase inhibitor, they are considered as an antidote. See, they have many uses. Antidote for atropine poisoning, antidote also for the datura poisoning, antidote for atropine and datura poisoning. In fact, there has been one question that was already asked on this one, which I'll be showing you, most likely 2023. Okay, rivastigmine. They are also reversible acetylcholine esterase inhibitor, but they are the synthetic one. Rivastigmine we mainly prefer in the management of the Alzheimer's disease. Rivastigmine, galantamine, and donepezil, they are going to be utilized in the treatment of the Alzheimer's disease, right? Alzheimer's. Rocuronium, vecuronium, these are the one. right? So I hope that all of you guys have got the correct answer and everything that I wanted to discuss around this question, right? Do remember that. Zoya Vani, I didn't get your question. Zoya nahi, Maru, right? I'm strange. Maru is also asking question from me, all right? Marrow, why only for ROVE, rocuronium? They are the specific for them. That is specific for them. More specific for vacuronium, rocuronium. Next question is going to be about aprepitant is a drug that is used in the treatment of some cases of chemotherapy induced nausea and vomiting. What is the mechanism of action of this drug? What is the mechanism of action of this one? Aprepitant, that is going to be PK antagonist. Aprepitant PK antagonist. Now, these are known as your NK1 antagonists. What are these? These are known as your NK1 antagonists. Aprepitant, rolapitant. So they have already asked this question. Aprepitant, rolapitant, and they have also asked you about netupitant. Netupitant. P antagonist. The name is having everything. These are the NK1 antagonists. Excellent, all of you guys. NK1 antagonist, not NK3, right? Not agonist, NK1 antagonist. These are considered as a drug of choice for chemotherapy induced nausea and vomiting, which is the delayed one. Now, always remember, for the prevention of chemotherapy induced nausea and vomiting, what do we use for the prevention of chemotherapy induced nausea and vomiting? What do we use? We always add 5-HT3 antagonists. So that means prior to the infusion of anti-cancer drug, listen to me what I'm saying. Prior to the infusion of the anti-cancer drug, there will be fluid loading for the nephroprotective property. So in that fluid only, we infuse 5-HT3 antagonist. That is called ondansetron, granisetron, palanosetron. So this is going to be utilized for the prophylaxis. That means the problem has not arrived yet, but still we are giving. We are going to call it as a prophylaxis. During therapy, even after giving ondansetron, granisetron, palanosetron, some patients still develop nausea and vomiting. So we can give another dose of the same. So if the next time examiner is going to ask you that what is drug of choice for chemotherapy induced nausea and vomiting, the answer to this question is also going to be same, that is 5-HT3 antagonist, which will be ondansetron. So prophylaxis also same, drug of choice for active management also same. Sometime even after discharge of the patient, 24 to 48 hours after the patient is coming non-responsive to ondansetron or any other 5-HT3 antagonist, right? Then we are going to call it as a delayed nausea and vomiting, and for that the drug of choice will be NK1 antagonist, that is aprepitant, rolapitant, netupitant. Aprepitant, rolapitant, netupitant. Other drug that can be utilized will also be dexamethasone. I'll tell you, if you guys have been following previous year question, it is so powerful to understand and so powerful to know the PYQs, that in one of the 2022 NEET PG, examiner says that what all drug will be used in the management or prevention of chemotherapy induced nausea and vomiting, and each option has 3 drugs. Each option had 3 drugs: ondansetron or either granisetron plus aprepitant, and it also has dexamethasone. Dexamethasone is one of the steroid. Remember, dexamethasone is one of the steroid. It's one of the phospholipase A2 inhibitor. They will always act as an anti-inflammatory action around the vomiting center, because the inflammation around the vomiting center is inducing vomiting center, causing nausea and vomiting. Right? Ondansetron, granisetron, yes. In any case, even the during therapy also, prior to chemotherapy also, we will be giving ondansetron. They are the one that is very safe kind of drug. Delayed nausea and vomiting, PK antagonist, right? So the 3 drug combination had, the correct answer was ondansetron, aprepitant, and dexamethasone. So any student who has had a good concept about it, they made it correct. Moving on to the next one, because as I told you, the question, we have a lot of question and we have to cover it effectively in the given time frame. Which of the following is an inclusion criteria for a shorter bedaquiline regimen in the treatment of tuberculosis? All right, so we all know bedaquiline. Now, what are the next potential MCQ that can be asked? First, all of you, can you guys tell me the correct answer, do you think, right? Anna, listen, session is equally important for FMG also. For FMG, there will be separate session that will be separately conducted. But rest assured that NEET PG questions are always going to be important in FMG also. Please give me the correct answer. Extrapulmonary TB like TB meningitis, rifampicin resistance with the both CAT-G INHA mutation, rifampicin sensitive, rifampicin resistant. Yes. Always a confusion when to choose a shorter and when to choose a longer regimen. Don't worry, you will not be confused after today. If you are going to listen to me for the next 3 to 4 minutes, you will not be confused. Anna? Okay, I think all of you guys are having correct answer is going to be rifampicin resistance, right? Rifampicin resistant, drug resistant, MDR TB, XDR TB, we can utilize them for both of them. Listen to me very carefully. We are going to have TB drugs. So do we not know that TB drugs are going to be HRZE, isoniazid, pyrazinamide, ethambutol, rifampicin, HRZE, isoniazid, rifampicin, pyrazinamide, ethambutol. Earlier we had streptomycin also. Now it is considered as a reserved drug. It is reserved drug from group B, group C. It is one of the group C drug now. Apart from HRZE, all other drugs are considered as a second line drugs. All other drugs apart from HRZE are considered as a second line drug. Now, what are those? Fluoroquinolone, bedaquiline, pretomanid, linezolid, thiacetazone, thionamide, para-aminosalicylic acid. The list is endless. Do you have to remember second line drugs? Not required. What you need to know? HRZE. Repeat with me. HRZE. They are the first line. All other apart from these are the second line. Now, coming back again to how do we use this one? See, drug sensitive versus drug resistant. What is unchanged since ages is the treatment of drug sensitive tuberculosis that will be given for a total duration of 6 months. Drug sensitive tuberculosis is going to be given for a total duration of 6 months. In the intensive phase, we are going to give why same for HRZD. In the continuation phase, we are going to give HRE. Intensive phase is always given for a shorter duration but with more number of drugs. What did I say? Shorter duration, more number of drugs. So we have 2 month ke liye HRZD and next 4 month we have HRE. Next 4 month HRE. So you can easily do the math that how many drugs are there in the intensive phase, how many drugs are there in the continuation phase. Now you might be wondering, sir, are you okay? Why are you telling us number of drugs? Watch out for 2019, 2020 NEET PG question where they have even given the number of drugs in RNTCP. And at that point of time, what we used to teach is revised national TB control program. So there also I have discussed that. Revised national mein we had different group of drugs. Now, currently what we are following is something called your National TB Elimination Program, NTEP. NTEP 2020, National TB Elimination Program. So this is lot of changes has been done. That is going to be your drug resistant TB. A lot of changes for drug resistant TB has been done. So we have MDR TB, XDR TB. Basic definition: MDR resistant with the isoniazid rifampicin, and XDR TB is going to be isoniazid rifampicin, any1 fluoroquinolone, any1 fluoroquinolone, and either linezolid or bedaquiline. If you compare the older definition, it was isoniazid rifampicin, any1 fluoroquinolone, and any injectable. You see, we are not using injectable in NTEP guideline ke under. We are not using injectable. So we will change the definition. The definition has also been changed. So we will study the changed one. Isoniazid rifampicin, any1 fluoroquinolone, and either linezolid or bedaquiline. Either linezolid or bedaquiline. All right. So you are asking, sir, where to use shorter regimen, longer regimen? See, we are having 2 shorter regimen, 1 longer regimen. Are you guys with me? Shorter regimen, longer regimen. Now the shorter regimen that is going to be utilized is for all the OPD based patient. The one is for 9 to 11 months. This is going to utilize for all the OPD based patient, all the patient with the MDR TB patient, right? At any point of time, if it doesn't work, then we shift to 18-month ka longer regimen. Do you guys know if this also doesn't work or the person will be diagnosed with the XDR TB, then we go for the 6 to 9 month regimen. Should I repeat again? I'm repeating again. Listen to me carefully. As I said that all the drug resistant TB, we are going to start 9 to 11 months. OPD based patient, whoever is coming, right? Then if they are non-responsive, we will shift to 18 month, non-responsive to 9 to 11 month. Plus there are other criteria as well. है ना, other criteria is also there, like pregnancy है, pediatrics है, someone is having severe extrapulmonary or severe pulmonary tuberculosis with the cavitation present. These are the other condition that we why we choose the longer regimen, right? If this doesn't work, then we go for the next regimen, this one 6 to 9 month wala. Then we go for 6 to 9 month wala, which we call BPAM regimen. Earlier it was BPOL regimen, now we call it as a BPAM regimen. Please follow with me. BPAM regimen का मतलब is, BPAM regimen is bedaquiline, pretomanid, linezolid, moxifloxacin. BPAM regimen, bedaquiline, pretomanid, right, linezolid, moxifloxacin, right? This will be mainly for patient non-responsive to long regimen, pre-XDR-TB, XDR-TB, or all the IPD based patient, those who require drug therapy. IPD based patient के लिए, IPD मतलब जो patient those who are admitted. This is only given for a duration of 6 to 9 months. Do remember that, right? No, this will be all 18 month will be all different therapy. It will all be started from scratch. 4 to 6 month, and this is the one that is for all the OPD based patient. Look at this here. This is for all the OPD based patient. OPD based patient of drug resistant TB. So this will be for a total duration of 9 to 11 month. Right, so this is the one that will be given for the drug resistant TB. 9 to 11 month will be divided into 4 to 6 month intensive phase, and next 5 month continuation phase. So in the first 4 to 6 month, what we give, listen to me carefully and you will never forget. Okay, the agent that we are going to give, I mean the drugs that we are going to give, you will remember by the simple mnemonic of BEI, BAY, CLEP, CLEP. Repeat with me, BAY, CLEP. If you have ever attended my class, you know this already, है ना? So why BAY-CLEP? Because if you look at the guideline, they have given in very haphazard manner, random manner, and students find it little difficult to remember, remember, recall and retain. ठीक है? So BEI, BAPES, है ना? आप सब लोग जानते हैं. All of you guys are already aware that is going to be BAPES, BAY-CLEP, है ना? BAY-CLEP, है ना? हाँ, अब BAPES हैं जो आती हैं आपके घर पे, एंड बेब्स इज टेकिंग एनीथिंग अराउंड दैट इज kept, or you can remember bay, clap, whatever way that you want. But the problem is my babes is clap, or let's say kleptomanic. I do not want to continue with such babes. I do not want to continue with the babes, those who is taking my sharpener, taking my all small stuffs from my home. Babes clap. No, 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 no. I should not be continuing babes के साथ, है ना, breakup, है ना. So I will continue only with the clap. So clap will be clofazimine, levofloxacin, ethambutol, pyrazinamide. Right? So you can easily remember. You might be wondering, sir, what is the advantage we are getting with the bay clap? Close your eyes and repeat. Bay, clap. Count the number of drugs without making any mistake. BEI, bay, CLEP, clap. How many drugs are there? You see, 7 drugs. So that is the power. Learn pharma in my style and you will never miss any of the question. 7 drugs in the intensive phase, 4 drugs in the continuation phase. Because sir said that babes के साथ continue नहीं करना है. Babes तुम्हारी kleptomanic है ना? Bay, clap. 7 days in the intensive phase, 4 drugs in the continuation phase, because I will continue only with the clap, right? Without putting any of the pressure, you will be able to correct this question very, very easily. Okay? At any point of time, did you notice that we do not use bedaquiline, that is one of the ATP synthase inhibitor, beyond 6 months? We never use bedaquiline beyond 6 months. Do you guys know that bedaquiline is one of the drug? This is one of the ATP synthase inhibitor. How to remember? B, bedaquiline, A, ATP synthase. B और A एक साथ, B और A और B एक साथ, right? Manid, pretomanid, delamanid, manid and manid, they are the mycolic acid synthesis inhibitor. They are the mycolic acid synthesis inhibitor. Simple question has been asked even on the mechanism of action, right? That is mainly due to free radical generation. Due to free radical generation, they will be causing mycolic acid synthesis. Linezolid is one of the protein synthesis inhibitor. Linezolid is one of the protein synthesis inhibitor, and moxifloxacin, fluoroquinolone, it's one of the DNA gyrase inhibitor. DNA gyrase inhibitor, right? They are the DNA gyrase inhibitor. So you have to know about these outside the box wala jo bhi terms hai, you have to know, and you have to know the basic detail about them. Another thing that examiner was asked in the very recent examination, was these two drugs, bedaquiline, predominant, they share a common kind of side effect. And what is the common side effect that they share? If I ask you, the common side effect that they are going to share is going to be QT prolongation. They both are the one that is going to cause QT prolongation. Both of them are also causing hepatotoxicity and electrolyte imbalance. They both are also associated with the hepatotoxicity and electrolyte imbalance. And this question has been asked already, whether it is causing QT prolongation, yeah, PR prolongation, yeah, ST segment elevation, right? So remember, they will be causing QT prolongation, and that is B palm regimen may bedaquiline predominate. So what I was telling you, that bedaquiline actually as a drug should not be given throughout the therapy. It is usually given for up to first 6 months or 24 weeks, right? So we have 9 to 11 months. After that, if it doesn't work, then what we are going to use is the longer regimen, and longer regimen is given for 18 months. In the 18 month, will be taking 3 drugs from group A, that will be LLB, LLB, and LLB is going to be linezolid, levofloxacin, bedaquiline. Linezolid, levofloxacin, bedaquiline. I have done this pre-writing just to make sure that we do lot of coverage in the shorter span of time. I think you guys can understand. Otherwise, if I keep on writing this one in the rapid revision kind of session, and you might be feeling little bored, and second thing, we will be losing a lot of time. But don't worry, this is my handwriting only, but I have done this pre-writing, so I have done a lot of previous homework before coming to the class here, right? So that we can save some time here. So LLB and CC, cycloserine clofazimine. Repeat with me. Longer regimen group A, group B. Longer regimen group A, group B. So group A ka all 3 drugs we will be using linezolid, LLB, linezolid, levofloxacin, bedaquiline. Group B, we have cycloserine clofazimine. We will be taking any one of these two. As I told you, that if any drug is not available or not working, then we are going for the group C drug. And I have told you already, group C is considered as the reserved kind of drug. Group C is going to be reserved, so all the other drugs are going to be under the reserved one. So how many drugs are there in the intensive phase? 3 drugs from group A and 1 drug from group B. So there will be a total of 4 drugs. So number of drugs is also going to be equally important, my students. Do you remember that? Okay, 4 drugs. In the continuation phase, which drug should not be used beyond 6 months because of the high cardiotoxic potential? That is bedaquiline. So we'll be giving linezolid, okay, levofloxacin, okay, either of the cycloserine or clofazimine. So how many drugs are there? Can you now tell me? That is going to be 3 drugs. I hope it is making sense to all of you guys, right? That overall, do remember that your drug bedaquiline will not be given in the continuation phase. So let me just give a quick 30-second recap, and then I can proceed to the next question, because हम लोग बहुत ज़्यादा टाइम ले रहे हैं इधर. ठीक है, चलिए. सबसे पहले drug sensitive tuberculosis, we are going to give HRZD, HRE. HRZD we are going to give for 2 months. HRE we are going to give for 4 months. So 4 drugs for 2 month intensive phase, then 3 drugs for the next 4 months, that is continuation phase. That is sorted, no doubt in that. Drug resistant TB, we have 3 different regimen, 2 shorter regimen or longer regimen. The shorter regimen that is commonly used for all the drug resistant TB is called BABE, CLEP. Babes मेरी kleptomanic, right? तो एक babes bedaquiline ethionamide isoniazid which is kleptomanic, I should not continue with such babes, right? So I'll continue only with the CLEP, that is clofazimine, levofloxacin, right? I'm going to continue only with my CLEP, right? That is going to be clofazimine, levofloxacin, ethambutol, and pyrazinamide. So how many drugs are there? 7 drugs in intensive phase, 4 drugs in the continuation phase. If it doesn't work, then we can go for the 18-month regimen, where we'll take group A ka 3 drug, group B ka 1 drug, LLB, CC. Repeat with me, LLB, CC. B bedaquiline should not be used, so we'll be continuing only with the LL, either of the C or C, cycloserine or clofazimine. So 4 drugs in the 4 drugs, first 4 drugs, and then next 12 months. There is no intensive or continuation phase in this one because we are using the same drug. It's just that we are removing 1 drug. है ना. There is no intensive phase in the longer regimen. They do not use the term intensive phase. If the patient doesn't respond to this also, then we go for BPAM regimen, or pre XDR-TB or XDR-TB के लिए also we give BPAM regimen, bedaquiline, predominate, linezolid, moxifloxacin. I think it is sorted. TB से जितने भी क्वेश्चन थे, whatever doubt that you had, I think you will not be having that kind of doubt anymore. Are we good? Can I proceed further? All right. Next one. A patient is found on railway track with hot, dry skin. Okay. So previous to this, they asked the question: a patient was brought from gutter, है ना, नाले से लेकर आया patient को. Similar kind of question, है ना, but the poisoning was something else. But when they ask, when they want to ask you, right, they'll be giving you options like this, questions like this: hot, dry skin, raised body temperature, dilated pupil, slurring of speech, and a staggering gait. Which of the following is the most likely cause? Railway track, hot, dry skin, point to be noted, number 1. Body temperature raised, number 2. Pupils are dilated, number 3. Right? So my way of handling this type of question is very easy, and let us understand and see how to make this very, very easy for all of you guys. Excellent. Most of you are giving Datura poisoning. Very good. Datura poisoning, and the antidote is also given. Antidote is called your physostigmine. I think I have already given you this one in the question number 1 or 2. We discussed this already. Okay. Now let us quickly sort out and see why others are not option. You see, opioid में the patient will present to you with the pinpoint pupil. There will be no dilated pupil. There will be pinpoint pupil. Also, there will be no increase in body temperature. No increase in body temperature. Body temperature will also not be increased. Cocaine poisoning में, yes, there is going to be mydriasis, yes, है ना, there will be mydriasis, but other thing, there will be no body temperature, there is no hyperthermia, no increase in the body temperature. Remember that, no increase. Plus cocaine poisoning में the patient will usually come to you with the feature like cocaine bugs. Cocaine bugs may be present, black tongue. Someone has attended my class in offline or in online, whichever mode, and they are giving the correct one. Zoya Vani, look into the eyes. I always says, look into the eyes, and eyes never lies. Listen to me very, very carefully for the next 2 minutes, and one question definitely is going to get sorted from this table. I always say, eyes never lies. So there are two type of poisoning where the patient will be always try to confuse you, although it's not confusing, but student get confused. Organophosphate carbamate, they are the irreversible acetylcholine esterase inhibitor, guys, that will be increasing the acetylcholine level. When you look in the eye in a condition where the acetylcholine level is going to be very high, the patient will usually have miosis. When the miosis is very excessively high, we call them pinpoint pupil. Body temperature will be normal, maybe lesser because of the too much secretion. Heart rate is going to be lesser. The antidote for this one is going to be atropine. And in organophosphate poisoning, we can also add oximes. Oximes like pralidoxime, obidoxime can also be added here. But if I compare the same with the atropine or datura poisoning, I never say atropine as atopine. I never say atropine as atopine. Pankaj Tiwari saying that please other toxicity like opioid. See, I told you, है ना, आपने demand किया, आपके सामने I am already discussing the same, है ना. Now I never say atropine as atopine, right? Atropine as atropine. I say it always as a atopine. I always say atropine as a atopine because in atropine everything will be in the top. And I always compare atropine with your hardcore crush, है ना? Let's say the crush that is only coming in your dreams, that kind of crush, right? So that crush, if you are going to look in the eyes will be bigger, आंखें होंगी बड़ी बड़ी. Look at the body temperature, right? दूर से ही feel हो जाएगा, हाँ, body temperature भी होगा बड़ा बड़ा. There will be hyperthermia. And if the crush will pass in front of you, right, what will happen to your heart? Heart rate will also be बढ़ा बढ़ा. Everything will be bada bada, right? तो आंखें बड़ी 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 आंखों वाली आपकी क्रश, राइट, रिमेंबर दैट, बॉडी टेम्परेचर भी बढ़ा, हार्ट रेट भी बढ़ा हुआ, एवरीथिंग विल बी बढ़ा, है ना। एंड एंटीडोट ऑफ चॉइस इज गोइंग टू बी फाइसोस्टिगमिन इन बोथ द सिनेरियो, रिमेंबर दैट, है ना, इन बोथ द सिनेरियो। सो आई थिंक दिस इज सॉर्टेड। एट्रोपिन को आज से एट्रोपिन नहीं बोलिएगा, रीड इट एज एटोपिन, एवरीथिंग विल बी ऑन द टॉप। एंड कहां से स्टार्ट करेंगे, आंखों से स्टार्ट करिए, आंखें होंगी बड़ी बड़ी, ठीक है। चलिए अब आते हैं दो ड्रग पॉइजनिंग का केस। सो दिस टू कुड बी अ पेशेंट इज here there will be always a history of a farmer, they will always give a history of farmer, there will always be a history of farmer. Next is going to be history of a drug addict. If there is a history of drug addict, if it is going to be opioid poisoning, as I told you, opioid will be working mainly via Edinger-Westphal nucleus, and wahin pe there is nucleus of cranial nerve 3, and that will be causing stimulation of this parasympathetic outflow to the eye, that will be causing miosis. You see, via the Edinger-Westphal nucleus there will be miosis. When the miosis is very high, we also call it as a pinpoint pupil. They have cardiac depressant property, so that will decrease the heart rate and decrease the BP. They will also affect your GI. There will be decrease in the GI motility, GI secretion, तो constipation, है ना. Opioid poisoning, opioid will very much mimic your organophosphate, O and O. But do remember this: in opioid, they will always give a history of a drug addict. If there is a drug addict with a bradycardia pinpoint pupil, opioid. If there is a farmer with a pinpoint pupil bradycardia, most likely organophosphate carbamate, right? The antidote for this one is going to be naloxone. Naloxone is going to be the specific antidote for this one. De-addiction or substitution therapy के लिए we are going to use partial agonist, that is called your buprenorphine. Buprenorphine is going to be the partial agonist. Cocaine poisoning. Cocaine, remember guys, it is one of the agent that is going to act by inhibiting norepinephrine transporter. So they inhibit the reuptake of catecholamines. Therefore, the catecholamine level will be high, like sympathetic outflow will be high, norepinephrine will be high. That is going to increase the blood pressure, mydriasis. So this is totally opposite to opioid. In opioid, the heart rate and BP was decreased. Here, the heart rate BP is increased. Opioid, there was pinpoint pupil. Here, there is going to be mydriasis. है ना? Cocaine bugs, jet black tongue, these are the other findings, finding to help you out in coming up with the proper diagnosis. You are going to manage this symptomatically. For example, if the BP is high, you will have to handle the BP. If the heart rate is high, you will have to handle the heart rate with the beta blockers and calcium channel blockers. So simply, whatever the symptom is there, we are going to use it symptomatically. So I hope it is sorted to all of you guys. Yes. Carbamate, organophosphate, sorted hai. Atropine, Datura also sorted. So opioid, cocaine. So there are 6 different kind of poisoning that I have summarized in this one. We are now going to go to the next question. A woman at 8 weeks of gestation is diagnosed with hyperthyroidism. Which of the following is the most appropriate treatment option? All right. So 8 weeks of gestation, I think you guys can easily tell me that 8 weeks is coming under which trimester of the pregnancy? It is diagnosed with hyperthyroidism. Which of the following is the most appropriate treatment option? What is the most appropriate treatment option? Methimazole, carbimazole, propylthiouracil, radioactive iodine. Start answering. As soon as you see the question, the answer should come with reflex, because these are all PYQs. There is nothing new in any of these. They are all PYQs. As soon as you see, you should quickly answer this. Go ahead, please. All right, so this is actually a case of first trimester. Now, this is actually going to be a case of first trimester. In maintenance therapy also, we can utilize your buprenorphine. And if you are proceeding with the therapy of opioid, someone has asked this question. Who is that? Sindhu Sins. Wow, Sins, है ना? So Sins brother has asked a question that what else can we use? So in the maintenance, we have many other options. For example, if you are using de-addiction, doing de-addiction therapy using methadone, so we have methadone substitution therapy. Followed by that, once you are done with that, then we'll be adding opioid antagonist. We are going to add opioid antagonist to make sure that there is no relapse. ठीक है, relapse को prevent करने के लिए we'll be doing that. and maintenance के लिए we can also use buprenorphine, which is a partial agonist. Okay, which of the following the most appropriate treatment option first trimester में? We will not be using methimazole, carbimazole. We are going to use what? We are going to use propylthiouracil. So this is the drug of choice for hyperthyroidism in pregnancy first trimester. Do you guys know it is also the drug of choice in the treatment of the thyroid storm? It's also the drug of choice in the treatment of the thyroid storm. Another question which is expected from this is going to be, this is 2024. I am discussing all 2024. Okay, propylthiouracil, how does it work? Propylthiouracil, it is going to act by inhibiting, right, thyroid peroxidase inhibitor, plus it also inhibits peripheral T4 to T3 conversion. It also inhibits peripheral T4 to T3 conversion. So these are the mechanism of action of propylthiouracil, dual mechanism. Methimazole, carbimazole, if it is exposed, they are considered the drug of choice in second or third trimester. Mind the fact that if it is going to be exposed in the first trimester, what will happen? If it is going to exposed in the first trimester, what is going to happen? They'll be leading to a condition that is called aplasia cutis. Abnormal development and no development of the skin over the scalp. Aplasia cutis. Definitely we can utilize propylthiouracil. They see both of them, they have the tendency to cross the blood-brain barrier. Propylthiouracil will have less blood-brain barrier crossing capacity. They have lesser blood-brain barrier crossing capacity. Okay? We can utilize PTU as well, right? ऐसा नहीं कि PTU is not used in the second, third trimester, but they are the more potent, more powerful methimazole, carbimazole, and if they're exposed in the first trimester, remember they will be leading to aplasia cutis. Radioactive iodine is a compound. Radioactive iodine, it should be contraindicated always in the pregnancy. They emit beta rays. They'll be contraindicated in pregnancy, and they'll be also contraindicated in young patients. Young patient less than 35 years. Young patient less than 35 years, they are going to be contraindicated. And yes, Sindusins, as you said, choanal atresia is also a possibility. Esophageal atresia, choanal atresia, fetal goiter, all of these are going to be the possibilities, right? So if you have attended any of the regular classes, I have given the entire list as well. Like, because they are anti-thyroid drug, fetal goiter will be one of the condition, fetal goiter, right? Then the other thing that they can cause will be abnormal scalp या atretic choanal atresia, esophageal atresia is also one of the possibility. Esophageal atresia, scalp defect. So this scalp defect is also given the name as aplasia cutis. So overall, I say that you have to look at the mnemonic faces. The other name of this one is also called your aplasia cutis. Overall, I say that you can remember like this: FACES, faces. Faces is a very, very simple mnemonic to remember. Methimazole, carbimazole mediated teratogenic effect. Okay. Why propranolol used in the thyroid storm? Although propranolol is not discussed here, we have a question on that. Abhijit Dev, just allow me a few minutes. I'll be coming to that and I'll be telling you why propranolol will be utilized. Abhi ke liye, for now I'm telling you propranolol is used in thyroid storm because it's a beta blocker. In thyroid storm, the cardiac activity is very high. The patient will be in arrhythmic condition, so we are going to use for that. Plus propranolol also inhibit peripheral T4 to T3 conversion. So this peripheral T4 to T3 conversion is also a feature of propranolol. So due to two important reasons, we are going to use propranolol, but we will not be using propranolol in asthmatic patient, and that is one of the favorite question of the examiner. Next question is, women at 30-week age of gestation is diagnosed with the deep vein thrombosis. Which of the following is the most appropriate for this patient for prophylaxis? Go ahead, please. Now this is going to be a little tricky question because a question like this has already been asked previously in NEET PG also, FMG also. This will be very, very tricky. A woman at 30-week gestation diagnosed with a deep vein thrombosis, which of the following is most appropriate to be asked in this condition at this trimester? Warfarin, low molecular weight heparin. So you see, at which age she is getting diagnosed? Is she a previous patient? No, 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 no. She is getting diagnosed at the 30-week age of gestation. Please follow. The question is saying she's getting diagnosed now. If she's getting diagnosed now, we will always try to keep the patient on the safer drug. So safer drug, safest one is going to be low molecular weight heparin. Safer or safest one is going to be low molecular weight heparin, right? What is apixaban? Apixaban is factor 10A inhibitor. Fondaparinux, it's also one of the low molecular weight heparin, but they are the one that is targeting only 10A. They are the indirect 10A inhibitor, indirect 10 inhibitor. They are also like low molecular weight heparin. इसको बोलते हैं ultra low molecular weight heparin. Ultra low molecular weight heparin. The one that is preferred is low molecular weight heparin. ठीक है. Now, when you are going to look at the anticoagulation in pregnancy according to American College of Cardiology or American Heart Association, ACC means American College of Cardiology, AHA is American Heart Association. According to them, according to those guidelines, in the first 12 weeks, 1 to 12 week, we are going to use low molecular weight heparin or unfractionated heparin, preferably low molecular weight heparin. In the 13 to 35 week, we are going to give warfarin to the patient because warfarin is a stronger one, and we know for sure that pregnancy is a hypercoagulable state. Pregnancy is a hypercoagulable state, right? Most of the clotting factor will increase except the 11 one, right? So do remember that we will be needing a stronger anticoagulant like warfarin. But around the peripartum, around the delivery, we will shift the patient again to low molecular weight heparin because we do not want more blood loss around the delivery, right? 4 to 6 hours after delivery, you will be starting heparin plus warfarin because warfarin is never started alone. Whenever you want to start warfarin, there should always be bridging therapy with the heparin, followed by the postpartum. You will stop after a few days, after let's say after 5 to 7 days, you will stop heparin and continue only with the warfarin, right? All right. If she is not pregnant, then अगर pregnant female नहीं है, if the pregnant female is not there, then we can proceed with the warfarin, the stronger one. But in that case also, you will never start warfarin alone. We should always give a bridging therapy with the heparin. Okay, now which of the following is represented by the below figure by X? So there is an image here, and they are saying that drug X. What does this image say? That there is something called plasminogen being converted to plasmin. There is something called PLG, plasmin activator. But look at this. This sign is saying that they are the blocker. This sign is used as a blocker. In every textbook, they say that this is going to be used as a blocker, right? So which drug inhibits the conversion of plasminogen to plasmin? Okay. Yes, to make sure that you guys are not missing any point, I'm telling you that overall safest in pregnancy, it is always going to be your low molecular weight heparin or unfractionated heparin. They are going to be the safest during the pregnancy, because if you expose warfarin, especially in the first trimester, they can cause fetal warfarin syndrome, also given the name as the Contradi syndrome. Okay. If a patient is already diagnosed in 30 weeks, if the patient is already diagnosed, this is for already diagnosed patient. The 1 to 12 week may you give heparin, 13 to 35 continue warfarin, 36 week may switch to low molecular weight heparin. So this is the guideline for someone who is already diagnosed. All right. Zoya Vani, sorted. All right, you're welcome, Abhijit Dev. Moving on. So can you guys tell me what is the correct answer for this one? Many of you are saying C, many of you are saying A. So you see, plasminogen to plasmin. So this is something called activator. So on the left hand side, there is activator. The activator for plasminogen to plasmin, I always say it is going to be streptokinase, urokinase, This is 2024 question. Streptokinase, urokinase, retiplase, altiplase, anistriptase, tenecteplase. So these are all going to be plasminogen activator, that is going to be SURAT. But examiner is asking that plasminogen to plasmin का inhibitor कौन है? Because here the sign is this one. This is the, in book they use it as a blocker. So who will inhibit the conversion of plasminogen to plasmin? So this conversion will be inhibited by two important drugs, epsilon aminocaproic acid, and other one is called your tranexamic acid, which is simply also given the name as a Tranexa or PAUSE. PAUSE is the brand name. Tranexa is the brand name. Tranexamic acid. Okay, so this conversion will be inhibited by epsilon aminocaproic acid. I think C is not the answer. You guys have made this wrong as a silly mistake, I would say. I would not say that you guys do not know. You know this already, but you have made it as a silly mistake. What is tenecteplase? It is one of the activator. What is aspirin? Aspirin is one of the COX-1 inhibitor that will decrease the thromboxane A2. This is also apne aap mein a question, that aspirin was given and the patient has developed bleeding. What is the cause? Decrease in thromboxane A2. And clopidogrel, it's one of the antiplatelet drug. It's one of the P2Y12 inhibitor. It's one of the irreversible P2Y12 inhibitor. It's an irreversible P2Y12 inhibitor, clopidogrel. Another potential MCQ clopidogrel is that clopidogrel always and always require activation, because clopidogrel is one of the prodrug. It require activation, and this activation of clopidogrel is going to be needing a microsomal enzyme CYP2C19. The microsomal enzyme that is required is CYP2C19. All right, so this is how we rule out other option, and we make sure that we cover all other option in these questions, right? So I have already told you in this one, epsilon aminocaproic acid, they are going to be utilized as the antidote of tissue plasminogen activator. So for example, if you are treating your patient with, let's say, streptokinase, urokinase, so these are going to be the antidote. These are going to be the antidote of streptokinase. Antidote for streptokinase is going to be epsilon aminocaproic acid. The full name is epsilon aminocaproic acid. Okay. Next one is a patient presenting with a hypertension. He has a history of renal stone. All right, so hypertensive patient with the history of renal stone and has experienced a few episodes of renal colic. Which of the following diuretic is most appropriate to use? All right, so patient with renal stone patient, what is the safe diuretic? What is the safe diuretic? See, clopidogrel, prasugrel, both of them are same. They are the both of them are prodrug. Both of them require their activation. Both of them are irreversible inhibitor. Prasugrel is little more notorious, on the notorious side. They will have more risk of bleeding. Okay, they are more notorious. We usually do not prefer prasugrel because of their high risk of bleeding. In this case scenario, safe diuretic. Always to remember that loop diuretic, they are associated with causing loss of, loop diuretic usually causes loss of calcium, and because of this reason, remember, loop diuretic are going to be contraindicated in two important conditions, that is called hypocalcemia. If there is already known case of hypocalcemia, loop diuretic should be contraindicated, and they are also going to be contraindicated if there is a patient with a history of renal stone. Now, why they should be contraindicated in a patient with the hypocalcemia? You see, hypocalcemia itself is an emergency, and if a diuretic, which is a very fast acting diuretic, loop diuretic are very fast acting diuretic, if you are going to give a drug that is further causing more calcium loss, that emergency will be precipitated. So you do not want to precipitate the emergency, right? You do not want to precipitate the emergency. Then they are also going to be contraindicated in a patient with a history of renal stone. Why? Because you see, when you give the diuretic, the calcium will be lost through kidney only, no? So more, if there is already renal stone ka history and you are going to cause more passage of calcium through the renal parenchyma, that excess calcium will be causing precipitation of, calcium in the renal parenchyma, and they will increase the stone size. They will increase the renal stone size. Okay. So furosemide should not be utilized. Loop diuretic will be contraindicated. The correct answer for this one is going to be hydrochlorothiazide. What is spironolactone? Spironolactone, it's one of the aldosterone receptor blocker. Aldosterone receptor blocker is called, we also say potassium sparing diuretics. We also say potassium sparing diuretics. Ethacrinic acid. What is ethacrinic acid? It's also one of the loop diuretic, but they are highly ototoxic. These are clinically not used. Ethacrinic acid, we do not use it clinically because they are highly ototoxic drug. Okay? Correct answer for this one is going to be B, hydrochlorothiazide. So do remember another very important point here that I'll just add, because I want to make sure that next potential MCQ should not be missed. If the examiner is planning to give you a question, that remember thiazide diuretics are going to be safe in renal stone patients. They are also considered relatively safe in patient with the history of hypocalcemia. We can continuously give because they increase the calcium reabsorption, and they are also considered the most preferred diuretic in the osteoporosis patient. So this will be the next potential MCQ. Osteoporosis में which diuretic will be preferred? That is going to be thiazide diuretic, because they inhibit the loss of calcium. Osteoporosis में we are going to prefer it, thiazide diuretics. Remember that. But at any point of time, I will never go out of habit to provide as much as possible. They are always going to be avoided in gout patients because they are going to cause hyperuricemia. Gout patient may you'll be avoiding them. Thiazides. Alright. Which of the following is the most appropriate treatment for overactive bladder in patient with dementia? Overactive bladder in patient with dementia. Ethacrinic acid we don't use, only Dr. Yasser Arafat. Gynecomastia is a side effect, yes, associated with gynecomastia, gift of gynecomastia. Gynecomastia, decrease in the libido, that is potassium sparing diuretics. Which of the following the most appropriate treatment for overactive bladder in a patient with dementia? In a patient with dementia, which of the following is the most appropriate drug? Trospium, tiotropium, telanzapine, tropicamide. Go ahead, please tell me what do you think is the correct one. Okay. All the questions is going to give you the mindset of the examiner. How an examiner think. You have to think it in the same way so that you can come up with the next potential MCQ ka topic. Now, dementia, that means they're actually talking about Alzheimer's disease. They're actually talking about Alzheimer's disease. Now, can you guys tell me, in a patient with Alzheimer's disease, there is degeneration of which neurotransmitter? Degeneration of acetylcholine in the locus ceruleus, nucleus ceruleus. All right, degeneration of the acetylcholine. Always do remember the treatment for this one is going to be reversible acetylcholine esterase inhibitor. Reversible acetylcholine esterase inhibitor that we use is going to be GRD. GRD stands for drugs like your galantamine. This reversible acetylcholine esterase inhibitor, they will increase the level of acetylcholine. This is going to be a tertiary amine that will cross the blood-brain barrier. Galantamine, rivastigmine, and donepezil. So what I have given here is the overall summary, donepezil being the drug of choice because of their longer T half-life, lesser side effect. This is the overall summary of Alzheimer's disease, reversible acetylcholine esterase inhibitor, why they are used. But examiner is asking that this is a case of a dementia. Now guys, in dementia, there is already going to be degeneration of the cholinergic neurons. In dementia, there is going to be degeneration of the cholinergic neuron. And the patient is presenting to you with the overactive bladder. For the overactive bladder, what have I told you? That overactive bladder we are going to utilize the drug that is known as your M3 antagonist. This M3 antagonist that is going to be agents like your solifenacine, oxybutynin, flavoxate, fesoterodine, tolterodine, trospium, and derifenacin. Derifenacin, that is highly vesicoselective, derifenacin. So these are the agents that we have for the management of overactive bladder. All of these are what, M3 antagonist. अब सोच के बताइए, M3 is an antagonist, M3 is a receptor for acetylcholine. If you block acetylcholine, what is going to happen? Acetylcholine is already going to be very low. There is too low acetylcholine, and if you block acetylcholine, there will be worsening of the problem of the Alzheimer's disease. There will be worsening of the problem of the dementia. These drugs that I have given above, that is going to be solifenacin, oxybutanin, tolterodine, and all these drug derifenacin, they also have the property to cross the blood-brain barrier, and they will further decrease the acetylcholine in the brain. So using these compound is not going to be very beneficial for you. But there is one compound by the name of trospium. This compound by the name of trospium, it is one of the quaternary amine. What is the meaning of quaternary amine? Who can tell me the meaning of quaternary amine? That this quaternary amine, they do not cross blood-brain barrier. They are water soluble. They do not cross blood-brain barrier, and therefore they are going to be safe in patient with the Alzheimer's disease. You check out the regular notes. I always mention this. That this is going to be asked at any point of time, always with a star. And luckily we got this one in 2024. Other options why they are incorrect, let us rule out. Because what is tropicamide? Tropicamide, it's also one of the M3 antagonist at the eye. They are going to cause mydriasis. M3 antagonists at the eye, they are going to cause mydriasis. Pyrenzapine, telenzapine, they are the M1 antagonist that is going to utilize in the peptic ulcer disease, although it is not marketed in our country. Pyrenzapine, telenzapine, peptic ulcer disease, we are going to use them in peptic ulcer disease. Tiotropium, ipratropium, tiotropium, they are also M3 antagonist that is utilized in COPD, bronchial asthma. So they are more sensitive for the bronchial smooth muscles. Bronchial asthma and COPD, ipratropium, tiotropium. As a matter of fact, tiotropium is a drug of choice for COPD, but you're not going to use these agents in the management of Alzheimer's disease related overactive bladder. So as a matter of fact, in this question, there is only going to be the quaternary amine that is present is called trospium. So that is going to be the correct one. Yes, those are the other, if you wanted to discuss Alzheimer's disease, those are the other drugs that is available. Monoclonal antibody against beta amyloid, monoclonal antibody against beta amyloid plaque. This monoclonal antibody against beta amyloid plaque is going to be aducanumab, Alzheimer's disease, and other one is called your lecanemab. Aducanumab and other one is called your lecanemab, that can also be utilized. In addition to that, NMDA blocker memantine can also be utilized. So overall, I have summarized the entire Alzheimer's disease itself. NMDA blocker like memantine can also be utilized in the management of Alzheimer's disease. So what all drugs that we have? We have drugs like galantamine, rivastigmine, donepezil. These two agents, aducanumab and lecanemab, they are monoclonal antibodies, so they are always going to be given by the injectable route. Currently, what we have is rivastigmine, donepezil. Rivastigmine and donepezil, currently we are having their transdermal patches also. Currently, we have their transdermal patch is also available. In dono ka transdermal patch is available. Earlier, the transdermal patch of only rivastigmine was available, but now rivastigmine or donepezil, dono ka transdermal patch is available. So to answer one of the question of the examiner that the patient is not tolerating oral drug, which agent will be utilized? So we can give the transdermal patch. We are going to give transdermal patch. Okay? A middle-aged female suffering from headache and blurring of vision while watching a movie. Look at this. Middle-aged female, headache, blurring of vision, watching a movie. Because in movie, there will be darkness. Sometimes there will be brightness. Mid-dilated fixed pupil. This is going to be always a feature of angle closure glaucoma. Angle closure glaucoma. In glaucoma management, there is a rule that you should know, that a mydriatic can always and always worsen the glaucoma. A mydriatic will always and always worsen the glaucoma. So it should always be avoided. Therefore, AD mydriatic should always and always be avoided. Now, mannitol can be utilized, but you will not be using atropine. There is no point of using antibiotic here or steroid here. Loteprednol, prednol, pred is steroid. So the only option that is left is going to be pilocarpine, right? So atropine is going to be a mydriatic. Pilocarpine being a M3 and M3 agonist, they will be causing meiosis. So meiosis can definitely be utilized, right? So correct answer for this one is going to be B. B is the correct answer for this one. Which of the following chelating agent is contraindicated in iron poisoning? In iron poisoning, which of the following chelating agent is contraindicated? British anti-lewisite, EDTA, DTPA, deferoxamine. Since for that I would request you to watch the rapid revision section, because अगर मैं पढ़ाने जाऊंगा तो फिर हम लोग का जो 100 क्वेश्चन से 120 क्वेश्चन है ना, that we will not be able to finish. We have already done 70 minutes and I am hardly on question number 12. So I have to make sure that we do this PYQ because the main aim to finish is PYQ. आप कोई भी पुराना हमारा सेशन उठा के देख लीजिए, उसमें you will be able to revise quickly the angle glaucoma and open angle glaucoma. ठीक है, वेरी गुड डॉक्टर पंकज. सो करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी बाल, है ना. तो आई ऑलवेज से दैट द ब्रिटिश एंटी लुइसाइड, राइट, दे आर गोइंग टू बी कॉन्ट्राइंडिकेटेड विद द कैडमियम, iron and selenium. Cadmium, iron, selenium. So remember, if you guys are planning to open a cafe and someone is getting bal matlab hair in their cafe, there is going to be a problem. So I always say कैफे से बाल को हटा दो, कैफे से बाल को हटा दो, राइट. कैफे से बाल, कैफे में बाल रहेगा, सो दिस इज नॉट गोइंग टू बी वेरी हेल्दी. कैफे से बाल को हटा दो, कैफे से बाल को हटा दो. ओके, सो दिस इज गोइंग टू बी द कॉन्ट्राइंडिकेटेड, दिस इज गोइंग टू बी द कॉन्ट्राइंडिकेटेड. कैफे से क्या हटाना है? बाल को हटाना है, कैफे से बाल को हटाना है. ऑलराइट. Now this British anti-lewisite, iske what are the uses, right? So I always say that learn pharma again in my style, that they are going to utilize in MRCOG, MRCOG, है ना. What is BAL का full form? British, and British Empire had launched this examination that is called MRCOG, member of Royal College of Obstetrics and Gynecologists, है ना. तो Britishers have given MRCOG and that is our mnemonic. The uses of BAL, ब्रिटिश का यूजेस, मर्करी, आर्सेनिक, MR, आर्सेनिक, कॉपर, गोल्ड एंड लेड विल बी PB. तो वो MRCOG इज ऑलवेज लीड्स, लीड्स इज लेड, लीड्स विल बी लेड, राइट, लीड्स विल बी लेड. तो since they have already asked what is contraindicated, in the next potential MCQ will be what, where it is used, right? So BAL, British anti-lewisite, we are going to use them in MRCOG. M mercury, R arsenic, C copper, O copper होगा, MRCO, G for gold, and leads will be lead, PB, lead will be there, right? चलिए. The loading dose of lidocaine for the treatment of arrhythmia depend on which of the following factors. So let me just tell you that lidocaine in which group of drug, and you guys will start giving the answer as soon as you see the question. Lidocaine is one of the class 1B antiarrhythmic drug. Class 1B antiarrhythmic drug that is going to be remembered by the very simple mnemonic that I'm so good that they all like to phone me. All like to phone me. I'm so brave, they all like to phone me. That is going to be lidocaine, lidocaine, tocainide, lidocaine, tocainide, phenytoin, and other one is called your maxilitine. Phenytoin and other one is called your maxilitine, that is called your like to phone me, like to phone me. All right. So when you give the loading dose of any drug, they are going to be dependent on which of the following factor: bioavailability, clearance, volume distribution, and half-life. All right. Do you guys know volume of distribution का formula is equal to D by C? D is equal to drug dose that is given divided by the plasma concentration. This D, that is drug dose that is given, is going to be the loading dose. Loading dose will be equal to volume distribution into the plasma concentration. Volume distribution into plasma concentration. So volume distribution will definitely decide. Maintenance dose is dependent on the clearance, yes, but volume distribution will be equal to D by C. D is equal to dose, drug dose that is given. C is equal to plasma concentration. Okay. Loading dose is going to be simply solved from the same formula of volume of distribution. Loading dose can be solved from the same formula of volume of distribution. All right. So this was a very easy PG question. A person was on if you want to revise that way, maintenance is equal to clearance into plasma concentration. Half-life is going to be T half is equal to 0.693, directly proportional to volume of distribution. Half-life, right? It is going to be directly proportional to volume distribution, and it is going to be inversely proportional to the clearance. Higher the clearance, lesser will be the T half-life. 0.693 is the log value of number 5, and clearance will be equal to rate of elimination divided by the plasma concentration. So that way you can revise all other formulas as well. Loading dose भी हो गया, volume distribution भी हो गया, clearance का formula भी हो गया, T half life का formula भी also sorted, ठीक है, and maintenance dose का formula is also sorted. Next question is about a person who was on antihypertensive drug, had symptoms like constipation, dry mouth and dizziness. He missed to take it while on a trip and has now presented with a high blood pressure. Which antihypertensive drug he was likely taking? Which antihypertensive drug he was likely taking? ठीक है? Which antihypertensive drug he was likely taking? ठीक है? If you are going to give by any other route, you will always divide by bioavailability, right? If you are going to give by other route, then volume of distribution, plasma concentration divided by F. F is equal to bioavailability. F is equal to bioavailability. So bioavailability will be taken into consideration if you are going to give by any other route. Right. So he is having dryness of mouth, constipation, dizziness, and he is presenting with a high blood pressure. So I think all of you guys are giving the correct answer. The correct answer is going to be yes. The correct answer is going to be clonidine withdrawal syndrome. Right. The correct answer is going to be clonidine withdrawal syndrome. Now, clonidine withdrawal syndrome is a very common side effect with the clonidine. Clonidine withdrawal syndrome is a very common side effect with the clonidine, and withdrawal syndrome will be mainly the opposite to the actual action of the drug. For example, the side effect is going to be dryness of mouth, and rebound hypertension is a very common, right? Other will be your constipation, low mood, nasal stuffiness, right? So these are going to be the important side effect of clonidine. Do remember that rebound hypertension plus the other side effects are also presenting here. Okay? The other side effect is also presenting here. If you're going to rule out other option like amlodipine, what kind of side effect is expected from amlodipine? It is one of the calcium channel blocker. They are going to be associated with something called your reflex tachycardia because they are DHPs, dihydropyridines. Apart from that, they can also lead to ankle edema and constipation. Ankle edema and constipation. Lisinopril being one of the ACE inhibitor, right? Lisinopril being one of the ACE inhibitor. तो ACE inhibitor के लिए minimum I say that remember at least 3 important side effect. ACE inhibitor का ACE, that is going to be angioedema, cough, which is going to be dry cough due to bradykinin, and E for elevated potassium. So there will be hyperkalemia also. Right? Hyperkalemia. Telmisartan will have all the side effects same like ACE inhibitor, but they will not be causing dry cough and angioedema. They can have other side effects like they can lead to elevated potassium. Hyperkalemia is one of the side effects. Hyperkalemia is going to be one of the side effects. They will not be causing angioedema and dry cough. Telmisartan के साथ angioedema and dry cough नहीं होगा. right? Telmisartan is one of the ARB, angiotensin receptor blocker. They block the AT1 receptor. They block the AT1 receptor. ACE inhibitor का side effect is ACE. All right. All right. So Dr. Clonidine is a simple way to remember the side effect of clonidine. Remember, clonidine is one of the alpha 2 agonists. Alpha 2 agonists, they are considered as a centrally acting sympatholytics. They are considered as centrally acting sympatholytics. So when you suddenly stop this, the BP will shoot. Lisinopril will have urticaria, angioedema. Angioedema. Clonidine is not effective in diarrhea, rather clonidine is the drug of choice in diabetic diarrhea. Drug of choice in diabetic diarrhea, not in diarrhea per se, but diabetic diarrhea mein they are the drug of choice because they are going to increase the sodium and water reabsorption from the intestine. Next question is going to be about a patient treated for hypertriglyceridemia, developed flushing, gout, hyperglycemia, and raised liver enzyme. Which of the following is the most likely cause? So look at this. You are treating a dyslipidemic patient, but now he is developing the flushing, gout, hyperglycemia, and raised liver enzyme. These are all worrisome side effects that is very commonly noted with which group of drug? Which group of drug will be causing this one? Atorvastatin, guys. Let me rule out other options because that is how we are going to solve the upcoming potential MCQ. HMG co-reductase inhibitor. Remember this HMG co-reductase inhibitor. Atorvastatin is one of the HMG CoA reductase inhibitor. They are associated with side effect that is called myopathy, hepatotoxicity, myopathy, hepatotoxicity. They are the important side effect. Fenofibrate, it's one of the PPAR alpha agonist, fenofibrate. They are going to be also associated with side effect like myopathy, and they will also increase the risk of gallstone. This will be causing hepatotoxicity and also causing hyperglycemia, right? Easy peasy drug, ezetimibe is the easy peasy drug that is one of the NPC1L1 inhibitor. They inhibit the cholesterol absorption from the intestine. Cholesterol absorption from intestine. Important side effect is going to be side effect like your steatoria. Steatoria. Important side effect is going to be constipation. Steatoria and constipation. Nicotinamide is the one that is going to be this important side effect. Every side effect that has been mentioned here is with the nicotinamide, niacin, vitamin B3, niacin, that is going to be same, right? These are all associated with something called your compliance limiting side effect. Now, what is the meaning of compliance limiting side effect? That because of this, the patient could not continue the drug. That is going to be flushing, pruritus, flushing, entire body will be flushed, pruritus, there will be generalized itching and dyspepsia. But these are not the only side effect. These are the compliance limiting side effect. Apart from this, the patient will also be having some dangerous side effect like hepatotoxicity, hyperglycemia, hyperuricemia. These are the other side effect, right? That is already mentioned here. So hepatotoxicity, hyperglycemia, hyperuricemia. Okay. Which of the following drug can cause QT prolongation when given with the erythromycin? I think each one of you can easily tell me. Erythromycin can cause QT prolongation? No. Erythromycin, remember thromycin alone, it is not. It is saying which drug will be causing QT prolongation if it is given with the erythromycin. Because erythromycin is one of the very potent enzyme inhibitor. Cetirizine is one of the second generation antihistaminic drug. Loratadine, desloratadine is also one of the antihistaminic drug. Fexofenadine is also one of the least sedative antihistaminic drug. All second generation, right? Yes. So the correct answer for this one is going to be estemizole. Remember, there were two drugs, estemizole and terfenadine. Estamazole and terfenadine, these are clinically not used. Estamazole, terfenadine, they are clinically not used because they are actually associated with a QT prolongation. This is a very old question. I remember this question once in 2017-18, somewhere examiner has asked this question, but in 2024 this recurred again. And so estamazole, terfenadine will be associated with the QT prolongation. That is why it is banned now. Currently, we are using isomer of terfenadine. The isomer of terfenadine is called your fexofenadine. So fexofenadine is an isomer of terfenadine only. They do not cause this QT prolongation as a side effect. Enzyme inhibitor, enzyme inducer, they will always be all-time favorite of the examiner. Inhibitor will inhibit and they will always increase the risk of toxicity. Increase the risk of toxicity. So I always say that if you are into a relationship, don't get induced easily. If you get induced easily, there will be problem. Don't get induced easily. If you are into a relationship, do not get induced easily. Inducer will cause lot of failure in life. Inducer will bring lot of failure in life. So don't get induced easily. And if you get too much inhibited, that will increase the risk of toxicity. If you get too much inhibited, that is going to increase the risk of toxicity. It will increase the risk of toxicity. All right, it is going to increase the risk of toxicity. Making sense? All right. Next is going to be which of the following is used to prevent alcohol withdrawal, right, seizure in an alcoholic patient. Alcohol withdrawal seizure को prevent करने के लिए, right, which of the following is going to be utilized? Prevent alcohol withdrawal seizure in an alcoholic patient. Lorazepam, fomepizole, disulfiram, naltrexone. So you have to know about other option as well. Fomepizole, form में पीता जा, form में पीता जा. Which type of drug is fomepizole? Who can tell me? Which type of drug is fomepizole? Which type of drug is lorazepam? Lorazepam is one of the benzodiazepine. It's one of the benzodiazepine. This is the one that will be correct one. But what is the other next potential MCQ? That fomepizole, it's one of the alcohol. It is one of the alcohol dehydrogenase inhibitor. Fomepizole is one of the alcohol dehydrogenase inhibitor. It is going to be utilized as an antidote for. It is going to be utilized for antidote for methanol poisoning, right, and ethylene glycol poisoning. Methanol poisoning and ethylene glycol poisoning. ठीक है. Disulfiram. Disulfiram is one of the aldehyde dehydrogenase inhibitor. They are mainly utilized for aversion therapy of alcohol. Please remember, aversion therapy of alcohol and decreasing the craving is not same. They are utilized for the aversion therapy of alcohol. Disulfiram. Naltrexone, it is one of the opioid receptor antagonists. Naltrexone is one of the opioid receptor antagonist. Naltrexone has multiple uses. Naltrexone is going to have multiple uses. What is the multiple uses? This is going to be utilized to prevent relapse, to prevent the relapse of opioid de-addiction. Opioid de-addiction के बाद से हम इसको ऐड करते हैं. They are also utilized to decrease the alcohol craving, and they are also utilized as anti-obesity drug. They are also utilized as anti-obesity drug. So there are multiple uses of this class of drug, this drug, right? Naltrexone is one of the orally effective and orally effective opioid, right? Lorazepam, fomepizole, disulfiram, naltrexone. Correct answer for this one is going to be lorazepam. So sometime they will also be giving ki alcoholic patient hai, so what else can we add? So we can always add vitamin B1. We can always add vitamin B1, thiamine, है ना? Longer acting benzodiazepine like chlordiazepoxide can also be utilized, but since it is not there, lorazepam is going to be the correct answer for this one. Okay. Which of the following statement about cyclisonide is incorrect? Which of the following is going to be incorrect about cyclisonide? Cyclisonide, guys, it's one of the steroid. What is incorrect? Oral candidiasis is common with its use. It has fewer side effects than other inhalational steroids. It is a prodrug activated by bronchial esterase. It has comparable efficacy to other inhalational corticosteroid. Comparable efficacy to other inhalational corticosteroid. So tell me, what do you think is the correct one? Cyclisonide. Cyclisonide is one of the inhalational steroid. It is one of the inhalational steroid. We are going to call them as a soft steroid. Because of the poor GI absorption, they are the soft steroid. They are the prodrug that is going to get activated by bronchial esterase. This is correct. Any soft steroid, the term that is given soft is because they are having fewer systemic side effects. This is also correct. You have to find out an incorrect statement. And their efficacy is almost similar to other inhalational steroids that is going to be mainly utilized in the treatment of bronchial asthma and COPD. Bronchial asthma and COPD. In one of the examination, examiner said that when you use inhalational steroid, there will always and always be, when you are going to use the inhalational steroid, there is going to be increased risk of, inhalational steroid is going to have increase in the risk of oral candidiasis. They are going to have increase in the risk of oral candidiasis. And to prevent this oral candidiasis, to prevent this one, what will you advise? What will you advise to prevent this one? To prevent this one, you have to advise that gargle after the each dose. Gargle after each dose of the steroid. Okay, gargle after each dose of the steroid. That is one of the advice that you will give. And for the treatment of this one, you can use clotrimazole. For the treatment of this one, you can use clotrimazole, or you can also use topical nystatin. Clotrimazole or topical nystatin, right? So to prevent the aphthous ulcer or oral candidiasis, you are going to avoid advice for the gargle. If there is development already, you are going to give clotrimazole or nystatin, right? So correct answer for this one is oral candidiasis is not common because these are soft steroid. The name soft steroid is given because they are having lesser local side effect and local systemic side effect also. ठीक है? Nystatin का topical पेंट के फॉर्म में आता है. Identify the type of inhibition. This question has been asked n number of times. I always say that, you see, do not worry about it. Just look like this, that if they are like competing on the y-axis, if they are crossing each other on the y-axis, they are going to be competitive. If they are crossing each other on the y-axis. However, some of them will also be, right, starting from a two different area, they will be starting and they will be proceeding. So they are going to be your uncompetitive. These are going to be your uncompetitive because you can simply add them from the back. अब इनको नीचे से add कर दीजिए, it will become U, that is going to be uncompetitive. This is going to be uncompetitive. Other one that I always say that if you want to quickly solve this kind of question, you simply have to see the graph and their patterns, right? If they are starting from one point and both of them, right? If you are going to see this one starting from one point, right? And other one, sorry, both of them are starting from one point. Okay. Right? And if you want to see them that one is competitive, other one become non-competitive, because all you have to do is simply draw an imaginary line. You are simply going to draw an imaginary line. So this will become your non-competitive, this will become uncompetitive, this will become competitive. So just try to see this Lean-Weaver-Burke plot. Usually this type of question has not been asked, I mean in the recent examination, but in 2024 they asked. इसके पहले वो लोग 21-22 में पूछे थे. 23 में again this type of question was not asked, and this type of question has also been asked in FMG and INICT as well. All right. So I hope all of you guys have got this one Lean-Weaver-Burke plot वाला question, and you will not be making any mistake. मैंने बताया था two swords are fighting with each other, so these are going to be competing with each other. X बन रहा है, then there is going to be U, uncompetitive, and this starting from one point, then you can simply draw an imaginary line to make it N, so that become your non-competitive. That is going to become your non-competitive. All right. Next, it is going to be which of the following is possible reason to add atropine with the diphenoxylate? Go ahead and start giving me the correct answer. Why are you adding atropine with the diphenoxylate? Remember a very important point. The diphenoxylate is one of the opioid. Diphenoxylate is the opioid that is working at the GIT. Diphenoxylate is one of the opioid that is working at the GIT. Start answering. Why should you add atropine? Atropine, it's a non-selective muscarinic antagonist. M1, M2, M3, non-selective muscarinic antagonist. To antagonize the analgesic effect of the diphenoxylate, to enhance the antidiarrheal effect of the this one, to prevent the abuse of the diphenoxylate, to reduce the risk. Tell me, all of you. Okay, other students also take part. Many students are sitting and they're not, replying to the question. They're simply sitting ideal. हाँ सर तो जवाब दे ही देंगे, है ना, हम आराम से सोते हैं यहाँ पे. Azaz, are you there? Azaz, start answering. And other students, start answering, please. Sindhu, since okay, other students are having different having different. Right? अर्जुन राजू, बिल्कुल काम ही रहना है. मैंने बोला 3 घंटे के लिए मुझे आपका 3 घंटे चाहिए, है ना. तुम मुझे 3 घंटे दो, कम से कम 10-12 नंबर मैं दूंगा. ठीक है. एट्रोपिन के साइड इफेक्ट की वजह से ओवर यूज नहीं कर सकते. बिल्कुल सही जवाब, राइट. तो करेक्ट आंसर टू एनहांस द एंटीडायरियल नोट टू प्रिवेंट द abuse of diphenoxylate. You see here, if you look at the diphenoxylate is an opioid. Diphenoxylate is an opioid. Opioid ka there will always be having high risk of abuse potential. Opioid ka abuse potential is always going to be very, very high. Abuse potential of opioid is always going to be very, very high. And that explains the fact that if you are going to add the atropine, remember atropine is an anticholinergic drug. With them, the side effect of atropine, the patient will start developing the dryness of mouth, other side effect of atropine. The side effect of atropine will limit the abuse. Other thing is that with atropine, which is an anticholinergic drug, the dose that is required for opioid will be lesser. The dose that will be required for opioid will be lesser. Opioid के लिए whatever dose that is required will be lesser. Imagine if the person require 1 milligram of opioid and you are going to give it along with the anticholinergic drug by the name of atropine, and you do not require now 1 milligram, so your work will be done, let's say, in 0.25 only, है ना. तो simple सा logic है कि if you are going to give atropine, how it is going to be beneficial, side effect, and also because of atropine, the dose that will be required will be less. ठीक है. A 25-year-old patient with a history of unprotected sexual intercourse presents to the clinic with complaints of purulent discharge, burning sensation during urination, and the purulent discharge from the penis from the past 5 days. Okay, so चलिए ठीक है. भाई की गर्लफ्रेंड से लड़ाई हो गई, है ना. वो चला गया घूमने बाहर, बोला नहीं अब तो मैं बदला लेके रहूंगा. He went to a place जहाँ पे वो अनप्रोटेक्टेड सेक्सुअल इंटरकोर्स में इंडल्ज हुआ. फिर बाद में रियलाइज हुआ, उप्स, झगड़ा तो छोटी बात थी, ये मैंने क्या ले लिया, है ना. झगड़े के चक्कर में मैंने ये तो बहुत सारी परेशानियां ले ली, तकलीफें ले ली. Now I am having this purulent discharge. Gram stain is revealing. Now this is the point that is always going to be given in the question, and it has been asked also in 2021. Same question, same line. That gram stain reveal intracellular diplococci, gram negative diplococci. So diplococci is going to be feature of what? Like the patient is otherwise healthy and has no known drug allergy. What is the most appropriate treatment for this patient? What is the diagnosis? Can you guys tell me? Can you guys give me the diagnosis? Sexual intercourse, gram negative diplococci. What's the diagnosis? Yes. So diagnosis is going to be Neisseria gonorrhea, है ना. नो गॉन रिया, है ना. तो रिया चली गई तो उसके बाद से आप कहीं और चले गए तो हो जाएगा ये, है ना. तो नो गॉन रिया, नो निसेरिया गोनोरिया, दैट इज ठीक है. द ड्रग ऑफ चॉइस फॉर निसेरिया गोनोरिया इज व्हाट इज द ड्रग ऑफ चॉइस? थर्ड जनरेशन सिफिलिस, दैट इज गोइंग टू बी सेफ्ट्रैक्सोन. Now, ceftriaxone is the injectable cephalosporin. If it is not there, the next best option is going to be cefixime 400 milligram orally will be giving. Okay. If ceftriaxone is not there, the other one, उसी के efficacy का है, that is cefixime. Why are we not giving benzathine penicillin? Please remember, benzathine penicillin, it is mainly going to be given for syphilis. Benzathine penicillin is given for the syphilis. Metronidazole 500 milligram thrice a day. Metronidazole MBBS वगैरह के लिए यूज करते हैं ना, MBBS, gram negative है ना. Doxycycline, we are having many other use of doxycycline है ना, like Lyme disease, ureaplasma erythritecum, cholera, Yersinia pestis, all the rare kind of infection we will be using, है ना. Scrub typhus, Rocky Mounted spotted fever. So that is how you rule out other options, so that you can be sure about it, that what could be the next potential MCQ in the examination. Moving forward to the next one. A pregnant female at 37-week gestation with a history of heart valve is currently taking warfarin. So she is in 37th week of gestation and she is already taking on warfarin. Okay. So I told you, according to American College of Cardiology, American Heart Association, in the 1 to 12 week period, you are going to give low molecular weight heparin. 13 to 35, you are going to give warfarin. And in 35 or 36, 37th week में or 36th or 37th week में, you will be shifting the patient again to low molecular weight heparin. Now she is already in 37th week. Although she is on the, she is having history of prosthetic heart valve, she comes for a routine antenatal checkup. What is the appropriate management advice? So we are going to switch the patient to low molecular weight heparin. Isn't that we have already covered a similar kind of question previously? Yes or no? Now, next potential MCQ, let me give you. You do not immediate do induction of labor or perform LSCS. There is no point of performing LSCS. There is no indication. And LSCS, like if there is pregnancy, that the baby, because of the poor cephalopelvic disproportion, and or if there is, let's say, any other complication where cesarean will be involved, it's not given in the question. And do not continue the same medication, because warfarin is more, stronger as compared to heparin. Next potential MCQ for this one, that if there is a patient with a prosthetic heart valve, what is the accepted PTINR? In a prosthetic heart valve, what is the accepted PTINR? See, किसी भी condition में accepted PTINR in patient on warfarin, that is the next potential MCQ. In patient on warfarin, the accepted PTINR is going to be 2 to 3. The only condition where it is a little more is going to be a mechanical heart valve. If there is going to be mechanical heart valve, in that case only, in mechanical heart valve, the acceptable range is 2.5 to 3.5. Acceptable range is 2.5 to 3.5. Okay? Rest all may 2 to 3. All right? Not 1.5. Now, as I remember, you have written less than 1.5. This is not on patient on warfarin. I have written here that your patient is on warfarin. You see, in a normal case, without the normal circumstance, normal case, or I would say patient planned for surgery, not on warfarin. Normal case, maybe any other patient not on warfarin, planned for surgery and require PTINR. So in that case scenario, what should be the PTINR? In that case scenario, the accepted PTINR will be less than 1.5. The range that has been given is 1.2 to 1.5, but I want you to remember, very simple, less than 1.5. Sorted hai, right? So do not mark 1.5 here, right? 1.5 is for you and me. Let's say we are willing to undergo some surgical procedure. We are not on warfarin, then the PTINR accepted will be less than 1.5. In which phase of clinical trial safe drug dosing is determined? I think this is also very easy peasy. Safe drug dosing. You guys be a little fast. The more faster you will be, the more faster I will be. Tell me, in which of the following safe drug dosing is going to be utilized? A, B, C, D. 1, 2, 3, 4. Safe drug dosing. Yeah, safety. सी सेफ ड्रग डोजिंग या सेफ्टी, गाइस सेफ्टी का डिटर्मिनेशन कहाँ पे होता है? First, when we start giving in the normal healthy volunteers, and safety is always going to be assessed in the phase 1. If the examiner would ask safe dosing range or safe therapeutic dosing range, then your answer would definitely be 2. Safety determination is always going to be in phase 1 clinical trial. They are also going to do the efficacy. Phase 2 is also for the efficacy. Efficacy will be first assessed in phase 2. Efficacy is going to be confirmed in phase 3. Phase 4 is going to be once the drug is launched in the market, we are going to call it as a post-marketing surveillance. Confirmed efficacy, no, Dr. Devajit, confirmed efficacy is always going to be phase 3. Okay? Not phase 2. Confirmed efficacy is going to be phase 3. All right. Usually what we do when we start doing the safety analysis in phase 1, we start the normal healthy volunteers. Phase 1 में normal healthy volunteers we take and we never give the therapeutic dose. We always start with a very low dose. Low dose we are always going to start. So let's say you are going to give a 5 milligram drug, then you will be increasing to 10 milligram, 20 milligram, 40 milligram, and the patient is saying, okay, absolutely fine, I'm not feeling anything else, right? And next is going to be 80 milligram. Let's say when you give 80 milligram to this patient, now at 80 milligram, he is complaining that I am feeling nausea and vomiting. I am having a feeling of nausea and vomiting. I am also feeling that there is a rash. Please remember, if at 80 milligram pe he is having some problem like nausea, vomiting, dizziness, all these symptoms. There can be many symptoms. I'm just writing few example. He's saying I'm having dizziness, nausea, and vomiting. 80 milligram. So his safer is going to be up to 40. Matlab up until 40 he is not complaining anything. 80 pe he is having a problem. So this is mainly the safe determination. Safe dosing is going to be mainly up to 40. So jab hum therapeutically when we give the drug, we will never move beyond 40. We will never move beyond 40. Okay, 40 ke beyond we do not give. Then we see ki therapeutically whether the patient is going to get adjusted in 5 to 10 or not, yeah, 10 to 20 or not, so that you can increase the dose as and when required. Sorted, eh? I hope all of you guys have got this one. Methotrexate is a chemotherapeutic agent used in the treatment of the breast cancer. There are many uses of methotrexate. Methotrexate is one of the dihydrofolate reductase inhibitor. Methotrexate is one of the drugs that is going to be utilized as a drug of choice in rheumatoid arthritis. It's also the drug of choice that is going to be utilized in psoriatic arthritis, right? Psoriatic arthritis. Methotrexate, rheumatoid arthritis, psoriatic arthritis, choriocarcinoma, right? Choriocarcinoma. Methotrexate is a chemotherapeutic agent. They are in all these conditions. They are the drug of choice for inducing, ectopic pregnancy. Ectopic pregnancy, maybe also we can utilize them, right? Plus they have many other uses. In osteosarcoma also they are going to be utilized the preferred drug. So it is inhibiting the synthesis of the which nucleotide? Which nucleotide will be inhibited? Other students, please. Mohammad Yasser, Arafat, Sindhu Sins, Sangeeta. AMP, adenosine, CMP, cytosine, UMP, uridine, TMP, thymidine. Thymidylate synthase. Methotrexate, remember, they also have an activity that they inhibit the thymidylate synthase enzyme also. They also inhibit the enzyme thymidylate synthase, right? Thymidylate synthase inhibitor. So that is the main mechanism of action is this. dihydrofolate reductase inhibitor, plus these are also going to be thymidylate synthase. So TMP, that is going to be the correct one. TMP, that is going to be the correct one. Examiner asked in one of the examination that what will be added. So remember, along with the methotrexate, you are supposed to add leucovorin, also given the name as a folinic acid, also given the name as a folinic acid, right? Folinic acid is also one of them, right? Yes, AICAR is also there. AICAR, that is also there. AICAR, transformylase is also one of the proposed mechanism. That is the enzyme which is known as aminoimidazole 4-carboxamide, aminoimidazole 4-carboxamide imidazole, 4-carboxamide ribonucleotide, right? Ribonucleotide transformylase. So that is also one of the proposed mechanism of this drug. All right. Now moving on to the next one, a patient with the HIV who is currently on antiretroviral therapy consisting of zidovudine, lamivudine, nevirapine. Zidovudine, it is one of the NRTI, nucleoside reverse transcriptase inhibitor. Lamivudine, also one of the NRTI. Nevirapine, it is one of the NNRTI, non-nucleoside reverse transcriptase inhibitor, is diagnosed with the tuberculosis. Considering the potential drug interaction, which of the following TB drugs should be changed in this patient? Which drug are you going to plan to change? I think it's very, very simple question. And a similar question was also asked in your 2022-2023 also, right? Very good. So you are going to change rifampicin to a more beautiful drug, that is going to be rifabutine. Remember, rifampicin is one of the very, very potent enzyme inducer. It's a very, very potent enzyme inducer. और अभी मैंने क्या बताया था कि do not get induced easily. If you get induced easily, they will always have increase in the risk of treatment failure. So what kind of treatment failure will it cause? Antiretroviral therapy treatment failure can be seen. Then in one of the previous examination they asked, then they said that you are going to start, right, patient on antiretroviral therapy, जिसको हम बोलते हैं TLD. What is TLD stand for? TLD stand for tenofovir, lamivudine, other one is called dolutegravir. So examiner asks that, okay, these are the antiretroviral therapy is taking TLD, tenofovir, lamivudine, dolutegravir. What are these? Remember, tenofovir is one of the nucleotide reverse transcriptase inhibitor. Lamivudine, NRTI. This information that I am writing in itself is a form of MCQ. Tenofovir क्या है? Nucleotide, T for tenofovir. Dolutegravir, it is one of the integrase inhibitor. So examiner asks that patient on ART and was started on ATT, anti-tuberculosis therapy. What kind of dose adjustment will you do? What kind of dose adjustment will you do? Yes, very good, right? So do remember dolutegravir, it is going to be a substrate of, dolutegravir happens to be the substrate of, it's a substrate of CYP3A4. Others are not the substrate. Others are not the substrate of CYP3A4, but only this one is substrate of CYP3A4. Therefore, with the enzyme inducer HRZE, may HRZE, rifampicin being an enzyme inducer, they will always increase the risk of dolutegravir metabolism, and therefore dolutegravir को double कर देंगे. So you are going to give double the dose, 50 milligram in the morning, 50 milligram in the evening. So we have to double the dose of dolutegravir. DTG is a simple term for dolutegravir, right? So this is also one of the form of question of TB and HIV that has been asked. And in one of the FMG examination, what they ask, FMG rather INICT or FMG, when they ask this question, that TB with HIV. So all form of question, let me just quickly summarize. TB with HIV diagnosed together. Remember, you are supposed to start ART 2 weeks after ATT. That means do not start antiretroviral therapy together or prior to TB therapy, mainly to prevent a syndrome that is called your iris syndrome, mainly to prevent the iris, the syndrome that is called your iris syndrome. Now what is iris syndrome? Iris syndrome क्या होता है? What is iris immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome. So to prevent iris syndrome, first what will you do? You are going to start TB, anti-tubercular therapy, and after that you'll be giving it for 2 weeks, and after that you add ART, एंटीरेट्रोवायल थेरेपी, है ना, 2 हफ्ते के बाद, मिनिमम 2 वीक्स के बाद, मिनिमम 2 वीक्स के लिए यूल बी गिविंग, ठीक है. बिकॉज इफ यू गिव योर immunosuppressant drug like antiretroviral therapy, there will be syndrome that is called immune reconstitution. This was also asked in 2024 only. Okay, so 3 different type of question has been asked on the same topic. I have summarized it for all of you. Moving on to the next one. Which of the following is commonly used for maintenance therapy in opioid abuse? See, opioid abuse with maintenance therapy. I told you, a similar kind of question I have already given you. So the drug that will be utilized as a buprenorphine, because buprenorphine is the partial agonist at the mu opioid receptor. Most of the student will be marking naloxone, I'm pretty sure, but no, naloxone will not be an answer, because Sangeeta Reddy, listen to me, naloxone, it is the opioid receptor antagonist. This opioid receptor antagonist, it is going to be utilized as an antidote for, it will be utilized as an antidote for opioids overdose. We do not use naloxone here. We are going to give partial agonist, because in presence of a full agonist and a partial agonist, if a person will take a partial agonist buprenorphine, and after that if he consumes the main opioid, remember, he will not be having wo wala maza. He will not be having full euphoria, because the receptor is occupied. So in presence of a full agonist, a partial agonist is going to act as the antagonist, right? Clonidine will be not utilized here. Clonidine has no role. It's alpha-2 agonist. They have many use in hypertension, and opioid withdrawal syndrome we can utilize, and can be used in opioid withdrawal syndrome. But not as a maintenance therapy. Opioid withdrawal syndrome. ठीक है. हाँ, नैलोक्सोन वाया आईवी रूट से हम इसको देंगे रैपिड एक्शन के लिए. नेक्स्ट वन, कैफीन इज वाइडली यूज्ड स्टिमुलेंट दैट प्रमोट्स वेकफुलनेस. Which of the following mechanism is responsible for this action? Caffeine maintaining wakefulness, increasing discharge of norepinephrine from locus ceruleus. No, वहां पे तो acetylcholine होता है. Release of histamine, that is promoting wakefulness. See, histamine does promote wakefulness. Histamine, undoubtedly, it promotes wakefulness, but does it get increased by caffeine? Inhibition of phosphodiesterase? No. The answer for this one, other students are still not marking, other students are still waiting. The correct answer for this one is adenosine antagonism. Adenosine A1 antagonism. Please remember this adenosine A1 antagonism. Adenosine in the brain, they will be causing sedation. Adenosine in the CNS, they are going to be associated with the sedation, and when you block it, there will be, right, promote wakefulness. Adenosine in the renal area, there is going to be adenosine A1 antagonist. Adenosine A1 antagonism. And because of this adenosine A1 antagonism, there will be increase in the renal blood flow. See, excess renal blood flow, that will increase the risk of, or that will increase the diuresis. तो कभी भी जब बहुत सारा आप जब कॉफी पीते हो ना, तो you need to pee a lot. So caffeine can also induce diuresis, possibly because of the same mechanism. Same goes for the other agent like theophylline, that is also causing diuresis. The mechanism remains the same, that is going to be adenosine A1 antagonism. Okay? They have no action on urine, phosphodiesterase or norepinephrine. All right. मिथाइल xanthine के ग्रुप का ही है. मिथाइल xanthine में we have caffeine also, है ना, we have theophylline also. Yes, so if you're going to look at the methyl xanthine group of drug, undoubtedly these are phosphodiesterase inhibitor. But that phosphodiesterase inhibition is not the reason for diuresis. Phosphodiesterase inhibition is not the reason for the diuresis. Are you guys following me? They are not the reason for diuresis. A 65-year-old patient presenting with the bone pain, anemia, hypercalcemia. Look at the classical clinical presentation. Anemia, hypercalcemia, plus there is a renal impairment. A bone marrow biopsy confirms the diagnosis of multiple myeloma. So see, even without reading the first two lines, if you are going to see the diagnosis has been given already, the patient is started on a treatment regimen. Which of the following treatment is most likely associated with the reactivation of herpes zoster? All of you, please tell me. जल्दी से जवाब आप लोग नहीं दे रहे हैं. बोर्टेजोमिब, लीनालिडोमाइड, दाराटुमुमैब, मेल्फलान. Lenalidomide, pomalidomide, bortezomib. Let me tell you, all these drugs that is given in the option are actually used in the multiple myeloma. ये सब multiple myeloma में यूज कर सकते हैं. बट क्वेश्चन क्या है कि मल्टीपल माइलोमा में, है ना, मल्टीपल माइलोमा में विच वन विल बी कॉजिंग रीएक्टिवेशन? सी, मल्टीपल माइलोमा का द ड्रग ऑफ चॉइस इज गोइंग टू बी बोर्टेजोमिब, which is one of the proteasome inhibitor. Bortezomib is one of the proteasome inhibitor. It is one of the proteasome inhibitor, bortezomib, है ना? That is mainly involved in the plasma cell division. Proteasome inhibitor, bortezomib. Other agents are going to be carfilzomib, ixazomib. So I always say that remember them like a zombie. Zombie wali drug. And zombies always eat your head, your brain that is full of protein. Zombie never come alone. They are always going to come in multiple number. So they are used as a drug of choice in patients with multiple myeloma. The problem with this proteasome inhibitor is that they have been associated with the reactivation of, because of the immunosuppression property, they will be causing reactivation of herpes zoster. So we already know this one. So to prevent this kind of problem, 1 degree sign is for the prevention. To prevent this kind of problem, we always add your drug like your acyclovir, right? 400 milligram once daily. Usually for therapeutic purpose, we give thrice daily or 5 times daily, right? But here we are going to give once daily. That is added already to prevent this one. Let us rule out other option as well. Lenalidomide, pomalidomide, they are from the family of thalidomide. Can it be used in the multiple myeloma? Yes. Daratumumab, and there is one more drug by the name of Ix, right? Not Ixa, daratumumab, isatuximab. Because Dara and Isha, इन दोनों की लव स्टोरी बहुत फेमस है. दारा सिंह वॉज अ वेरी फेमस रेसलर. सो आई से अ स्टोरी, बनाया हुआ स्टोरी मान लीजिए कि दारा सिंह फेल इन लव विद ईशा एंड दिस हैपेंड व्हेन दे वर वेरी यंग. तो एट विच एज दे फेल इन लव? एट द एज ऑफ 38. दारा एंड ईशा fell in love with the NT at the age of 38, and when they fell in love they got married, and after that they starting breaking bone of each other. Yeah, they are enemies, है ना? तो दारा and ईशा, दारा टुमुमैब, ईशा टुक्शिमैब. ईशा, what is the difference between the both? No difference. Both of them are anti-CD38. The only difference is that Isha has an X factor. Isha tuximab, it's a chimeric monoclonal antibody. This is a fully human monoclonal antibody. This is a chimeric monoclonal antibody, XI, and this is a fully human monoclonal antibody, right? So they both can be utilized in the treatment of multiple myeloma. Remember that. Melphalan is one of the alkylating agent. They can also be utilized in the alkylating agent that can also be utilized in the multiple myeloma. Earlier we were using melphalan only as a first line drug, but now also we are using, but the drug of choice now has been changed to bortezomib. Zombie protein खाता है, proteasome inhibitor. Zombie come always in multiple number. If you have watched any zombie वाला movie, है ना, you know already. ठीक है? But we try to understand it, है ना? We try to make it much simpler, as simple as we can. ठीक है? Zombie. SNRI used in the treatment of ADHD, attention deficit hyperactivity disorder. Now, as soon as this question was asked, attention deficit hyperactivity disorder, most of the students, they jump directly to the answer. Now, let's see in this class how many of you are jumping to that one. Please go ahead and tell me the correct answer. Okay, you guys are marking D, then other people also, please take part immediately. Maximum that it can go will be wrong. No one is going to judge you. And see, as soon as you see the question, you are getting a tendency to mark methylphenidate, because undoubtedly methylphenidate is one of the derivative of, you know, your drug that is called amphetamine. It's the drug of choice for ADHD, attention deficit hyperactivity disorder. But examiner is not asking what is the drug of choice for ADHD. Examiner is asking which is a SNRI used in the treatment of ADHD. SNRI is going to be your atomoxetine, serotonin noradrenaline reuptake inhibitor. Atomoxetine is an SNRI, serotonin noradrenaline reuptake inhibitor. Okay. Modafinil is a CNS stimulant that is going to be utilized as a drug of choice in the treatment of narcolepsy. ये मेरा बनाया हुआ क्वेश्चन नहीं है, दिस इज 2024 का क्वेश्चन है ना. गोयाफेनिसिन, that is guanafacine. This is guaifenesin. Guaifenesin is one of the cough remedy. It's one of the anti-cough medication. ठीक है. Correct answer for this one is atomoxetine. Now this was also one of the very peculiar question which was many students made wrong, many students corrected it also. 18-year-old boy from Rajasthan weighing 50 kilogram is diagnosed with the mixed Vivax and falciparum malaria. Mixed kind of malaria, say he was diagnosed. Which of the following is the appropriate treatment on day 2? What do you think is the appropriate treatment on day 2? Who can tell me the correct answer for this one? Anyone can tell me the correct answer for this one? Who can tell me the correct answer for a question like this? Mixed kind of malaria. So mixed malaria is something that I have taught n number of times. Artesunate 4 tablets, Primaquine 2.5 milligram 6 tablet, 50 milligram 4 tablet. तो ये typical as it is आया हुआ था. So you have to just be very very careful. According to this regimen, you are going to give on day 2. Artesunate, Primaquine, artesunate, sulfadoxine, artesunate, sulfadoxine, pyrimethamine plus Primaquine. Okay, so I think I'm getting a lot of different answer by Chandan, Sangeeta Reddy, Apurva, Shabaz, Sahabaz Begum, and let me just quickly summarize this one. All of you guys, just sit back, relax, and listen to me for the next 2 to 3 minutes. Malaria, जैसे TB मैंने summarize किया था, malaria I'm going to summarize for all of you guys. Malaria, if you're going to look at this, you will be getting a case of malaria that is Plasmodium vivax and oval. I'll be writing uninterrupted for the next 2 minutes without any interruption. Please go ahead and write it down if you want to. Vivax and oval malaria may, for any patient, we are going to give chloroquine. Chloroquine will be given initially, plus we are going to give Primaquine 15 milligram on the daily basis for a total duration of 2 weeks. At any point of time, if it doesn't work, then we are going to shift the patient, and our non-responsive may, we are going to shift the patient to artemisinin combination therapy. What is artemisinin combination therapy? I will discuss subsequently. Remember, if the patient is coming with the Plasmodium falciparum, which is the most common type of malaria, in that case scenario, you have to ask the history from where the patient is coming. If the patient is coming from the northeast state, or if the patient is coming from the rest part of the country. If the patient is coming from northeast state, then in that case scenario, the treatment will be artemether lumefantrine, artemether plus lumefantrine. Right? I always say, remember the mnemonic NEAL, that north is say artemether lumefantrine. Rest part mein you are going to give ASP, artesunate sulfadoxine pyrimethamine. Artesunate plus a combination of sulfadoxine, pyrimethamine. Artesunate, sulfadoxine and pyrimethamine. Right. Now in this case scenario, on day 2 with both of them, this artesunate will be given. On day 2 also, we are going to give Primaquine 45 milligram single dose on day 2, single dose on day 2. ठीक है, this sulfadoxine pyrimethamine will also be given as a single dose on day 2. However, if the patient is coming to you with the mixed kind of malaria, mixed malaria का मतलब क्या हुआ, the patient is having vivax oval, vivax or oval, plus the patient is also having falciparum, that is banana shaped gamete is also there, and a vivax and oval ka gamete is also there. Then in that case scenario, you will be using same artemisinin combination therapy depending on from where the patient is coming. North is it say artemether-lumefantrine, rest part say ASP, rest part say ASP, artesunate sulfadoxine pyrimethamine. Plus the primaquine that you are going to use here is going to be 15 milligram on the daily basis for a total duration of 2 weeks. So the only thing that is changed is going to be your 2 week के लिए primaquine. So on the day 2 also will be using, right? Any drug that I have given here, chloroquine, like for example, I am going to give 600 milligram, then I'll be giving 300 milligram, right? 300 after 8 hours. This will be given for a duration of 3 days. Here also it will be given for a duration of 3 days. This will be given for a duration of 3 days, right? This is also going to be duration for 3 days. Okay. Sometime the patient will also be coming to you with something called your cerebral malaria. That is also one of the questions that is going to be asked. Cerebral malaria. Cerebral malaria mein we are going to give IV artesunate. IV artesunate. IV artesunate will be given for a duration of 3 days. For a duration of 48 hours. And if the patient gains consciousness after that, you can shift the patient once again to artemisinin combination therapy. Same like above. Another question that is asked, what will be given if there is going to be malaria in pregnancy? If there is a malaria in pregnancy, find out which type of malaria the examiner is asking about. Is the examiner asking malaria in pregnancy for Plasmodium vivax or oval? Then we are going to give our patient something called your chloroquine, but at any point of time, we will never be giving primaquine in pregnancy. If it is non-responsive, chloroquine कैसे देते हैं? We give 600 followed by 300. So 300 ka into 3 day we will be giving, and after that we are going to continue 300 per week. This will be continued throughout the pregnancy. 300 per week. This will be continued throughout the pregnancy. Primaquine will not be given. However, if it is going to be Plasmodium falciparum, you have to give the therapy according to trimester. First trimester mein we are going to give quinine. However, if the condition is severe, we can always and always add clindamycin. So quinine and clindamycin is always going to be the combination in the pregnancy. But if the patient is coming second, third trimester, if the patient is coming second and third trimester mein, then second, third trimester mein we are going to give same artemisinin combination therapy. But please remember, in any trimester, if the patient is coming, primaquine is always going to be contraindicated during the pregnancy. Primaquine is always going to be, right, contraindicated during pregnancy, because chloroquine is one of the drugs that is having high volume of distribution, no? So this is always known as loading dose. First dose is always going to be 600 milligram. Loading dose 600 milligram followed by 300 milligram. Okay? Loading dose. First dose is always going to be loading dose, right? So let me quickly summarize. Vivax oval mein we are going to give chloroquine. Non-responsive case mein artemisinin combination therapy. Same like I have given here on the right hand side here. Falciparum में नॉर्थ स्टेट में NEAL artemether-lumefantrine, rest part में artesunate sulfadoxine pyrimethamine. So what you know here that we'll be using artesunate sulfadoxine pyrimethamine, and here the examiner is asking on the day 2. So what you know that on the day 2, do we need artesunate? Yes. Do we need sulfadoxine? Yes. Do we need pyrimethamine? Yes. Do we also require primaquine? Yes. Right now, according to the guidelines that I have also given in the notes also, if you look at this, artesunate sulfadoxine pyrimethamine that is mentioned here, look at this, artesunate 100 milligram twice daily, mg per kg के हिसाब से 4 mg per kg. As I told you, 3 days के लिए will be giving. Sulfadoxine we are going to give 1500 milligram, 25 mg per kg, and pyrimethamine 75 mg per kg. 1.25 mg per kg, 75 milligram will be giving as a single dose. So this will be given on day 2. So are we going to give artesunate? Yes. Now see, artesunate, if you are going to give in this case scenario, artesunate 50 milligram ka 4 tablet. So how many will that be? 50 milligram ka 4 tablet. How many will that be? 200 milligram, right? Artesunate we have to give 100 mg twice daily. तो twice daily मतलब 100 milligram सुबह हो गया, 100 milligram शाम को हो गया, right? Second day को देंगे. Sulfadoxine we are going to give 1500 milligram and pyrimethamine 75 milligram. 1500 and 75 milligram. So look at this. If you have to give 2 tablets of 750, तो 750 into 750 2 tablet हो जाएगा 1500 प्लस 75 तो 37.5 37.5 2 टैबलेट, ये भी हो गए 2 टैबलेट्स हो गए. एंड प्राइमाक्विन वी आर गोइंग टू गिव 2.5 मिलीग्राम का 6 टैबलेट. तो 2.5 का 6 टैबलेट रफली अराउंड 2.5 का 6 टैबलेट. तो ऑन द डे 2 दिस इज हाउ मच विल दैट बी? 50 milligram का 4 टैबलेट, दिस 2 टैबलेट. इफ यू कैलकुलेट दिस वन 7.5 into 6 tablet, that will be coming roughly around 45. But if you are going to calculate 2.5 into 6 tablet, that will be coming roughly around 15. तो हमें वाइवैक्स मलेरिया को ट्रीट करना है, फैल्सिपैरम को ट्रीट करना है. दैट मीन्स मिक्स्ड काइंड ऑफ मलेरिया है. एंड मिक्स काइंड ऑफ मलेरिया के लिए वी हैव टू गिव फॉर 15 डेज. कितने दिन के लिए देना है? फॉर मिक्स्ड काइंड ऑफ मलेरिया we have to not give single dose. हमें कैसे यूज करना है? for 15 days 15 milligram. तो we have to give 6 tablet. तो 2.5 into 6 will be 15 milligram. This will be continued. So on the day 2 we have to use this one. ठीक है, तो you have to remember this one. This has been a little tricky one. Many of the students have thought that okay, mixed hai, so let us understand and let us mark this one. But do remember that if you just do a little bit of left and right, this question will be high chances that it will go wrong. Like in today's class also, if you see, many of you have made mistake. As I said that I'll be taking 2-3 minutes and quickly I have summarized all the different type of malaria, malaria in pregnancy, cerebral malaria, everything I have summarized here for all of you guys. चलिए, which of the following growth hormone analog is used in the treatment of HIV associated lipodystrophy? Start answering this already. As soon as you see this question, start answering this please. HIV induced lipodystrophy में which of the following will be utilized? Tesamorelin, bromocriptine, micasermine, octreotide. Which of the following do you think will be utilized? I think the examiner is saying growth hormone analog, tesamorelin, bromocriptine. Bromocriptine, guys, is a D2 agonist, and we know for sure that dopamine has inhibitory action at the prolactin. Dopamine also has inhibitory action at the growth hormone. So this bromocriptine as a drug, it can be utilized for hyperprolactinemia, right? Hyperprolactinemia. We can also utilize them for acromegaly. Bromocriptine, because it's a D2 agonist, dopamine agonist. Remember, this dopamine agonist can also be utilized in a condition that is called type 2 diabetes mellitus. It's one of the FDA approved drug because they have shown to increase the insulin sensitivity. Micasermine is what? What is micasermine? Anyone can tell me micasermine kya hai? What is micasermine? Octreotide is one of the somatostatin analog. I'm waiting on the micasermine. Somatostatin analog ka other name is called your growth hormone inhibitory hormone. Somatostatin analog, octreotide. So we can utilize them as a preferred drug in patient with the acromegaly, gigantism. Plus we can also utilize them in the secretory diarrhea, VIPoma, carcinoid syndrome, because they are going to reduce the secretion. So carcinoid syndrome maybe also we can utilize. Can you guys tell me what is micasermine? Who can tell me? Micasermine. Recombinant insulin-like growth factor. Yes, insulin-like growth factor 1. So it will be utilized. It's insulin-like growth factor 1. Right? So where do we use micasermine? Where do we use micasermine? If it is insulin-like growth factor 1, so they are like growth hormone के जैसे काम करने वाले, and they are going to be utilized for the treatment of what? Where do we use them? Micasermine. If there is growth hormone receptor resistant in growth hormone deficient patients, growth hormone deficiency case में if growth hormone receptor is resistant, then you cannot use growth hormone directly. You cannot give growth hormone. Like a condition, let's say dwarfism. Dwarfism is one of the conditions where there is decrease in the growth hormone, right? Dwarfism. Stunted growth may, if the growth hormone receptor is going to be, growth hormone receptor is actually going to be resistant, then we will not be using growth hormone, because growth hormone receptors are resistant. Then we are going to use recombinant insulin like growth factor 1, that is your micasermine. Tesamorelin is the one that is the correct answer for this one, that is growth hormone releasing hormone, GHRH, growth hormone releasing hormone. They can be utilized in wherever we want the growth, including HIV induced lipodystrophy. We also we can utilize them. We can also utilize them in HIV induced lipodystrophy. Okay. So other options also I have ruled out here for all of you guys. A patient on MAO inhibitor was started on sertraline, developed symptoms like headache, tremor, diarrhea, agitation. What is the treatment for this possible toxicity? So see, if there is a patient on MAO inhibitor and was started on sertraline, you see he is already on MAO inhibitor. Sertraline is which group of drug? Selagelene, rasagiline is a MAO inhibitor. Citalopram, fluoxetine, paroxetine, sertraline, that is one of the SSRI. MAO inhibitor will itself inhibit the level of monoamine oxidase like serotonin. So MAO inhibitor has increase in the level of serotonin property, and SSRI will also increase the level of serotonin property. Ultimately, this will be a case of serotonin syndrome, because SSRI will be always having increased side effect risk, that is called serotonin syndrome, where the patient will have nausea, vomiting, diarrhea, BP fluctuation, headache, agitation, anxiety. Let me tell you, a similar kind of question, exactly similar kind of question was also asked in one of the INICT examination. Exactly similar kind of question was also asked in around 2022 INICT examination. That a husband has brought, not INICT, sorry, FMG examination. A husband has brought his wife and he said that she is having symptoms like headache, agitation, anxiety, which was not before. The symptom started ever since she was started on one of the drug. Which drug was possibly added to add on this symptom? So depressed patient was started on a drug having this symptom, right? So that is going to be serotonin syndrome, and serotonin syndrome ka drug of choice is going to be cyproheptadine, that is one of the serotonin antagonists and antihistaminic drug. Flumazenil, this is going to be antidote. Flumazenil, it is going to be benzodiazepine toxicity में यूज करेंगे, naloxone opioid toxicity में यूज करेंगे, and leucovorin is usually added with any of the dihydrofolate reductase inhibitor, example like methotrexate, right? Methotrexate, proguanil, pyrimethamine, इन सबके साथ we can always add proguanil, pyrimethamine. They are also the dihydrofolate reductase inhibitor if we are also going to add along with them. Okay, so this is going to be the correct answer for this one. Now, this was a little tricky question. When administering magnesium sulfate for eclampsia, which of the following would you not monitor? Now, according to me, I believe this is a wrong recall. I do not consider this as a right recall, because I look at many research paper, many textbook, including gynae books also. And in fact, the gynae book is still on my table right now also, the Datta textbook. And examiner is asking, while administering magnesium sulfate for eclampsia, which of the following would you not monitor? Urine output, deep tendon reflex, serum magnesium level, blood pressure. I believe this is a wrong recall. If you guys can help me out, what do you think is the correct answer and why that is the correct answer? Serum magnesium level. मैग्नीशियम लेवल यार वो मॉनिटर करेंगे. मैग्नीशियम इज नैरो थेरापेटिक में आता है वो भी, समवेयर अराउंड 1.5 to 3, राइट. तो मैग्नीशियम का लेवल तो हम डेफिनेटली मेजर करेंगे, मिलियोस्मॉल पर लीटर. ठीक है. मेंटेनेंस डोज के लिए क्या के लिए मॉनिटर करते हैं यूरिन आउटपुट? यस. सो एक्लेम्शिया, in this case scenario, if the patient is in emergency, everything will be monitored, including urine output. If the patient is admitted, you'll be also monitoring deep tendon reflexes and serum magnesium level also. OPD based, अगर patient admitted है तो we should always also keep an eye on the respiratory rate and blood pressure also. इसीलिए मैंने पहले ही बोला this is going to be नहीं यार, magnesium it does affect the blood pressure, no, it does affect the blood pressure. Magnesium, it inhibit the calcium influx, no, so it can cause fall in the blood pressure also. ठीक है. प्रिवेंशन ऑफ सीजर वो सही है. मैग्नीशियम को भी ऑल्सो यूज इन सर्टेन एरिथमिया कंडीशन, है ना, लाइक टोर्साइडस डिपॉइंटस. हैव यू नॉट रेड दैट? In Torsades de Pointes, we use also magnesium. So see, why have I written here wrong recall? Because almost all these in the option that is given here is going to be monitored. But if you are asking me, sir, one possible answer क्या होगा? देखिए, ऊपर वाला 1, 2, 3 तो डेफिनेटली करते हैं. बट जब पेशेंट हमेशा अपने घर पे रहेगा, एक्लेम्शिया का पेशेंट है, अगर मान लीजिए आप उसको मेंटेनेंस थेरापी भी दे रहे हो, तो बीपी विल बी द लेस कॉमन दैट आई शुड से. तो यहाँ पे मैं बोलूंगा नन. अगर वो नहीं है तो यू कैन गो अहेड विद द डी. प्लीज डू रिमेंबर, यूरिन आउटपुट इज वेरी वेरी इंपॉर्टेंट, डीप टेंडन रिफ्लेक्स ऑल्सो वेरी इंपॉर्टेंट, सीरम मैग्नीशियम लेवल इज ऑल्सो वेरी इंपॉर्टेंट. बाकी आई एम श्योर ऑल ऑफ यू गाइस आर ऑलरेडी अवेयर कि इसका लोडिंग डोज 14 होता है, मेंटेनेंस डोज 5 होता है, 2.5 ईच बटक्स पे होता है. दैट यू हैव रेड इन योर फेवरेट सब्जेक्ट गायनेकोलॉजी. आप अपने फेवरेट सब्जेक्ट से तो कोई भी गलती नहीं करोगे, आई एम प्रीटी श्योर. ठीक है. Which of the following drug is used in the treatment of irritable bowel syndrome and has a direct spasmolytic action on the GI smooth muscle? Irritable bowel syndrome and has a spasmolytic. अभी तक हम लोग पहले ईयर का ही डिस्कस कर रहे थे. I was thinking by 7:30 I'll be able to finish the 2024 question, but I have not. But I'm sure that जो मैंने 3 से 4 घंटे का आपका टाइम लिया है उसमें मैं खत्म कर दूंगा. Yes. Scopolamine, mebeverine, resicadotril. No. The correct answer is not resicadotril, Dr. Sins. है ना? Right. Resicadotril. Who can tell me the mechanism of action of resicadotril? Who can tell me the mechanism of action of resicadotril? जितना पढ़ाया है अभी उससे थोड़ा और ज़्यादा रह गया है. Who can tell me resicadotril? But rest assured, you are here for revision only. No, don't look at the time. Time को हटा दो, watch को निकाल के थोड़ा side कर दो. Don't look at the time. Look at the amount of information that you are gaining here in the class. Don't look at the time. Let's revise because examination both of them is going to be very near. और examination में time देके question नहीं आता है, concept पे question आता है, तो उसको हम clear करेंगे. ठीक है. Yes, very good. Resicadotril is one of the encapsulinase inhibitor. So this is also a potential MCQ in the upcoming examination. Encapsulinase inhibitor, because we know for sure that encapsuline is having encapsuline. अगर आप देखोगे encapsuline, it is one of the encapsulines. It is one of the endogenous opioid, and any opioid wherever they work, they are going to decrease the secretion, GI secretion, and they will also decrease the GI motility. So this is going to be very good work. But the problem with the encapsuline is that this encapsuline is going to get metabolized with the help of enzyme encapsulinase. The name of the enzyme that is causing metabolism is called your encapsulinase. And our drug that is going to act by inhibiting this encapsulinase is none other than your resicadotril. So resicadotril will be inhibiting this one. This is the resicadotril that is going to inhibit this one. So encapsulin level will increase, leading to decrease in GI secretion, GI motility. So they are very commonly very effective drug in the treatment of secretory diarrhea. In fact, आज के time पे almost all the GI people, GI surgeon, all the clinical practitioners, they are using resicardotil in patients with the diarrhea, secretory diarrhea. They are also going to be very much safe in the pediatric population as well. So pediatric maybe also they are coming in the form of Respule also, they are coming in the form of sachet also, tablet के form में भी आता है, capsule के form में भी आता है, तो they are given in multiple forms. ठीक है. So directly spasmolytic action on GI smooth muscle, that is going to be a dicyclomine. Dicyclomine is the correct answer for this question. Remember that dicyclomine is the correct answer for this question. Dicyclomine. All right. So this is the one that is having spasmolytic action. That is one of the M3 antagonist. They are one of the M3 antagonists. Dicyclomine. एंजाइम न्यूट्रल एंडोपेप्टिडेज वो थोड़ा अलग था, वो भी उसके नाम में भी ट्रिल था, दैट इज कार्डोट्रिल सैक्यूबिट्रिल, दैट वाज अ डिफरेंट एंजाइम, है ना, दैट वाज यूज्ड इन हार्ट फेलियर. सैक्यूबिट्रिल कार्डोट्रिल दैट वाज यूज्ड इन हार्ट फेलियर. दे वर NEP inhibitor, neutral endopeptidase inhibitor. This is encaphelinase. All right. A 30-year-old patient, drug addict, coming to the emergency department with signs of unknown drug poison. The patient exhibit dilated pupil. Look at this. I have already taught you the poisoning. Now you will be able to use the previous information. So आने वाले question will be able to solve very quickly. Dilated pupil, sweating, tachycardia, and tremor. On examination, the blood pressure is 160/100. Heart rate is 120. What is the most likely diagnosis? Cocaine, morphine, cannabis, alcohol. I just taught you this. 5-6 different poisoning I taught you, right? Pupils are increased. Drug addict increased pupil size. That is going to be cocaine, tachycardia, increasing the blood pressure. Have I already taught you this? All others also have been taught to all of you guys, right? So only now I was able to finish your 36-37 question of 2024, but we have done a wide coverage. General pharma, ANS, CNS, CVS, lot of coverage has been done. Now we are going to start 2023, and believe me, 2023 will be much easier. Why? Because lot of repeat question you will see now in 2023. Let me know, are you all ready for 2023? तो 2023 मोस्टली मैं 40 मिनट के भीतर कर दूंगा. आई एम श्योर अबाउट इट, है ना. प्रॉमिस तो नहीं कर सकता, बिकॉज वादा तो टूट जाता है, और मेरे से अक्सर टूट जाता है ना. चलिए, इसीलिए मेरे सारे फ्रेंड्स, है ना, हर तरह के फ्रेंड्स, और वो हर लोग थोड़ा ज़्यादा नाराज रहते हैं, क्योंकि वादा हमसे जल्दी टूट जाता है. हम थोड़ा ओवर एंथुजियास्टिक हो जाते हैं, नहीं मैं तो कर दूंगा, है ना. तो वादे होते हैं टूटने के लिए. चलिए, आर यू ऑल रेडी? कैन वी स्टार्ट? यस. तो जैसे कि मैंने बोला था कि आपको एटलीस्ट 3 से 4 घंटे के लिए ग्लूटियस को मजबूती के साथ रखना है. स्टार्ट करेंगे. 50-year-old पेशेंट साइकोटिक सिम्टम के साथ आता है. ही हैज बीन नो इम्प्रूवमेंट ऑन हेलोपेरिडोल एंड थायरोडाजिन. हेलोपेरिडोल, थायरोडाजिन, दे आर द D2 ब्लॉकर, दैट इज कंसिडर्ड द टिपिकल एंटीसाइकोटिक्स. टिपिकल एंटीसाइकोटिक्स के साथ ही वाज गिवन. द न्यू ड्रग इज इंक्रीजिंग सैलिवेशन, हाइपरलिपिडीमिया एंड सेडेशन. What is the drug that he was shifted to? Mebeverine का answer is mechanism of action is not well understood, but they have shown to decrease the calcium influx into the smooth muscle, and they will relax the smooth muscle rather than having spasmolytic property. Spasmolytic property is mainly M3 antagonist. This is for Nico. Okay, the correct answer for this one is going to be clozapine. मैं बोलता हूँ ना कि दोस्त बोलता है क्लोज आप पीने चले, clozapine. So do remember, clozapine is one of the drug that is having maximum risk of your metabolic syndrome. That is there. In addition to that, they will also be having other problem, that is going to be agranulocytosis. See, अगर आप फ्रेंड की बात में आ गए और फ्रेंड ने बोला क्लोज आप पीने चलें, तो agranulocytosis आपके सारे काउंट्स को खत्म कर देगा, इंक्लूडिंग बैंक अकाउंट. एवरीथिंग विल बी लॉस्ट. agranulocytosis, Then there will be sialorrhea. Your friend says close आप पीने चलें, आप तुरंत ड्रूल करने लगे saliva. Sialorrhea is so high that when the person sleeps in the night, the pillow will be wet, and there we are going to call it as a wet pillow syndrome. Then they are also going to cause sedation, and they are also going to cause seizure. They have also been associated with the myocarditis. See, too much drinking से आपको myocarditis भी हो सकता है. तो दोस्त की बात में नहीं आना है, खासकर ऐसा दोस्त जो बोलता है क्लोज आप पीने चलें, right? Now it is my always prime responsibility to quickly summarize other options as well. For example, risperidone. मेरी तरह से पढ़ो, कभी नहीं बोलूंगा. risperidone, it is also the atypical antipsychotics. Clozapine is also one of the atypical antipsychotics. It's also one of the atypical D2 block, atypical antipsychotics. Atypical antipsychotics. This is also an atypical antipsychotics, but this is considered the most potent atypical antipsychotics. तो I always say that इसके साथ रिस्क है, इसके साथ रिस्क है, और जहां रिस्क है वहां इश्क है. ये भी मैंने बताया आपको, जहां रिस्क है वहां इश्क है. तो दिस इज गोइंग टू बी द वेरी कॉमनली यूटिलाइज्ड आल्सो इफ यू हैव टू यूज इट इन एक्यूट सिनेरियो. इट इज द मोस्ट इंपॉर्टेंट वन, राइट? एंड बिकॉज इट इज वेरी रिस्की वन, it is atypical, yes, but this is also among atypical, it is also maximally associated with extrapyramidal symptom. Please remember this, extrapyramidal symptom is mainly a side effect of typical, but among atypical, मैंने जानबूझ के यहाँ पे वर्ड लिख दिया among atypical, ऐसा नहीं कि सब में. Extrapyramidal symptom like dystonia, akathisia is a side effect of typical, but atypical में if there is very risky and it can cause typical वाला side effect, that is going to be risperidone. Then we have aripiprazole, ziprasidone का spelling correct कर लीजिए. Aripiprazole, ziprasidone, remember aripiprazole, ziprasidone, they are associated with the less weight gain. All the atypical can cause weight gain. Aripiprazole, ziprasidone, less weight gain. They always say, let's see, क्लोजापिन तो वेट गेन कराते हैं, ओलांजापिन वेट गेन कराते हैं, क्यूटियापिन वेट गेन कराते हैं. दे आर ऑल कॉजिंग वेट गेन. बट लुक एट दिस, अरे शिप्रा को देखा क्या? अरे किसको देखा? अरे शिप्रा को देखा, वो तो बड़ी स्लिम है, उसका तो वेट बढ़ ही नहीं रहा है. शिप्रा इज स्लिम. अरे शिप्रा को देखो, है ना. एरिपिप्राजोल, जिप्रासिडोन, दे आर गोइंग टू बी वेरी वेरी लेस वेट गेन. एरिपिप्राजोल, जिप्रासिडोन, right? Because of their partial D2 agonistic property, they also have less extrapyramidal symptom. Always do remember that extrapyramidal symptom, hyperprolactinemia, is always going to be the important side effect associated with the side effect of the typical antipsychotics like haloperidol, droperidol, thiazidine and all. Okay, next question. Hypertensive patient, multi-drug therapy for hypertension, presented with the chest pain and shown ECG. We are discussing 2023. Each of this question I am telling you is from directly taken from the students' feedback. This is not from any random places that you will be seeing this question directly. और ये उस समय भी I have done the same kind of discussion. Now also I am doing. This is a 2023. ठीक है? Which drug might have precipitated this condition? So what do you see here? That QRS तो ठीक था, but look at all the T waves. All the T waves are on the higher side. That is going to be tall T waves. And do remember, tall T wave is always and always going to be associated with the hyperkalemia. Out of the given one, which one can cause hyperkalemia? Spironolactone can always cause hyperkalemia. Spironolactone is one of the potassium sparing diuretic. It can cause hyperkalemia. Apart from that, remember all the RAS system inhibitor. Listen to me carefully. Are you all listening to me? All the RAS system inhibitor, like for example, ACE inhibitor, ARBs, all the RAS system inhibitor, ACE inhibitor, ARB, renin inhibitor, and your potassium sparing diuretic, all of them, they are all associated with hyperkalemia. These are all associated with hyperkalemia. So never combine them together. Never, or I would say, do not combine them together. So examiner will ask the question, which two drugs are not given together, right? do not combine them together. So you are not going to give ACE inhibitor ARB or ACE inhibitor with the spironolactone. You should not be giving them because they are going to cause lots and lots of hyperkalemia. They are going to cause lots and lots of hyperkalemia. Are we all good here? Are you all with me? Yes. Amlodipine, I have told you already, calcium channel blocker. It's one of the DHPs. I have already told you their important side effect. क्या मैंने नहीं बताया था आपको side effect? In one of the question previously, I have already taught you. That's why I said that most of the information I have already given you previously in 2024, so that these are going to be much easier. Like they will be causing ankle edema, reflex tachycardia, constipation. Hydrochlorothiazide, thiazide diuretics, they will be causing hypokalemia. है ना, hypokalemia, hypomagnesemia. Metoprolol is a beta blocker, cardioselective beta blocker. They will decrease the heart rate, increase the risk of heart block, है ना. So these are the important side effects. The correct answer for this one is going to be spironolactone. Moving on to the next one. Now this was a very atypical question, unexpected question from 2023 NEET PG. Which of the following drug inhibit the area marked by 1 and 2? So there is a drug that is inhibiting an enzyme called neutral endopeptidase, and it is also inhibiting the enzyme called ACE. Similar kind of information I have already taught you. See, mindset of examiner ko, are you guys following me or not here? Mindset of the examiner was asked about ARNI. याद है पिछले क्लास में मैंने पढ़ाया था, पिछले एग्जाम पिछले ईयर वाले पेपर में, where I told you that there is a drug that is inhibiting neutral endopeptidase inhibitor, and the drug is also inhibiting ARB. The drug is also inhibiting ARB. So which drug is having inhibiting property for both of them? That is a different one. So since it's inhibiting ARB and neutral endopeptidase inhibitor, we are going to call them ARNI. क्योंकि मैंने आपको ARNI पढ़ा रखा है 2023 में, see, you can easily mark. This is going to be ARB. कौन सा होगा? That is going to be valsartan, and this is going to be sacubitril. But here it is not asking ARB, it is asking ACE inhibitor. The name of the drug is going to be vasopeptidase inhibitor. The class of the drug is vasopeptidase inhibitor. The name of the drug is going to be omapatrilat, sam patrilat, facidotrilat. ठीक है? They are going to be the ACE inhibitor. So see, their name has trill of neutral endopeptidase and prill of ACE inhibitor. Prill together. Trill together. Prill and trill are coming together in this one. Prill and trill are coming together in this one, and we call them vasopeptidase inhibitor. ऊपर वाले को we say ARNI. Now this drug is clinically not used. They are clinically not used because they have not approved. They are not approved. Why? Because they still have the side effect of ACE inhibitor, that is dry cough and angioedema. So they are not approved. But still, examiner has asked this question. Correct answer for this one, I think each one of you have got this one. That is going to be omapatrilat. Right? What is nasiritide? Next potential MCQ. Have I not taught you this already in the previous 2024? Nasiritide nasha. नशा आता है, nasiritide नशा आता है ब्रेन से. So this is going to be BNP analog, brain derived natriuretic peptide analog. It can also be utilized in a patient with a congestive heart failure. We can also utilize them in patient with a congestive heart failure. Nasiritide, that will be causing natriuresis and vasodilation. Sacubitril, which type of drug is sacubitril? That is going to be neutral endopeptidase inhibitor. Yeah, neprilis inhibitor. Losartan is one of the ARB. Correct answer for this one is D, and I have already given you the definite reason and I have ruled out other options as well. Next one. A patient on chemotherapy presented with thrombocytopenia. Which of the following will be given? See, 2024 में क्या आया? 2023 में ये आया, 2024 में similar kind of question, delayed nausea and vomiting. Now there is thrombocytopenia. So in this case scenario, what is the answer for this one, guys? Thrombocytopenia में darbepoetin, filgrastim, oprelvecin, sergramostim. This is going to be granulocyte, monocyte stimulant. This is granulocyte, monocyte, colony stimulating factor. Filgrastim, granulocyte. So this is going to be granulocyte, colony stimulating factor. So they are going to utilize in the neutropenia. Why? To prevent the systemic infection. They do not have any anti-cancer property. Rather, we are going to give them to prevent the systemic infection. Darbepoetin, epoetin for the treatment of anemia. They are the erythropoietin analog. They are the agent that is utilized for the treatment of anemia due to CKD, chronic kidney disease, or end-stage renal disease, or chemotherapy. बचा क्या? Oprelvecin, that is going to be interleukin 11 agonist. Interleukin 11 agonist, that is utilized for the thrombopoiesis, right? So that is going to be utilized. Then in 2021, this is 2023 actually, they asked which tyrosine kinase inhibitor is used. Which tyrosine kinase inhibitor is used for idiopathic thrombocytopenic purpura? Now the first option was oprelvecin. Student immediately marked oprelvecin. Remember, oprelvecin can be used in thrombocytopenia, yes, but they are not the tyrosine kinase inhibitor. So the answer to that question become fostamatinib. वो question भी आएगा, fostamatinib. Fostamatinib. So you have to be careful while reading the question because your examiner knows what the student do not know. Examiner को पता है बच्चे को क्या नहीं पता है. ठीक है, चलिए quickly let's revise once again. The drug of choice for chemotherapy induced nausea and vomiting. I have told you already. Ondansetron 5-3 antagonist. Delayed nausea and vomiting, that is going to be NK1 antagonist. Neurokinin 1 या substance P antagonist, that is going to be aprepitant, rolapitant, netopitant. Anemia के लिए we are going to use epoetin, darbepoetin, filgrastim, granulocyte stimulant, oprelvecin, or we can also utilize other agents like that is called your romiplastim. Romiplastim, that is going to be platelet का stimulant, या PEG वाला L-thrombopeg, that is going to be thrombopoietin agonist. So they are the oral one. बाकी ये दोनों जो है इंजेक्टेबल है. L-thrombopeg, ava-thrombopeg, lushu-thrombopeg, they are going to be the oral one. PEG वाले, PEG कैसे बनता है? चाय वाला जो PEG बनता है ना, कैसे बनता है? ओरल बनता है ना, चाय वाला PEG है ना. चलिए, तो ESRD मतलब end stage renal disease. The meaning of ESRD is end stage renal disease. So sorted है. This is the question that has been asked, and everything that I have discussed around this question will be the potential MCQ for all of you guys. A child went on to play and consumed some fruit. See, I have already taught you this as well. So टॉपिक अब आपको समझ में आ गया एक्चुअली में कि वाई डूइंग PYQ is important. Tell me, have I not taught you this? Symptom like this will be presenting confusion, body temperature is high, urine retention, that is all going to be anticholinergic. Fruit का intake है. So what is the correct answer? Right? Please go ahead. Immediately you see the question and immediately start marking. Select the correct option in case of poisoning and the antidote. Datura, 5-stigmine, organophosphate will never have increase in the body temperature. Atropine can have body temperature, but atropine is not going to be treated with the neostigmine. Antidote नहीं है उसका. Carbamate atropine, no. The correct answer is going to be datura poisoning. Have I not taught you this? Yes, we have covered this already. No need to spend time on this anymore. A patient was on dialysis presented with vomiting. See, dialysis patient presenting with the vomiting, tremor, muscle cramps, and visual disturbances. What is the drug used in the management? After dialysis, if you are having all these CNS symptoms, we are going to call this condition as a dialysis disequilibrium syndrome. What are we going to cause? What are we going to call it as a dialysis disequilibrium syndrome? Drug used in the management are going to be mannitol, nasiritide, ethacrinic acid, bumetanide. Ethacrinic acid, loop diuretic, highly ototoxic, clinically not used. Bumetanide, indacrinol. Nasiritide, I told you already, BNP analog. BNP analog, this drug that I have given here, it is going to be utilized in which condition, guys? BNP analog, ये कौन से condition में use करेंगे बताइए? That is going to be utilized in a patient with the BNP analog, congestive heart failure. Bumetanide is also one of the drugs that is going to be utilized in the congestive heart failure. It's also going to be utilized in, it's also one of the diuretic utilized in the congestive heart failure, right? So congestive heart failure we also we are going to utilize a loop diuretic. So correct answer for this one is going to be a faster acting diuretic, that is going to be mannitol. Mannitol happens to be the drug of choice in a patient with the dialysis disequilibrium syndrome, DDS. Mannitol का दो important use हमेशा ध्यान रखिएगा. One is acute angle closure glaucoma. Tell me, was this question not asked in your 2024 that you were using mannitol plus pilocarpine? That is why I say that what is important is the previous year question, previous year topic. So mannitol, was it asked in 2023? Yes. Then they asked this question, right? So the topic almost is going to be somewhat same. Mannitol ka different uses, mannitol ka different site of action. The next potential MCQ, site of action. So the site of action for this one is going to be your PCT, loop of Henle, iske baad se all other site maybe it will be working. Dialysis disequilibrium syndrome. Let us understand what is the meaning of dialysis disequilibrium syndrome, guys. Disequilibrium से नाम में ही समझ में आ रहा है ना, there is going to be some equilibrium imbalance. When you are going to do rapid dialysis or first timer dialysis, rapid dialysis and first timer dialysis, they will always have high risk of DDS, dialysis disequilibrium syndrome. You are going to cause rapid removal of the urea or the small molecule. आपने क्या किया? There will be rapid removal of the small molecule from the circulation, because dialysis में you are doing the dialysis from the circulation. ब्लड का डायलिसिस कर रहे हैं. सो व्हाट विल हैपन टू द लेवल ऑफ दिस कंपाउंड इन द ब्लड, इन द पेरिफेरल ब्लड, दिस कंपाउंड विल बी लेसर. व्हेन द कंपाउंड इज लेसर इन द पेरिफेरल ब्लड, नाउ व्हाट विल हैपन, compared to these, brain mein there is high concentration, and because of that now there is going to be movement of the water towards the brain, towards the CNS. There will be movement of the water, and that will lead to cerebral edema, and that can lead to CNS symptom. The patient will present to you with the CNS symptom. I repeat, when you do the rapid dialysis, there will be decrease in the ions like your urea or other small molecules. So concentration will be lesser in the blood. So blood will be more diluted as compared to the brain. Brain will be having more high concentration, so more water will be moving towards the brain, leading to CNS symptoms. So we are going to call this one as the dialysis disequilibrium syndrome, right? So do remember this one: acute angle closure glaucoma, dialysis disequilibrium syndrome, and your increase in the intracranial pressure, maybe due to ischemic stroke or cerebral edema. So these are the three important conditions that I want you to remember always. Three important conditions, rather than two, I will say three for this mannitol. So since they have already asked these two, cerebral edema will be the next potential. Because mannitol is very, very important, potential MCQ. Mannitol is going to be contraindicated in which scenario? It is going to be contraindicated in which scenario? It will be not given in a patient with the hemorrhagic एक्टिव सेरेब्रल ब्लीड. हेमोरेजिक या एक्टिव सेरेब्रल ब्लीड में कभी नहीं देंगे. इन अ पेशेंट विद एक्टिव सेरेब्रल ब्लीड वी आर नॉट गोइंग टू गिव हेमोरेजिक और एक्टिव सेरेब्रल ब्लीड में. वी आर ऑल्सो नॉट गोइंग टू गिव देम इन द पेशेंट with the congestive heart failure. In a patient with the congestive heart failure, we are not going to give. And in pulmonary edema, already there is too much fluid. If we give them, they can worsen the edema as well. So do remember this: active cerebral bleed, congestive heart failure, pulmonary edema, we are not going to give. In congestive heart failure, the intravascular volume is already very high. Heart के ऊपर बहुत load आ रहा है, too much load आ रहा है. If you give a diuretic, that is further going to increase the intravascular volume. It is going to be a problematic for the patient, right? So do remember this. These are going to be the important contraindication. Please do not miss this out. Next potential MCQ for all of you guys, putting a star over this one. और क्या हो सकता है, सबसे ज़्यादा चांसेस किसके हो सकते हैं? तो कंजेस्टिव हार्ट फेलियर का हिस्ट्री रहेगा. विच ड्रग इज कॉन्ट्राइंडिकेटेड, ये उसका सवाल रहेगा. ठीक है. Hyperthyroid and asthmatic patient not taking any asthmatic medication, presented with anxiety, restlessness, and blood pressure of 180 over 110, pulse rate of 120 per minute, and ECG is suggestive of atrial fibrillation. What is the treatment that is going to be preferred? All of you guys, please tell me the correct answer. Esmolol, propylthiouracil, propranolol, diltiazem. The preferred treatment for this one. Hyperthyroid asthmatic patient. See, asthmatic patient है तो propranolol तो rule out हो गया, because propranolol is going to be non-selective beta blocker. That is going to be propranolol. This non-selective beta blocker will always be contraindicated in patient with the bronchial asthma. It will be contraindicated in patient with bronchial asthma. It will also be contraindicated in peripheral vascular disease like Raynaud's, and it is also going to be contraindicated in diabetic mellitus. So तीन condition में BPD are going to be always three important contraindication of these three. Propranolol. तो प्रोप्रानोलॉल तो होगा ही ना, मैंने प्रोप्रानोलॉल को रूल आउट कर दिया, आई हैव तो रूल आउट प्रोप्रानोलॉल, तो दैट कैन नॉट बी द आंसर। सी तो रूल आउट हो गया ना, बिकॉज सी इज एन एस्थमेटिक पेशेंट, एस्थमा में प्रोप्रानोलॉल कैन नॉट बी गिवन। But in other patient, propranolol can be given because propranolol is one of the beta blocker. It is one of the non-selective beta blocker, but plus it also inhibit peripheral T4 to T3. So one of the students, those who asked the question how you can use, I think this is the reason. Okay. Guys, what is the diagnosis of this case? What is the diagnosis of this case? The diagnosis of this case, hyperthyroid hai, and all the symptom is coming with the thyroid storm. All the patient is coming mainly with the thyroid storm, and in the patient with the thyroid storm, the preferred answer is going to be propylthiouracil. It's the drug of choice in a patient with the thyroid storm. It's the drug of choice in a patient with the thyroid storm. In addition to that, for cardiac symptom, we can always and always add. It will be added with propylthiouracil for the cardiac symptom. For the cardiac symptom, we'll be adding this one, but we will not be giving propranolol. Do remember this one. I hope it is making sense to all of you guys that propylthiouracil is going to be the drug of choice in this case scenario. This is the 2023. Moving on to the next one. A patient was on digoxin therapy, developed a toxicity, and the level was 4. Okay. The level that was found to be was 4 nanogram per ml. How much time will it take to reach the therapeutic plasma concentration? When the therapeutic plasma concentration is 1, okay. So what is the therapeutic plasma concentration? Therapeutic plasma concentration is 1. So 1 nanogram per ml. This is थोड़ा सा correction कर लीजिएगा. This is hours. ये सारा का सारा जो unit है ना, all the units are in hour. All the units are in hour, not minute, no, because digoxin का half life होता है 40 घंटे. So this is not going to be in minutes. I'm doing a little bit of correction, please do that. But any number, if you know the basic concept, it is going to be solved very easily. If you know the basic concept, you will be able to solve this very easily. This is all going to be into hours, है? So this is going to be hours, 80 hours, 40 hours, 160 hours, and 120 hours. Go ahead, please. Okay, Gautam. Definitely, it is going to help you out. चलिए, तो 4 है and 1 is the therapeutic. This is the therapeutic one. And half life is what? What is the T half life? That is going to be 40 hours. Now this is correct also. T half life 40 hours. The question is they are always asking. In fact, they also asked the question in recent examination 2024 also. In INI also there was a question like this. Okay. That means every 40 hour it will become half. So this 4 will become 2 in the 40 hour, and 2 will become 1 in the next 40 hour. Now can you tell me that 140 hour yahan pe, 140 hour yahan pe, so there will be 2 half life that will be required. So what is the correct answer? That is going to be 80 hours. Excellent, Dr. Sins. है ना? Correct answer is going to be 80. Asthma patient with management therapy presented with a whitish oral thrush and buccal mucosa. Okay, I have already told you this. I have taught you this already, and I have told you that when you give inhalational steroid, there will be high risk of oral thrush, and we are going to use either nystatin or clotrimazole. Tell me, have I not taught you this already? Have I not taught you this already? Clotrimazole. 5-flucytosine 5-FC is one of the DNA and RNA inhibitor. That is the next potential MCQ for all of you guys. DNA and RNA inhibitor. They are always and always added with the, mind it, always and always added with the amphotericin B in the treatment of cryptococcal meningitis. In the treatment of cryptococcal meningitis. Grisufulvine is one of the mitotic spindle inhibitor. They can be utilized in many conditions, but not for the buccal mucosa. Terbinafine is one of the squalene epoxidase inhibitor. Squalene epoxidase inhibitor. Terbinafine is one of the squalene epoxidase inhibitor. They are the drug of choice in the treatment of dermatophytosis. Not only that, remember, they are also the drug of choice for onychomycosis, because onychomycosis is also one of the dermatophytosis. Fungal infection of the nail, fungal infection of the skin hair, sabhi ke liye squalene epoxidase inhibitor terbinafine can be utilized, right? So correct answer for this one is going to be clotrimazole. Alternative to this is going to be nystatin. Tell me, have I not taught you this already? Yes, I have taught this. A patient presented to emergency after consuming 100 tablet of aspirin. Management of this case, aspirin. बताइए 100 tablet. As soon as you see the question, please immediately go with the answer. 100 tablets of aspirin, and then what do you think is the correct answer for this one? Management for this case is going to be soda bicarbonate. Okay, please go and take soda bicarbonate to alkalinize urine, N-acetylcysteine to replenish the liver glutathione, post-gastric diuresis using ammonium chloride, chelator like D-penicillamine. फास्ट जैसे ही क्वेश्चन देखिए लाइन लगा दीजिए आप आंसर का, है ना, आग लगा दीजिए आप लोग, आग लगा दीजिए. Yes. So if it is going to be an acidic drug, there is going to be acidic drug poisoning, and in the acidic drug poisoning, you have to use post alkaline diuresis. For the treatment of this, you are going to use post alkaline diuresis. Post alkaline diuresis will be done using simple drug है soda bicarbonate. आप यूज कर लीजिए soda bicarbonate, or you can also use carbonic anhydrase inhibitor, or you can use carbonic anhydrase inhibitor, carbonic anhydrase inhibitor. So soda bicarbonate to alkalinize the urine we are going to utilize. You see, N-acetylcysteine to replenish the glutathione store. This is mainly utilized for paracetamol poisoning. In one of the 2024, they asked, how is N-acetylcysteine working? N-acetylcysteine is going to replenish the glutathione store. Remember that. Chelator like D-penicillamine, it is mainly utilized for copper. It is mainly utilized for copper. All right. Sorted hai? Now, because they have already asked acidic drug poisoning, alternative to CA inhibitor is going to be acetazolamide. That is one of the carbonic anhydrase inhibitor. Acetazolamide is one of the carbonic anhydrase inhibitor. It is one of the carbonic anhydrase inhibitor. Remember that. Okay? If the examiner is going to ask you basic drug poisoning, basic drug like your atropine, atropine का एंटीडोट अवेलेबल है, अगर एंटीडोट नहीं रहे, राइट, दैट इज गोइंग टू बी योर स्ट्राइचिनिन, स्ट्राइचिनिन है ना, एम्फेटामिन, strychnine, amphetamine, these are all going to be the basic drug. They are all going to be the basic drug poisoning. And in the basic drug poisoning, what else we can utilize? We are going to utilize forced acidic diuresis. We are going to utilize forced acidic diuresis using what? Using ammonium chloride, or we can also utilize simple ascorbic acid का injection. Simple ascorbic acid का injection, right? Vitamin C, simple ascorbic acid का injection. ठीक है? Just allow me a minute, please. I'll be back. Just allow me a minute. Hi guys, sorry for the short interruption. Let's get started. Sure. So this type of question has been asked, and other option I have also ruled out for all of you guys. Moving on to the next question. Acute gout patient on anti-gout medication, which act by decreasing the uric acid level by decreasing the production of uric acid, right? Decreasing the uric acid level by decreasing the production. Now, gout has been all-time favorite topic also for the examiner. So, gout se question has been asked 2020 में, 2021, 2022, 2023. In every year they have asked the question. Okay? What will decrease the level of uric acid by decreasing the production? I think it's very simple. Decreasing the production ke liye we also know xanthine oxidase inhibitor. So the only one that is going to be xanthine oxidase inhibitor is going to be allopurinol. Other one is going to be febuxostat. Diclofenac sodium, it is not utilized, it is not decreasing the uric acid level. They are going to be the NSAID. It can be utilized in acute condition. Probenecid, can it decrease the uric acid level? Of course, it can decrease the uric acid level, but that is by increasing the uric acid ka excretion. And any drug that increases the uric acid excretion, we are going to call them uricosuric. What are we going to call them? Uricosuric. Guys, what type of drug is colchicine? Colchicine is a drug that is utilized in the acute gout. They are acting by inhibiting chemotaxis. They have no action on the uric acid level. They have no action on the level of uric acid. They do not increase or decrease the uric acid level. Let me quickly summarize the gout for all of you guys so that we can cover all the potential MCQ of gout in the upcoming examination. If the patient is coming to you in a case of acute gout scenario, first and foremost, you will be giving NSAID. All the NSAID can be utilized except the aspirin. Aspirin is an NSAID that will not be utilized. Aspirin is an NSAID that is not going to utilize. Remember that. Aspirin हम कभी नहीं use करेंगे. Next is going to, if it is non-responsive, then we are going to utilize colchicine. Next is going to be your colchicine. Steroid. If it is non-responsive to this steroid also, then we are going to add colchicine. Although colchicine is a better anti-inflammatory drug, but we are not preferring that because colchicine has a lot of side effects like nausea, vomiting, diarrhea, abdominal pain, hypersensitivity reaction, and lots of bone marrow suppression. Okay? But in case of chronic gout, in a patient with a chronic gout, we are going to give the drug that will be decreasing the uric acid production, xanthine oxidase inhibitor, allopurinol, febuxostat. Increasing the uric acid ka excretion, we call it as a uricosuric. So we have agents like your probenecid, lesinurate, sulfenpyrazone, benzbromarone, and last but not the least is going to be increasing the uric acid ka metabolism, and we are going to call them as a recombinant uricase. These are RAS uricase and P glutticase. These are going to be RAS uricase and P glutticase. RAS uricase and P glutticase. They are the recombinant uricase. Recombinant uricase. They are going to increase the metabolism of uric acid. Because they are very fast acting, we can also utilize them in a patient with a tumor lysis syndrome. This has been also one of the PYQ which can be utilized in a patient with a tumor lysis syndrome, right? So on the left hand side, what are the three that we have for acute? NSAID, steroid, colchicine. In the chronic condition, you can decrease the uric acid level by three important mechanisms. Decrease the production by allopurinol, febuxostat. They are the xanthine oxidase inhibitor. Uricosuric drug, you promote the excretion, right? So probenecid, lesinurate, benzbromarone, sulfenpyrazone, or increase the breakdown of uric acid to a water-soluble metabolite, allantoin, right? Water-soluble metabolite, allantoin. That is going to be RAS uricase, P glutticase. Okay. Okay, next question is going to be about a patient with arrhythmia and antiarrhythmic drug. Which of the following drug can cause pulmonary fibrosis? Just by looking at the question, I think you can mark this immediately. All these are very genuine question from the examination of the year that I have mentioned. 2023 is the genuine question. Please go ahead and tell me the correct one. This is going to be the drug that is going to be amiodarone. Amiodarone, it is one of the class 3 antiarrhythmic drug. They will be associated with multiple side effects like your QT prolongation. They are also going to cause lots of hepatotoxicity. This is going to be very important side effect. QT prolongation, hepatotoxicity. They are also going to cause thyroid abnormality or thyroid toxicity. Thyroid abnormality mein anything can happen. Hyperthyroidism or hypothyroidism can happen. Can also lead to pulmonary fibrosis, corneal microdeposits, जिसको we call it as a cornea verticillata. Corneal microdeposits, we are going to call it as a cornea verticillata. They are also going to be associated with the photosensitivity. You see, if they are going to cause photosensitivity, the sun exposed part will turn out to be bluish gray, and we are going to term it as a blue man syndrome. We are going to term it as a blue man syndrome. Because they have already asked this question, let us figure out what could be the potential MCQ for this one. A patient was started on antiarrhythmic drug, amiodarone. What is the investigation that will be asked on follow-up? What will be the investigation that is going to be asked on follow-up? So I always say you will be asking for LFT because they are highly hepatotoxic drug. You should also ask on ECG because they are causing QT prolongation. So you should always keep an eye on the ECG. Then you should also ask for thyroid function test. Yeah, simply serum TSH you can ask, right? Serum TSH. Or you can even ask for HRCT if the patient is having pulmonary symptom. HRCT or spirometry. High resolution CT scan is the investigation of choice for interstitial lung disease. So pulmonary fibrosis is an example of interstitial lung disease. Okay, so these are the next potential MCQ for all of you. That what investigation will you ask if the patient is on amiodarone? Now, which antiarrhythmic drug is causing pulmonary fibrosis? That is one question sorted. But do we have other drug causing pulmonary fibrosis? What are the other drug causing pulmonary fibrosis? Can you guys tell me? ब्लू मैन सिंड्रोम मैंने लिखा है ना बेटा, यहाँ पे कहीं तो लिखा था, ये रहा ना ब्लू मैन सिंड्रोम. What are the drugs associated with the pulmonary fibrosis? Drugs associated with the pulmonary fibrosis. So we have many drugs. कुछ ड्रग बैन हो चुके हैं. फॉर एग्जाम्पल मेथिसरजाइड, इट्स वन ऑफ द ऑटोकॉइड रिलेटेड टॉपिक. मेथिसरजाइड क्लिनिकली नॉट यूज बिकॉज ऑफ दिस पल्मोनरी फाइब्रोसिस. कैंसर की दो दवाइयां हैं, रेदर बहुत सारे हैं, दो सबसे इंपॉर्टेंट है. दैट इज गोइंग टू बी ब्लियोमाइसिन एंड बुसुल्फैन. रिमेंबर ऑलवेज द कीमोमैन दैट आई टीच यू ऑलवेज. In addition to that, remember nitrofurantoin, one of the antibiotic that can also cause pulmonary fibrosis. Amiodarone is something that I have already discussed with all of you guys. Methotrexate has been associated with the pulmonary fibrosis also. Methotrexate has been associated with the pulmonary fibrosis. Okay. Amiodarone, okay. Bleomycin, busulfan, nitrofurantoin, these are all the example of the drug that will be associated with the pulmonary fibrosis. Gold salt, earlier we used for the management of the rheumatoid arthritis. Gold salt, that is also causing pulmonary fibrosis. Okay. Verapamil is a non-DHP calcium channel blocker. They can decrease the heart rate and they can also cause constipation. So next potential MCQ for this one is going to be verapamil ka related side effect. Quinidine, which group of antiarrhythmic drug? It is class 1A antiarrhythmic drug. Sotalol is having dual antiarrhythmic property. It is class 2 and class 3 antiarrhythmic drug. Why class 2? Because sotalol lol drug aa raha hai, so this is a beta blocker. Why class 3? Because it is also having potassium channel blocking property. So I always say sotalol is very chalak, है ना, वेरी वेरी कनिंग, वेरी क्लेवर पर्सन. ये सोता तो है लेकिन सोने से पहले इट ब्लॉक समथिंग. सोने से पहले कुछ बंद करके सोता है कि कुछ खतरा ना हो जाए, धोखा ना हो जाए. तो क्या बंद करता है सोतालॉल? सोने से पहले क्या बंद करता है? पोटेशियम को बंद करता है. तो ध्यान रखिएगा, सोतालॉल सोने से पहले खोल के नहीं सोएगा, बंद करके सोएगा. और आप भी बंद करके सोइएगा, है ना, नहीं तो सोने के बाद, है ना, चोरी हो सकती है, कुछ भी हो सकता है ना. दरवाजे की बात कर रहा हूं मैं, पोटेशियम वाले दरवाजे की. A 3-month-old patient presented with the paroxysm of cough, apnea. In between with the fever, TLC count is going to be more than 50,000. Absolute lymphocytosis. What is the drug of choice? What is the diagnosis here? Who can tell me the diagnosis? Who can tell me the diagnosis here? The diagnosis is very, very important here, and usi ke basis pe you will be getting the correct one. Amoxicillin, azithromycin, clarithromycin, clotrimazole, cotrimoxazole. It's a combination of trimethoprim and sulfamethoxazole. Yes, very good. Pertussis, paroxysm of cough, which we are going to call it as a whooping cough. Whooping cough, right? We'll be preferring erythromycin or azithromycin. The problem with erythromycin is that erythromycin has been associated with congenital hypertrophic obstructive pyloric stenosis. So intrauterine life may be also, and in kids also we try to avoid as much as we can. So the preferred drug in this case scenario is going to be none other than your azithromycin. That is the most commonly used macrolide. It is the most commonly used macrolide. Another point to be noted that macrolide may, remember, they have no enzyme inhibiting property, therefore they have no drug interaction, no interaction with other drugs. They have no interaction with other drugs. Azithromycin, they are also very long acting, long TRF. So सबसे commonly used macrolide में azithromycin है. It is also considered as a macrolide like azithromycin. It is the best alternative to penicillin allergic patient. Penicillin allergic patients. If there is a penicillin allergy, macrolides are the best, and उसमें भी सबसे जो best होगा, that is going to be your azithromycin, right? So whatever I have written around this, you will see question from here. Believe me, You know, whatever I have written around this is going to be very, very important. Diabetic patient with hypertension was started on ARB. Which of the following is true? Now, this question I have taken previously also. And I always say that some questions are directly taken line by line from the textbook. This is a line by line from Goodman-Gilman. I will show you the screenshot also. You will understand. Hypertension, he was started on ARB, angiotensin receptor blocker. Angiotensin receptor blocker act by blocking AT1 receptor. Which of the following is true? Losartan is a competitive antagonist of thromboxane A2. It attenuates the platelet aggregation. Candesartan clearance is affected by hepatic insufficiency, but not in renal insufficiency. Telmisartan clearance is affected by renal insufficiency. One question that I always teach, that RAS system inhibitor that are going to be safe in renal failure without any dose adjustment that we can give is going to be fosinopril, moxapril, and ये दोनों pril ACE inhibitor हो गए, and telmisartan. Now please remember this important point that I'm telling. Telmisartan is one of the ARB, but it's one of the RAS inhibitor, yes. So telmisartan clearance is not affected by renal insufficiency because these drugs are safe in renal failure, and these drugs are mainly getting excreted by these FMT wale drugs. They are mainly getting excreted by the hepatic route. This FMT are going to get excreted by the hepatic route. FMT, fosinopril, moxapril, telmisartan. They are the RAS system inhibitor, right? Irbesartan clearance is affected in both renal and hepatic insufficiencies. Okay, they are unaffected rather. I'll show you first the textbook line. Goodman-Gilman 14th edition, that is the most latest edition, page number 601. Losartan is a competitive inhibitor of thromboxane A2, and exact line wahi hai. They have not even changed the decrease. They use the same word, attenuate. Question may be wahi tha, attenuate the platelet aggregation. So that is going to be the correct one, losartan. And I always say, learn pharma in my style. Losartan, everything will be low. Losartan has low T half-life, around 3 hours. Losartan, it lower the blood pressure. Of course, it's antihypertensive drug. Losartan, it lower the platelet aggregation. Losartan, it also lower the uric acid level, because they are going to be uricosuric in nature. They are going to cause excessive excretion of uric acid. Losartan हर चीज को करता है लो. Losartan हर चीज करता है लो. Losartan has also shown to lower the glucose level because of their PPAR gamma agonistic property. PPAR gamma was earlier thought that it is mainly and only with the telmisartan, but recent studies are saying no, it is not only with the telmisartan. It is associated. It is also with telmisartan, irbesartan, losartan, तीनों के साथ TIL, telmi, irbe, losartan. Now other option is that telmisartan clearance by mainly by the biliary secretion. So ये तो rule out हो गया. The plasma clearance of irbesartan is unaffected by either renal or mild to moderate hepatic insufficiency. So they are not affected by this one, right? So this was again, as I told you, line by line question from your Goodman-Gilman. Correct answer, if you know the rule of low, losartan, हर चीज होगा low. Low मतलब low नहीं, low मतलब low, decrease. Everything will be low with the losartan, right? You will be able to crack this question easily. Next one is about a patient on organophosphate poisoning was started on atropine infusion and pralidoxime. He developed high-grade fever after 2 hours. Which of the following is the possible cause of the fever? See, 2024 में similar kind of question was there. This time organophosphate poisoning, and he was started on atropine. So as I told you, atropine, atopine, everything will be on the top. Pupil size on the top, heart rate on the top, body temperature on the top. हर चीज होगा on the top. And I also compare that with your hardcore crush, which you also want on the top of the head, right? So that is actually going to be the cause of atropine का side effect. So this is called your atropine fever. इसको बोलते हैं क्या? Atropine fever. Atropine fever is the correct one, and that is why we should always be careful when we give atropine in the pediatric population. All right. A pregnant female with history of asthma. Other options are simply मतलब immediately ruled out. उसका कोई logic ही नहीं है ना, वो they are dummy choices. A pregnant female with history of asthma presented in the 3rd stage of labor. Now asthma is something that 2023 में there were 3-4 questions easily. Which drug to avoid in the third stage of labor? In the third stage of labor, which drug will you avoid if there is a patient with asthma? Misoprostol, carboprost, oxytocin, dinoprostone. What is the third stage of labor? From the delivery of baby to delivery of placenta. I think that is the third stage of labor. अगर मैं अपनी गायनी को ठीक से याद कर पा रहा हूँ, so that is the third stage of labor, right? Full dilatation तक 1, dilatation to baby delivery 2, third will be from baby delivery to delivery of the placenta, and postpartum 1 hour is the fourth stage, right? Now, if there is a patient with asthma, we will not be giving something called your PGF2 alpha analog that can cause bronchoconstriction, and they can always and always precipitate bronchial asthma. They can always and always precipitate bronchial asthma. Among the given choices, the one that is PGF2 alpha analog is going to be A. That is going to be A is the correct one. Now, many of the students, मैं अभी भी अपने एंथुसियाज्म को मेंटेन करके रखा हूं, आप लोग बैठ के सुन रहे हो खाली, फिर भी आप लोग लूज पड़ गए हो, है ना? कैसे लड़के हो आप लोग, कैसे मर्द हो या कैसे लड़कियां हो आप लोग, है ना? कि आप लोग थक गए इतनी जल्दी, अभी तो पार्टी शुरू हो रही है ना? रिवीजन करने बैठे हो, टाइम देख के मत रिवीजन करिए, है ना? आप लोग बस ये देखिए कि जितने टॉपिक आ रहे हैं उससे अगले क्वेश्चन गलत नहीं होने चाहिए. Oxytocin happens to be the drug of choice in the patient with the postpartum hemorrhage. Do remember that, है ना? Dinoprostone, PG1 analog, that can also be utilized for cervical ripening. Same use as misoprostol. In a patient planned for cardiac surgical procedure, which of the following is the preferred antibiotic? Start answering, because आपका जवाब आना कम हो गया है, स्लो हो गया है, इसलिए मैंने बोला कि आप लोग थक गए हैं. थकिए मत, थकना मना है. All right, great. So cefazolin, it is one of the first generation cephalosporin. It is one of the first generation cephalosporin, remember? And they have very high tissue penetration. High tissue penetration. That means they are going to be utilized as a drug of choice for surgical prophylaxis. So just prior to the surgery, the anesthetist will be injecting this one. Cefazolin is the correct one. Not penicillin G or amoxicillin or imipenem. Imipenem is one of the carbapenems. So correct answer is going to be your cefazolin. Cefazolin. Cefazolin is the first generation cephalosporin. Now see, similar kind of question was also asked in your January 2024, which I told you कि उनसे नाराज होके चला गया, and he went to meet someone and now he is having vaginal discharge, penile discharge. But this time in 2023 it was vaginal discharge. Young female partner, multiple sexual partner, है ना? Vaginal discharge. Same gram negative diplococci. Same gram stain is showing gram negative diplococci. Same type of question. See, mindset of examiner is going to be same, right? So the correct answer for this one is going to be, right, Neisseria, gonorrhea, gonorrhea. Doxycycline I already told you, typhus fever, scrub typhus, उसमें यूज करेंगे एरिथ्रोमाइसिन, मैक्रोलाइड, एम्पिसिलिन इज अ ब्रॉड स्पेक्ट्रम एंड पेनिसिलिन, है ना? ड्रग ऑफ चॉइस फॉर लिस्टीरिया, ठीक है? Neisseria gonorrhea, that is going to be gram negative diplococci, it's going to be, है ना? The mechanism of action of tissue plasminogen activators. C, tissue plasminogen activator. 2023 में ये पूछा, आपको याद है 2024 वाला क्वेश्चन? I have shown you already that in 2024 they asked the same question but by showing the image. I hope I get it very easily without making any. See, this question I have already shown you. 2024 का 8th question है ये, ठीक है? So they said कि tissue plasminogen activator has been given and you have to give an antidote, and they have given an image base here. See the image base they have given, and they have which drug will be acting here. So if you understand the mindset of the examiner, believe me guys, you guys will be able to solve a lot of questions just on the basis of the previous year question. The mechanism of action of tissue plasminogen activator is inhibit extrinsic pathway, inhibit platelet aggregation, enhance fibrin degradation, right? So tissue plasminogen activator is going to be drugs like your tissue plasminogen activator is going to be drugs like your streptokinase, urokinase, 10 active place, है ना? So they are going to be fibrinolytic in nature. Fibrinolytic in nature. So that is the correct one. Inhibit the extrinsic pathway वाला जो clotting factor था, that was warfarin. Platelet aggregation के लिए we have aspirin. Then we have clopidogrel, that is going to be P2Y12 inhibitor, clopidogrel. Then we have etopaxar, vorapaxar, that is going to be your PAR inhibitor. अगर इसके अलावा आप फार्मा को रिवाइज करना चाहते हो तो मैं आप सभी लोग को बता रहा हूँ, एक मैंने नीट पीजी का 4 घंटे का रिवीजन सेशन लिया हुआ है, रैदर वो भी थोड़ा सा 4.5 घंटे का हो गया, वो इसी चैनल पे अवेलेबल है, फार्मा रिवीजन फॉर नीट पीजी 2025. आई जस्ट टुक इट, आई थिंक 3-4 भी नहीं हुआ यार, 2 weeks ago, 2 weeks मोस्टली, या मे बी 10 days ago I took it. It is freely available. Please, if you get some time, try to put it on 1.25 speed, 1.25 and watch it out. उसका लिंक, आई मीन उसका पीडीएफ भी आराम से आप ले सकते हो, ग्रुप में भी अवेलेबल होगा, टेलीग्राम ग्रुप ऑफ पीडब्ल्यू मेडेड भी अवेलेबल है, आप वहां से भी डाउनलोड कर सकते हैं, और आप एक बार क्विकली गो थ्रू करिए. तो PYQ प्लस दैट आपका कंप्लीट फार्मा रिवीजन हो गया, ठीक है. All right, next question. I think this is the same one, that is clotting factor we are having, extrinsic and intrinsic, that is going to activate factor 10A. So this clotting factor will be inhibited by drugs like your warfarin, that is going to be, warfarin will be inhibiting the clotting factor. Factor 10A inhibitor will be drugs like your apixaban. In fact, in one of the examinations they simply asked which of the following is the 10A inhibitor. 10A पे ban लगाने वाला apixaban. Then 2A inhibitor will be drugs like your unfractionated heparin or low molecular weight heparin. या direct inhibitor will be drugs like your hirudine, lepirudine, they are the factor 2A inhibitor. Fibrin को lyse करने के लिए we have a drug that is going to be fibrinolytic agent. So this fibrinolytic, if you give, they are going to cause lysis of fibrin. तो fibrin strand will be broken down into small pieces. उनको हम बोलते हैं fibrin degradation product. And if you want to measure the fibrin degradation product, you simply measure the D dimer. If the D dimer level is high, that means the body is trying to get rid of the clot formation, excess clot formation, right? All right. So this is going to be tissue plasminogen activator, that is streptokinase. लेकिन इसका इनहिबिटर अगर पूछ ले तो that is going to be epsilon aminocaproic acid. इसका इनहिबिटर कौन होगा? Inhibitor will be epsilon aminocaproic acid, और tranexamic acid. ठीक है, sorted है. Can we proceed? Very good. Now, as I told you, 45 मिनट में है ना, मैंने 45 मिनट के भीतर कर दिया है ना, मैं अपने बातों का बहुत पक्का होता जा रहा हूँ, है ना. अब 2022 अगेन 35 to 40 मिनट्स के भीतर ये भी sorted है. 2022, are you all with me? Can we do 2022 or you want me to end the session? समय तो बहुत ज़्यादा हो गया, मुझे अलॉट किया गया था 3 घंटा, लेकिन मैं अपनी भावनाओं में बढ़ गया और बह गया, और आप लोगों को बस ये था कि मैक्सिमम कवरेज हो जाए, सो दैट यू डू नॉट रिग्रेट दिस. इफ यू गाइस आर विलिंग, वी कैन कंटिन्यू, अदर देन दैट वी विल टेक अ बिग ब्रेक या वी कैन एंड द सेशन. शैल वी डू? अरे ब्रेक मत मांगो यार, ब्रेक नहीं होता है यूट्यूब में, सेशन में ब्रेक नहीं होता है. मैंने पहले ही बोला था कि ग्लूटियस को मजबूत करना है, खाना पीना लेके बैठना है ना. चले आगे चलें. मिस्टर फूडी, देखिए आपका नाम ही फूडी है, आपके नाम से मुझे भूख लग जा रही है. मैं समझ सकता हूं आपके दर्द को, है ना. कुछ ऑर्डर कर लीजिए, ठीक है. चलो वेरी गुड. चलो क्विकली, जैसे 35 मिनट बोला, 30 मिनट्स के भीतर कर लेंगे, बिकॉज मोस्ट ऑफ द टॉपिक वी हैव कवर्ड ऑलरेडी. सी, विच ऑफ द फॉलोइंग इज द मैकेनिज्म ऑफ एक्शन ऑफ बोtulinum टॉक्सिन? रिमेंबर, बोtulinum टॉक्सिन इज अ ड्रग दैट इज यूटिलाइज्ड इन मेनी कंडीशन. बोtulinum टॉक्सिन बाहर नहीं जाने देता है. FMG 2024 क्वेश्चन, बोtulinum बाहर नहीं जाने देता है. सो व्हाट इज गोइंग टू बी द मैकेनिज्म ऑफ एक्शन? इनहिबिट द रिलीज ऑफ द एसिटाइलकोलिन. इनहिबिट एसिटाइलकोलिन इनटू द प्री-सिनेप्टिक वेसिकल. Inhibit acetylcholine into the pre-synaptic, that is going to be vesicle uptake transporter inhibitor. The name of the drug is going to be Vesamicol. See, it is called acetylcholine wala. NM receptor blocker, that is going to be non-depolarizing muscle relaxant, that is going to be D-tubocurarine, curare drug. curare drug. So correct answer for this one is botulinum toxin. So how to remember? Botulinum बाहर नहीं जाने देगा, botulinum बाहर नहीं जाने देगा. And next potential MCQ, where can we use them? Anyone can tell me where can we use them? Any idea where can we use them? See, it is utilized for the prophylaxis of migraine, achalasia cardia. As a beauty treatment, all the models are botulinumized. Beauty treatment for the facial wrinkle के लिए हम यूज करते हैं, facial wrinkles. ठीक है, facial wrinkle में we are going to utilize prophylaxis of migraine. Yes. Spastic cerebral palsy, these are all FDA approved uses. Spastic cerebral palsy, axillary hyperhidrosis, नाम में ही सब कुछ है. Axillary hyperhidrosis, too much sweating होता है from the axilla, axillary hyperhidrosis, है ना. Spasmodic dysphonia, in ENT you must have read spasm of the intrinsic laryngeal muscle, right? So there also they can use spasmodic dysphonia. There also they are one of the utilized drug. Spasmodic dysphonia, spasm of the intrinsic laryngeal muscle. So they are the next potential MCQ for all of you guys. A DVT patient was started on anticoagulant therapy. Next day, always remember, if it is occurring next day, the patient is presented with the feature that is shown below, likely drug implicated. So this is called your fetal, sorry, not fetal. It is called your, पहले आप लोग बता दीजिए. फेस एंटी एजिंग वही हो गया, एंटी एजिंग मतलब रिंकल वाला. डॉक्टर पंकज तिवारी. I think this is very easy. Next day, always remember, I always say, if there is a hypercoagulable state, W for within 5 days, hypercoagulable within 5 days, so it will be none other than warfarin. None other than warfarin. We are going to call this one as a purple toe syndrome. Yeah, purple toe syndrome. This is the warfarin induced hypercoagulable state. Paradoxical hypercoagulability by the warfarin. Paradoxical hypercoagulable state by warfarin, right? Hypercoagulable state. And to prevent this one, right? What is the cause? The cause is due to inhibition of protein C and S. And to prevent this one, to prevent the purple toe syndrome, what will you do? You are going to add the bridging therapy. और bridging therapy किससे मैंने क्या बताया था अभी 2024 वाले में भी ये टॉपिक आया था. Bridging therapy with what? Low molecular weight heparin or heparin. As a matter of fact, I told you, never start warfarin alone ever. Never start warfarin alone ever, right? We always add the bridging therapy. What are the other option? Dabigatran. They are the orally effective direct 2 inhibitor. All the other direct 2 inhibitor are not oral. This is the only one, dabigatran. और इसका ओवरडोज हो जाए तो एंटीडोट क्या होगा? दबा के दारू, इदारुसीजुमाब. Okay. Then one more thing that I'm telling you, there is a condition that is called your HIT syndrome type 2. HIT syndrome type 2. Type 2 HIT syndrome. This will be usually also an immunogenic response. This HIT syndrome will be an immunogenic response. This can also present with problems like hypercoagulability, but they will never be occurring within 5 days. It is going to occur 5 to 14 days after the unfractionated heparin. HIT syndrome is mainly going to be associated with your unfractionated heparin, and the treatment of this one is going to be direct thrombin inhibitor. That is going to be drugs like hirudin, lepirudin, ergatroban, melagatran, any of them, right? They are the direct thrombin inhibitor. Any of the direct thrombin inhibitor, hirudin, lepirudin, or any other, ergatroban, melagatran, right? So I'm pretty sure you guys have got this important thing. Within 5 days, warfarin, dabigatran, direct 2 inhibitor, rivaroxaban, C10A को बैन लगाने वाला ड्रग. लुक एट दिस, रिवारोक्साबेन 10A पे बैन लगाता है. सो दे आर गोइंग टू बी द 10A इनहिबिटर. Correct answer for this one is going to be warfarin. Fondaparinux, they are also the ultra low molecular weight heparin. Fondaparinux are the ultra low molecular weight heparin. Okay? They will not be having HIT syndrome. HIT syndrome is mainly seen with the unfractionated heparin. ओके हिट सिंड्रोम के भी दो टाइप होते हैं, टाइप 1 टाइप 2 वाला जो वरीसम होता है, टाइप 1 वाला इज सेल्फ लिमिटिंग कंडीशन. विच आर द फॉलोइंग ड्रग रेजिस्टेंट विल यू कॉल इट एज एमडीआर टीबी. मैं बता रहा हूँ ये नीट पीजी का क्वेश्चन है 2022 नीट पीजी, और एफएमजी में पूछा XDR TB का definition. तो I think I have already taught you all the TB का definition, MDR TB, everything I have taught you, isoniazid and rifampicin, everything about TB has been sorted for all of you guys. A patient on antidepressant give a history of bleeding and fatty stool. Okay, तो bleeding हो रहा है, fatty stool हो रहा है, तो that means maybe the fat is not getting absorbed. तो fat soluble vitamin will not be there, fat soluble vitamins, right? That is called your A, D, E, K. अब इनमें से which vitamin is also associated with the clotting? So that is going to be vitamin K dependent clotting factor. There are some vitamins that are associated with the vitamin K. That is going to be 2, 7, 9, 10. So this vitamin K will be activating this clotting factor. So correct answer for this one is going to be vitamin K. So fatty stool है, that means fat soluble vitamin की deficiency होगी. तो which vitamin is deficient here? That is going to be vitamin K. So this is the, I would say, easy peasy kind of question. All right, the gamma carboxylation step. Yes, a patient on digoxin therapy. See again, digoxin फिर से आ गया. A patient on digoxin therapy consumed 8 tablets of digoxin. Each of this is going to be 0.5 milligram. Presenting with a heart rate of 56. Most appropriate therapy for digoxin therapy: DC cardioversion, DG bind, lidocaine, IV quinidine. Out of these, remember, lidocaine is the drug of choice for digoxin-induced arrhythmia, but there is no arrhythmia right now. Digoxin arrhythmia भी करा सकता है, bradycardia भी करा सकता है. So digoxin-induced arrhythmia के लिए lidocaine will definitely be preferred, but here there is no arrhythmia, rather there is bradycardia. We are going to utilize digibind. Do remember that the agents that can be utilized, one will be digibind, that is the drug of choice in severe digoxin toxicity. Drug of choice in severe, तो heart rate देखिए काफी कम हो गया. Severe digoxin toxicity में we can utilize this one. In addition to that, examiner next potential MCQ क्या पूछेगा? What else can be used? In addition to this, what else you can use? Digibind के अलावा what else you can use? Anyone can tell me? What else you can use? You can also utilize atropine because heart rate is very, very less. Atropine is also something that can be utilized. You can also give potassium supplement because potassium always interfere with the digoxin. Potassium will always interfere with the digoxin at the digoxin binding site. And a digoxin is an agent that is acting by inhibiting sodium potassium ATPase. So when they inhibit the sodium potassium ATPase, they always bind at the potassium binding site. They are going to bind at the potassium binding site. They are going to compete at which site? Compete at potassium binding site. So when you give potassium, potassium will always interfere with the digoxin and they will not allow the digoxin toxicity to proceed further. They are going to inhibit the digoxin toxicity to proceed further. All right. So I hope it is pretty easy peasy for all of you guys. Goodman-Gilman again, see here, many students have asked, sir, why not DC cardioversion? So see, Goodman-Gilman clearly says in patient with the elevated serum digitalis level, the risk of precipitating ventricular fibrillation by DC cardioversion probably is increased. This line is line by line from Goodman-Gilman. It was a screenshot. My team has typed it. But anyway, DC cardio and in those with the therapeutic blood level, DC cardio, if the blood level will be normal, then we could be utilized. But high level, we should not be using this. Effective antidote is going to be your digibind. If it still doesn't work, we can give atropine, and we can also use potassium infusion that I have already told you. AB block वाला history आ रहा है, तो you can also give atropine in this case scenario. ठीक है. So again, this is actually going to be your Goodman-Gilman का line से कई बार क्वेश्चन उठा के पूछ देता है. This was a very important question. A patient presented with the ventricular tachycardia, ECG shown below. अच्छा ECG दिया नहीं है इसमें because I think वो ECG मिला नहीं. But see, if the question is itself saying ventricular tachycardia, what is the drug of choice? See, ventricular tachycardia है emergency है. Oral drug तो we are not going to use. As simple as that. Currently, all the drug of choice for all kind of ventricular tachycardia is going to be amiodarone. That is going to be a class 3 antiarrhythmic drug. So class 3 antiarrhythmic drug, correct answer is going to be amiodarone. Correct answer is going to be amiodarone, as simple as that. Next question, in a patient with hyperkalemia, the agent will reduce the level of potassium. Okay, this was a very conceptual question. In patient with hyperkalemia, a while ago I taught you hyperkalemia is going to be associated with RAS system inhibitor. All the RAS system inhibitor, all the drug like spironolactone, I told you already, right? But this time examiner is saying what? Which agent will reduce the level of potassium? Atropine, glucagon, epinephrine, lactic acid. Chemical cardioversion can also be done. Ibutylide, sotalol, amiodarone के साथ हम कर सकते हैं. But the best treatment for that was digibite. In this case scenario, what we'll be using? Mr. Foodie is saying C. Restart, reset, refocus. RRR is saying C. Other student also please take part. है ना? थकिए मत आप लोग. थकना मना है. Which agent will reduce the level of potassium? See, if you are going to look at the cell, over the cell we will have a transporter, and the name of the transporter is called sodium potassium ATPase, that pump 3 sodium out and it is going to take 2 potassium inside. Sodium potassium ATPase. So the sodium potassium ATPase level can be actually done by any beta agonist. So beta agonist like your salbutamol, any other beta 2 agonist or epinephrine or any other beta 2 agonist. Not only that, insulin can also increase the level of sodium potassium ATPase, and that explains the fact that why and how salbutamol epinephrine can also be utilized in the treatment of acute hyperkalemia. So in the treatment of acute hyperkalemia, can we use epinephrine? Yes, the answer to this question is going to be C. Very good, very good, very good. Right? I hope all of you guys have got this one. A 65-year-old male presenting with a rigidity, tremor, bradykinesia, rigidity, tremor, brady मतलब slow, kinesia मतलब slow movement. So there is going to be slow movement. Masked faces. Guys, what is the diagnosis? Just by looking at this, have I already not taught you every point about Alzheimer's disease? And see, Alzheimer's disease, a lot of question has been asked recently. That Alzheimer's disease with the urge incontinence या urine का problem, bladder incontinence का problem, so we are going to use trospium because they are quaternary amine. So here, sorry, Parkinson disease, yes. मास्क फेज ना, मैं अल्जाइमर डिजीज बोल रहा हूँ. अल्जाइमर पढ़ाया हूँ लेकिन देयर द आंसर विल मेनली रिलेटेड टू अल्जाइमर डिजीज का ऑप्शन. दिस इज एक्चुअली पार्किंसन डिजीज. यस 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 पार्किंसन. एक्चुअली द आंसर इज रिलेटेड टू अल्जाइमर, सो दैट्स व्हाई आई रोट बाय मिस्टेक अल्जाइमर. आंसर इज रिलेटेड विद अल्जाइमर. ठीक है. विच ऑफ द फॉलोइंग एजेंट विल बी गिवन? सी, डोनेपेजिल विल नॉट बी यूज्ड बिकॉज डोनेपेजिल इज मेनली गोइंग टू यूटिलाइज द ड्रग ऑफ चॉइस इन पेशेंट विद अल्जाइमर डिजीज. तो डोनेपेजिल को तो आपने रूल आउट कर दिया. Selegiline, rasagiline. Selegiline, rasagiline is one of the MAO-B inhibitor. So this MAO-B inhibitor can definitely be utilized. Thioridazine, haloperidol, they are going to be the typical antipsychotics. They are going to be typical antipsychotics. They are going to be associated with extrapyramidal symptom like dystonia, akathisia, neuroleptic malignant syndrome, secondary Parkinsonism, all those है ना. सेलेजिलिन, रेसाजिलिन, दे आर द माओ बी इनहिबिटर. तो माओ बी इनहिबिटर कौन कौन से हैं? तो मैं क्या बोलता हूँ, लर्न फार्मा इन माय स्टाइल. माओ बी इज गोइंग टू बी मेरा बेटा. और मेरा बेटा किसके जैसा? मेरा बेटा है शेरा के जैसा. और अगले एग्जाम का ये पोटेंशियल क्वेश्चन हो सकता है दैट विच ऑफ द फॉलोइंग इज द माओ बी इनहिबिटर, या सफीनामाइड एक्ट बाई. तो मेरा बेटा किसके जैसा? मेरा बेटा है शेरा जैसा. दैट इज गोइंग टू बी सेलेजिलिन. माओ बी मतलब मेरा बेटा, मेरा बेटा, माई बेटा है ना. माई नॉन हिंदी स्पीकिंग स्टूडेंट, माओ बी माई बेटा, बेटा इज सन. सेलेजिलिन, रासाजिलिन, सेलेजिलिन, rasagiline, and other one is safinamide. Safinamide is a new drug. Selagiline, rasagiline, safinamide. तो मेरा बेटा माओ भी, माँ मेरा बेटा शेरा जैसा, शेरा जैसा. Selagiline, rasagiline, safinamide, right? So that is going to be the MAO-B inhibitor for all of you. A patient presented with a severe headache associated with photophobia, phonophobia. Okay, so migraine is all-time favorite again of the examiner. Photophobia, phonophobia, headache है मतलब migraine है. Simply the diagnosis is going to be migraine. All right. Now look at the question once again. Which of the following drug can provide immediate relief to this patient? Propranolol, sumatriptan, topiramate, flunarizine. Which of the following can provide immediate relief? Propranolol is the drug of choice for prophylaxis of migraine. Flunarizine or verapamil, they are the calcium channel blocker. Calcium channel blocker. Topiramate, valproate, they are the anti-epileptic drug. All these are utilized in the prophylaxis of migraine. The prophylaxis will not provide immediate relief. Immediate relief will only be provided by sumatriptan. Now listen to me very, very carefully. The next potential MCQ, for the next 60 seconds I will be talking about it. It is going to be 5-HT1B by D agonist, not antagonist. Point to be noted here, my all dear students. Sumatriptan. Remember, sumatriptan 5-HT1 by D agonists, they are associated with increase in the vasoconstriction, and therefore they can always and always precipitate ischemic heart disease. Ischemic heart disease, if it is going to get precipitated, you should not give them, or they are going to be contraindicated in patient with the history of angina, in patient with the history of angina, in patient with the history of MI. So in a patient with history of angina and MI, which anti-migraine drug should not be used? That is going to be sumatriptan. It has been FMG 2024 July, FMG 2024 July question. Okay? You can check it out. I have already given in my book also. FMG solution में मैंने दिया हुआ है इसको. Contraindicating angina and MI. Now the next further potential MCQ that I am postulating might be asked that if you do not want this one, there is something also called 5-HT1F agonist. Guys, this 5-HT1B by D agonist, how do they work? They simply inhibit the CGRP release. They simply inhibit the CGRP release from the presynaptic neuron. They inhibit the CGRP release from the presynaptic neuron. On the presynaptic neuron, we also have 5-HT1F. So this 5-HT1F, it says I will not give an F to the CGRP, to the blood vessel. F matlab my receptor F is not at the blood vessel. So this 5-HT1F is going to be drug like lasmiditan. It doesn't give the F receptor to the blood vessel. And you can also remember lasmiditan says that ये less MI देता है. Less MI देता है. So they are also going to inhibit the CGRP release from the presynaptic neuron. They are also going to inhibit the CGRP release from the presynaptic neuron, plus they do not precipitate ischemic heart disease. तो less MI देता है in upcoming exam का. This is the potential MCQ. Do not precipitate ischemic heart disease. अगर आपके एग्जाम में आएगा तो पैनिक मत होइएगा. Put a smile on your face and mark it very, very confidently. Right? Lasmiditan. Very good. A female patient presenting with a TCA toxicity, ECG changes of broad QRS complex and right axis deviation. What is the treatment? See, have I not taught you already? Acidic drug poisoning, basic drug poisoning. We have covered this already, right? So TCA toxicity, tricyclic antidepressant toxicity. Drugs like your imipramine, trimipramine, right? They are always associated with metabolic acidosis. So if they are causing metabolic acidosis, this metabolic acidosis can also always induce arrhythmia, and we are always going to do forced alkaline diuresis using soda bicarbonate. Forced alkaline diuresis. We have covered this. Yes or no? Please tell me. Ascorbic acid, NH4Cl, they are mainly going to utilize in basic drug poisoning because they are going to cause acidic drug poisoning, acidic diuresis. In basic drug poisoning, we will be using them. Okay. Next one. Which of the following drug have least adverse effect on pleura? Bromocriptine, metformin, methotrexate, methotrexate. Least adverse effect on pleura. See, so in 2023, did they ask which is causing fibrosis? Yes. And in 2025 also, there was a question on fibrosis. in one of this INI examination or FMG examination. Okay? So that means this topic is important. Sorted up multiple times. This question has been asked. Metformin has no effect on the pleura. Others, bromocriptine, methotrexate, methotrexate, they will be causing. And I also told you others will be your bleomycin, busulfan, bleomycin, busulfan, right? Methotrexate already diya hua hai, amiodarone. So they're all going to be associated with the pulmonary fibrosis. Correct answer for this is metformin. That is one of the AMP kinase agonists. It's the drug of choice for type 2 diabetes mellitus. They do not have any pulmonary fibrosis wala side effect. A patient presented emergency with acute poisoning of opioid. Very simple question. What is the antidote? See, I've already taught you this one. Without any second thought, your answer should come here. Naloxone is the correct antidote. Physostigmine is also, it is considered as the antidote for what? Atropine. Datura का active component is atropine only. ठीक है? Which of the following hypolipidemic drug act by inhibiting PCSK9? Another very simple question. PCSK9. If you are following me on Insta, the very first thing that I recently you will find me on my page is a very good animated which our team at PW Medit has created. PCSK9 inhibitor. The name of the drug is going to be alirocumab, evolocumab, and inclisiran, right? Alirocumab, evolocumab. So PCSK9, normally a PCSK9 that is present, it promotes the LDL receptor degradation. What do? LDL receptor ka degradation. They do not allow the reuse of LDL receptor. They are going to cause LDL receptor ka degradation, PCSK9. So if you want to inhibit this one, I always say, think of my friend who recently got into a PCS. Ali is evolved into a PCS. Ab isme they are the PCSK9 inhibitor. They are PCSK9 synthesis inhibitor. They are not allowing the formation of PCSK9. At the level of RNA, they will be working. They do not allow the formation of PCSK9. So ultimately, all of them are PCSK9 को ही interfere करने वाले drugs. Correct answer for this one is going to be your evolocumab. Correct answer is going to be evolocumab. Are we good here? Not C. Ezetimibe, easy peasy drug. Ezetimibe is what? NPC1L1. NPC1L1. I have already taught you this. Just I think half an hour ago. NPC1L1 inhibitor. They inhibit the cholesterol absorption from intestine. Cholesterol absorption from GI. Fenofibrate, PPAR, alpha agonist. Atorvastatin, they are the HMG co-reductase inhibitor. All their side effects I have already covered. Guys, if you just listen to this one, lot of topics we have covered in our PYQ topic, right? Alirocumab, evolocumab, they have mainly got approval for their familial hypercholesterolemia, right? When you give PCSK9 inhibitor, after giving PCSK9 inhibitor, there will be increase in the reuse of LDL receptor. So basic concept should also be very, very clear. कि जब आप PCSK9 दे रहे हो तो फायदा क्या हो रहा है? And that is how examiner is wanting to know your knowledge, है ना? PCSK9 से क्या फायदा? What is the benefit that you are getting? Asthmatic patient, theophylline therapy presented with the frequent and increased urination. Okay, how many of you will remember that methylxanthine के बारे में I have already told you? Like caffeine. तो पहले क्या पूछा? I mean पहले ये पूछा. And then 2024 में same question was asked in form of caffeine. Caffeine is keeping you awake. Caffeine is also keeping diuresis, right? So the correct answer is going to be adenosine A1 antagonism, that is going to cause preglomerular vasodilation. That will be increasing the renal blood flow. More renal blood flow will be mainly causing more filtration, leading to diuresis. Okay, histone deacetylation is the mechanism of action of theophylline undoubtedly, but they are having anti-inflammatory property. They do not have any action on the kidney. They are going to have anti-inflammatory action. Remember, theophylline do not work at the NAK2Cl or NaCl property. NAK2Cl activity at the loop of Henle, this will be property of loop diuretics. NaCl at the DCT, this will be property of thiazide diuretics. Right? So other options are also sorted here. pediatric patient presented with the hips arrhythmia. Now, in 2022, 2021 and 2020, 20, 21, 22, there was a surge of question on salam seizure, hips arrhythmia, salam spell, and this question was not only asked in NEET PG, same year May, it was also asked in FMG examination as well. Which anti-epileptic drug is the drug of choice for this condition? Which anti-epileptic drug is the drug of choice for this case scenario? Please go ahead and tell me the correct one. Phenobarbital, phenytoin, ACTH, valproate. What do you think is the correct answer? What do you think is the correct answer? We are about to finish. A pediatric patient, hips arrhythmia, salam spell, yes, ACTH. Now, salam spell ke liye ACTH is something that can be utilized. What else we can use? See, infantile spasm hai na. The next potential MCQ will be in front of your screen in the upcoming examination. Infantile spasm. You said the drug of choice is going to be ACTH. Sometime there will be patient with the infantile spasm with the tuberous sclerosis. We have to use the drug that is called your vigabatrin. In addition to that, there is a new drug if it is non-responsive cases, NR, non-responsive cases. Then we are going to use a very new drug that is called your ganoxolone. Ganoxolone, remember, ganoxolone, it's a GABAergic drug. And I want you to remember by the same way where we are using them in the infant. We are using them in the infant. Infants. Have you seen any infant? They make their own noises. They run their own company. They do everything. मतलब उनको जो करना है वो खुद ही करते हैं, अपने मन से करते हैं. They do not listen to anyone. Infants always and always do everything that they want to do. Infant always and always do everything that they want to do. तो infant गाना गाता है alone. कौन गाना गाता है alone? Infant गाना गाता है alone. That is going to be ganoxolone. Ganoxolone गाना गाता है alone. Very simple. Ganoxolone गाना गाता है alone. Sorted है? गाना गाता है alone. That is going to be ganoxolone. ठीक है? Now, because मैंने ganoxolone आपको बता दिया, it's a GABAergic drug. मैं बता रहा हूँ कि 2 बार से तो मैंने प्रेडिक्ट किया था, नहीं आया. क्या पता इस बार आ जाए, है ना? मैं अभी बता रहा हूँ आपको. First line drug ACTH, drug of choice. Other drugs will be your vigabatrin. It's a GABA transaminase inhibitor. GABA transaminase inhibitor. साथ में हम steroid और vitamin B6 ऐड करेंगे. Second line drugs are going to be all these levetiracetam, zonisamide and all those drugs. The 2 new drugs that I wanted to introduce for all of you guys. One of which is called your styripentol. मैं फिर से बोल रहा हूँ styripentol. बहुत डिफिकल्ट नहीं है. स्टाइरिपेंटोल इज अ न्यू ड्रग. इट्स आल्सो अ GABAergic ड्रग दैट हैज गॉट देयर अप्रूवल फॉर ड्राइवेट सिंड्रोम. तो पूछेगा विच इज अ स्पेसिफिक ड्रग फॉर ड्राइवेट सिंड्रोम. तो स्पेसिफिक ड्रग अप्रूवल फॉर ड्राइवेट सिंड्रोम इज स्टाइरिपेंटोल. एंड हाउ विल यू रिमेंबर? इफ यू हैव एवर अटेंडेड माय क्लास यू विल नेवर फॉरगेट दिस गाइस. जस्ट बाय लुकिंग एट द ड्राइवेट सिंड्रोम कैन यू थिंक ऑफ अ वेरी फेमस क्रिकेटर? ड्राइवेट सिंड्रोम नाम देख के आपको किसी बड़े फेमस क्रिकेटर की याद आ रही है? ड्राइवेट सिंड्रोम का नाम देख करके आपको किसी बड़े फेमस क्रिकेटर की नाम याद आ रही है? Just by looking at the Dravid syndrome, can you think of a very famous, very big cricketer of the country? Dravid. Think of Dravid. See, आपको नाम याद आएगा एक बड़े famous cricketer की, right? Dravid. And whenever Dravid used to play, we always want to see him on the strike. Dravid को हम strike पे देखना चाहते हैं. कहाँ देखना चाहते हैं? Dravid को strike पे देखना चाहते हैं. We want to see Dravid on the strike. Styripentol Dravid, it's a new drug, it's a GABAergic drug. It's a new drug, it's a GABAergic drug. Remember that. Then there is one more drug, newer drug. में 3 न्यू दवाइयों को मैं यूजुअली आजकल बता रहा हूँ कि इनमें तीनों में से कोई भी एक आ जाएगा. एक न्यू ड्रग है जिसका नाम है क्लोबाजाम. न्यू ड्रग का नाम है क्लोबाजाम. Clobazam is a new drug that has got their approval for Lennox-Gastaut syndrome. They have got their approval for Lennox-Gastaut syndrome, which is a recurrent form of generalized tonic-clonic seizure. Lennox-Gastaut syndrome mainly seen in the pediatric age group, है ना? अब इसको याद कैसे करोगे? देखो द्रविड़ को हम स्ट्राइक पे देखना चाहते हैं, ये तो सभी को पता है, द्रविड़ एट द स्ट्राइक, ये तो हमने बता दिया, स्टाइरिपेंटोल। नाउ लेट मी ड्रॉ समथिंग एंड सी हाउ मेनी ऑफ यू कैन आइडेंटिफाई दिस। अगर आपने घर में कभी गए हो वाइफ का हेल्प करने, या वाइफ का हेल्प कैसे ही करोगे आप लोग, है ना, मदर का हेल्प करने, मदर का हेल्प करने तो जाओगे नहीं, गर्लफ्रेंड का हेल्प करने कभी गए हो, तो आपने इस तरह के कोई चीजें देखी होंगी। व्हाट इज दिस, व्हाट हैव आई ड्रॉन हियर, आपको दिख रहा है कुछ, क्या है ये, व्हाट हैव आई ड्रॉन हियर। अगर किसी को समझ में आ रहा है कि हाँ भाई गर्लफ्रेंड को मैंने हेल्प किया था, हम जैसे लोग वाइफ की हेल्प करते हैं, आप लोग जैसे लोग गर्लफ्रेंड की हेल्प करते हैं, तो आपके सुनहरे दिन हैं, सुनहरे दिन को एंजॉय करिए। ब्रिंजल, ऐसे ब्रिंजल कौन होता है, ऐसे कोई ब्रिंजल होता है क्या? बैगन, अरे यार ऐसे कौन बैगन बनाता है, बैगन अगर होगा तो बैगन ऐसे होगा ना, ऐसे होगा बैगन, उसका ये बड़ा होगा, है ना, उसका तो ये कई सारे होता है ना, ये वाला उसका छोटा डंठल, ये होगा बैगन। बैगन कुछ भी बोल रहे हो, बैगन, ऐसे बैगन होता है क्या? इतना सुंदर मैंने इमेज बनाया है, मेरे इमेज की तारीफ करने के बजाय आप लोग बैगन बोल दे रहे हो, अस्तगफिरुल्लाह। क्या बताऊं इन बच्चों को, है ना। हाँ क्लोव, हाँ अजीब मैं लौंग है तू इलायची, वो वाला क्लोव है ये, है ना, तेरे पीछे आ गवाची, पढ़ा होगा ना आप लोगों ने। तो देखिए क्लोव को हिंदी में क्या बोलते हैं, क्लोव, है ना, जैसे जो इंग्लिश बोलने वाले लोग बोलते हैं क्लोव, देसी लोग क्या बोलते हैं, लौंग, क्लोव को बोलते हैं लौंग। तो प्लीज रिमेंबर क्लोव एंड लौंग इज गोइंग टू बी सेम। तो आपको कैसे याद रखना, बहुत आसानी से याद रखना है। सी, इन्फेंट गाना गाता है एलोन, इन्फेंटाइल में हमने दिया गैनोक्सोलॉन, इन्फेंटाइल में न्यू ड्रग गैनोक्सोलॉन। द्रविड़ को देखना चाहते हैं स्ट्राइक पे, ड्रेविड सिंड्रोम में स्टाइरिपेंटोल न्यू ड्रग। क्लोव, क्लोव तीनों में से एक ड्रग अगर आ गया तो क्या ही बात है ना। पिछली बार भी गेस किया था, नहीं आया, है ना, तो मेरा बैगन हो गया। लेकिन उम्मीद है कि अपकमिंग किसी भी एग्जाम में आ जाए और मेरा बैगन होने से बच जाए। क्लोव लॉन्ग, है ना, बिकॉज जब मैं बुक खोलता हूं तो मुझे लगता है यार एग्जामिनर भी तो हो सकता है बुक ही खोल के पेपर बनाएगा, और एग्जामिनर अगर बुक खोल दिया तो समझ लीजिए क्वेश्चन तो आना ही आना है। ठीक है, चलें आगे। ठीक है, a patient consumed around 20 tablets of paracetamol. What is the antidote? This same question was asked in FMG 2025 January examination, that he consumed paracetamol. He was given an antidote, and antidote is going to be N-acetylcysteine. This N-acetylcysteine will do what? So option में था, it is going to replenish the glutathione store. Tell me if any one of you are FMG aspirant here. Have you seen that question or not? January 2024 कि सर आपने तो पढ़ाया था, मैंने कहा था उसके नीचे ये भी पढ़ाया था कि हाउ डज इट वर्क, और आप जाके चेक भी कर लीजिएगा, बैक डेट में यूट्यूब में पढ़ा हुआ है या रिकॉर्डेड लेक्चर पीडब्ल्यू मेडेट में पढ़ा हुआ है। हमेशा बताता हूं मैं, इट रिप्लेनिश द ग्लूटाथायोन स्टोर, बिकॉज पुरानी चीजों को सिर्फ एंटीडोट याद कराना हमारा काम नहीं है, एंटीडोट के बाद कैसे काम करता है, बिकॉज वो पोटेंशियल एमसीक्यू होते हैं। ठीक है, N-acetylcysteine, it replenishes the glutathione store. That is going to be the correct answer for this question. I hope it is making sense to all of you guys. आपके कमेंट पढ़ने के लिए मुझे अपने फोन को थोड़ा चार्ज करना पड़ेगा, बिकॉज फोन का चार्ज खत्म हो गया कांस्टेंट लाइव चलने की वजह से। ठीक है, so always remember paracetamol and acetaminophen, normally they are getting inactivated non-toxic moiety by either conjugation reaction. But when the level is very high, NAPQI being the toxic metabolite. So in one of the 2021 INICET examination, examiner asked NAPQI is the toxic metabolite of what? So acetaminophen. When you give glutathione, when you give N-acetylcysteine, ये देखिए ये इमेज भी मैंने पहले भी दिखाया हुआ है, when you give N-acetylcysteine, N-acetylcysteine will replenish the glutathione store. So glutathione store को replenish करेगा. This glutathione store is going to cause conversion of NAPQI to cysteine and mercaptopuric acid, which is the non-toxic metabolite. Glutathione store is replenished. That will be converting NAPQI into cysteine and mercaptopuric acid, that is non-toxic metabolite. आगे चलें यार, ये सारे ऑप्शन तो पता ही है ना, लूप डायरेटिक है, हाइड्रोलाजीन इज अ पोटेशियम चैनल ओपनर है ना, वी कैन यूज देम इन हाइपरटेंसिव, वी कैन यूज देम इन हाइपरटेंसिव इमरजेंसी, दे आर आल्सो एडेड विद द नाइट्रेट्स टू प्रिवेंट नाइट्रेट टॉलरेंस, टू प्रिवेंट नाइट्रेट टॉलरेंस। इतने रिफ्लेक्स के साथ अगर आप पढ़ लिए तो मजा ही आ गया। डोपामीन इज अ D1 agonist. Dopamine is a D1 agonist. In one of the examination they ask at low dose what will happen. Low dose, in the dose of less than 2 microgram per kg per minute, there will be vasodilation. Low dose में there will be vasodilation. ठीक है. All right. A patient was started on anti-TB drug. He presented with the tingling numbness. We are about to finish. Just 5-7 more minutes and then you guys will be free. है ना? I think 107 108 स्लाइड हैं. 102 पे हम लोग हैं already. 5 मिनट और मैक्सिमम. A patient was started on anti-tubercular drug. He presented with tingling, numbness, of another feature suggestive of peripheral neuropathy. Guys, come on. Isoniazid. Isoniazid is the one that is a drug that is associated with vitamin B6. So what does isoniazid do? Isoniazid inhibit the pyridoxine activation. It inhibit the pyridoxine activation to pyridoxal phosphate. So since they have already asked in 2021 this question, in upcoming examination they will ask why and how they will cause peripheral neuropathy. So one reason is they will inhibit the pyridoxine. Isoniazid inhibit the pyridoxine activation to pyridoxal phosphate, because pyridoxal phosphate is the active form of the pyridoxine, vitamin B6. Plus isoniazid, it increases the vitamin B6 का excretion renally. So renal excretion of vitamin B6 will increase. So there are two ways how isoniazid is getting rid of vitamin B6, right? And please remember the another potential MCQ is isoniazid is not an active compound. Isoniazid is always and always going to act as a active compound, and this active isoniazid is going to act by inhibiting mycolic acid. It is going to act by inhibiting mycolic acid synthesis. तो दिस माइकोलिक एसिड सिंथेसिस इनहिबिशन इसको उसके लायक बनाने के लिए, इस बेटे को जो बिल्कुल ही नालायक है, इनएक्टिव है, बिना काम के है, इसको लायक बनाने के लिए उसके पापा उसकी शादी कराते हैं, और पापा उसकी शादी कराते हैं कैटरीना जी से, जिसका नाम होता है कैटालेज पेरोक्सीडेज। किससे शादी कराते हैं? कैटरीना जी से शादी कराते हैं, जिसका नाम है कैटालेज पेरोक्सीडेज। सो कैटालेज पेरोक्सीडेज इज अ वेरी इंपॉर्टेंट एंजाइम दैट इज एक्टिवेटिंग आइसोनाइजिन। और आपको पता है कैट के अंदर क्या है? कैट के अंदर भी कैट है, बिकॉज दिस इज गोइंग टू गेट एक्टिवेटेड बाय द जीन दैट इज कॉल्ड कैटरीना जी वाला जीन। अब यहाँ पे बहुत इंपॉर्टेंट क्वेश्चन सॉल्व होता है जो कि 2024 2025 एफएमजी में भी था, दैट इज गोइंग टू बी कैट जी जीन। Which drug require their activation by catalase peroxidase? Question number 1. The drug that require their activation by catalase peroxidase is isoniazid. All my FMG student, if you are sitting in this classroom, if you have given 2025 January, then you know already which drug will be resistant if there is a cat G gene mutation. अगर कैटरीना जी उसको लायक बना रही थी, कैटरीना जी नाराज हो गई। अगर कैटरीना जी नाराज हो गई तो आइसोनायाजिड का एक्टिवेशन नहीं होगा। आइसोनायाजिड जैसे नालायक था वो नालायक रहेगा, मतलब नालायक बिना लायक के, है ना, इट विल कंटिन्यू टू बी इनएक्टिव। तो कैट जी जीन म्यूटेशन विल लीड टू रेजिस्टेंस ऑफ कैट जी जीन म्यूटेशन, बिकॉज कैटरीना जी उसको लायक बना रही थी। इफ देयर इज अ कैट जी जीन म्यूटेशन देयर इज गोइंग टू बी रेजिस्टेंस ऑफ आइसोनाइजिन। इज इट मेकिंग सेंस टू ऑल ऑफ यू? तो 3-4 इंपॉर्टेंट एमसीक्यू इस टॉपिक में होते हैं, मैंने आपको सारे बता दिए। विच ऑफ द फॉलोइंग इज द ग्रोथ हार्मोन रिसेप्टर एंटागोनिस्ट? ग्रोथ हार्मोन रिसेप्टर एंटागोनिस्ट फटाफट बताइए। विच ऑफ द फॉलोइंग द ग्रोथ हार्मोन रिसेप्टर एंटागोनिस्ट? मीकासर्मिन तो है नहीं, बिकॉज मैंने अभी थोड़ी देर पहले बताया था 2023 वाले में, दे आर द IGF-1 एनालॉग, रिकम्बिनेंट IGF। इट इज मेनली गोइंग टू बी यूटिलाइज्ड इफ ग्रोथ हार्मोन रिसेप्टर इज रेजिस्टेंट। टेसामोरलिन है नहीं, बिकॉज इट इज गोइंग टू बी ग्रोथ हार्मोन रिलीजिंग हार्मोन। तो अब देखिए आपको पता चल रहा है विच टॉपिक इज इंपॉर्टेंट, ग्रोथ हार्मोन इज इंपॉर्टेंट। तो ग्रोथ हार्मोन से रिलेटेड 4-5 दवाइयां हैं, पढ़ लो। कहां से पढ़ना है? आज ही तो पढ़ाया है, उसका उतना पढ़ लो मिनिमम। ब्रोमोक्रिप्टिन इज अ D2 एगोनिस्ट दैट इज ऑलवेज एंड ऑलवेज हैविंग इनहिबिटरी इफेक्ट एट द ग्रोथ हार्मोन। तो ब्रोमोक्रिप्टिन कैन बी यूज्ड इन एक्रोमेगाली, जाइगेंटिज्म, सब में यूज कर सकते हैं। पेगवीसोमैंट दैट इज द करेक्ट वन, पेगवीसोमैंट, राइट? Pegvisomant is the correct one. Pegvisomant, they are the growth hormone receptor antagonist. Where can we use pegvisomant? Who can tell me? Where can I use pegvisomant? Anyone can tell me where can we use pegvisomant? ग्रोथ हार्मोन रिसेप्टर एंटागोनिस्ट है ना, तो सिंपल सी चीज है, क्या मैं इसको एक्रोमेगाली में यूज करूं? बिल्कुल यूज कर सकते हैं, एक्रोमेगाली में यूज कर सकते हैं, राइट। पेग्विसोमेंट, they have been associated with a very important side effect that is called pituitary adenoma. पिट्यूटरी एडिनोमा, सोचिए एडिनोमा करा दे रहा है, एंड बिकॉज ऑफ दैट पिट्यूटरी एडिनोमा की वजह से पेशेंट कैन प्रेजेंट टू यू विद द प्रॉब्लम लाइक बाई टेम्पोरल हेमी एनोपिया, बाई टेम्पोरल हेमी एनोपिया। तो फार्मा को मैंने बड़ी स्विफ्टली जेंटली स्थल के साथ इंटीग्रेट कर दिया, विच कैन बी आस्क्ड, ठीक है। रेजिस्टेंट केसेस ऑफ द एक्रोमेगाली कैन बी यूटिलाइज, विजुअल सिम्टम वही बाई टेम्पोरल हेमी एनोपिया आएगा। करेक्ट आंसर इज गोइंग टू बी ए। This is the same thing that I have already told you, उसी का summary है। We are about to finish, just 2-3 more minutes. A female presented with the galactoria, urine pregnancy test was negative. Okay, galactoria urine pregnancy test was negative. MRI had revealed large pituitary tumor. So basically there is going to be a case of hyperprolactinemia. And what is the drug of choice for hyperprolactinemia until the surgery is done? That is going to be bromocriptine, which is a D2 agonist. It's the drug of choice for hyperprolactinemia. हाइपरप्रोलैक्टिनीमिया। डीगा रेलिक्स क्या है? दे आर गोइंग टू बी जीएनआरएच एंटागनिस्ट, गोनाडोट्रोपिन रिलीजिंग हार्मोन एंटागनिस्ट, गोनाडोट्रोपिन रिलीजिंग हार्मोन एंटागनिस्ट, दैट इज गोइंग टू बी डीगा रेलिक्स, सेटोरेलिक्स, आना जितने भी नाम है सबके नाम में रेलिक्स आएगा, रेलिक्स वर्ड आएगा, राइट, रेलिक्स। All right. Leuprolide is going to be GnRH analog. This GnRH analog, if you give continuously, they will be usually acting as antagonist, because pulsatile secretion होता है, and if you give continuously, they will be giving the feedback inhibition that will be leading to antagonistic property. I hope it is making sense to all of you guys. All right. So moving on to the next one, that is going to be 11-year-old boy presented to the emergency with vomiting. Parents gave a history of consuming 8 tablets of ferrous sulfate. What is the antidote? तो ferrous sulfate मतलब आयरन है। ब्रोमोक्रिप्टिन कैबरगोलिन सेम फैमिली का है, ब्रोमोक्रिप्टिन कैबरगोलिन सेम फैमिली का है, ब्रोमोक्रिप्टिन कैबरगोलिन। अगर कैबरगोलिन ऑप्शन में है तो दिस विल बी मोर प्रिफर्ड बिकॉज ऑफ लेसर साइड इफेक्ट, एंड मोर प्रिफर्ड because of lesser side effect and longer T half life, so they are more preferred. Bromocriptine, cabergoline, they are going to be from the same family. अगर cabergoline है तो this will be preferred because of the longer T half life and lesser side effect. आयरन है तो फर होगा, बिल्कुल सही बात है। So that is going to be your deferoxamine. And if the examiner is going to ask you that oral iron chelator कौन है, oral iron chelator, that is going to be deferriprone. Oral iron chelator is going to be deferriprone, and other one is called your deferrasirox, deferriprone, and other one is called your deferrasirox. So where will you use oral iron chelator? Always remember, there will be a patient with history of, listen to me what I am saying, patient with history of thalassemia, इस तरह के क्वेश्चन आएगा, और any other condition of blood transfusion, with recurrent blood transfusion. Please remember, with a recurrent blood transfusion, there will always have high risk of increase in the risk of iron toxicity. Iron toxicity का risk is always going to be there with the recurrent blood transfusion. ठीक है, remember that. बाकी rest all I have already discussed with all of you guys in multiple questions previously. A patient on cisplatin therapy, I have already given you this as well. Chemo-induced nausea and vomiting के लिए the drug of choice is ondansetron, but here he has been given an anti-emetic drug, but the patient is developing Parkinson-like feature like dystonia, akathisia, secondary Parkinsonism, है ना, that is going to be tremors and all. So which drug will be causing this? Metoclopramide is the correct one. Ondansetron is the drug of choice. They will not cause dystonia-like feature. Drug of choice for chemo-induced nausea and vomiting. Metoclopramide is a D2 blocker that has also shown to cross the blood-brain barrier, and this excess blood-brain barrier crossing will decrease the dopamine level in CNS. Because of that, there will be increase in the level of prolactin, leading to hyperprolactinemia. And when you block dopamine in the CNS, the patient will also have other feature like abnormal movement like dystonia, akathisia, because all your voluntary movement is controlled by the dopaminergic pathway. Voluntary movement is controlled by the dopaminergic pathway, है ना. आपने पढ़ा होगा डोपामिन में देयर आर सर्टेन पाथवे दैट इज कॉल्ड mesolimbic pathway, mesocortical pathway, nigrostriatal pathway, right? So it is the nigrostriatal pathway that mainly control the voluntary function. तो एग्जाम में पूछा कि which pathway is going to get affected, so remember it is the nigrostriatal pathway. Which pathway? It is the nigrostriatal pathway. See, each option will definitely be ruled out. Just hold on a minute, please. Domperidone is also one of the D2 blocker. Yes, it is the D2 blocker. But the thing is that domperidone do not cross blood-brain barrier. That is one good news with the domperidone. So domperidone can be utilized in nausea and vomiting management. In fact, these are considered the most preferred drug in levodopa-induced nausea and vomiting. Levodopa का सबसे बुरा जो side effect होता है वो nausea and vomiting होता है. Sometimes the nausea and vomiting is so high that the Parkinson वाला जो patient होता है which is on levodopa, he will scold you a lot that earlier I did not have nausea and vomiting, I had problem with the movement, I had problem with the tremor, but ever since you have given the drug, I am vomiting like anything. What kind of doctor you are, right? The nausea and vomiting is so severe with the levodopa, right? Because they are directly going to stimulate the D2 at the chemoreceptor trigger zone, so we need to block D2 as well. Domperidone must to add a drug hai along with that. A pregnant female with UTI took antimicrobial. The baby of the female is brought with the, born with the tendon rupture and arthropathy. So simply, it is asking tendinitis and arthropathy will be caused by which one? Tendinitis and arthropathy. So this, remember, tendinitis and arthropathy has been associated with the fluoroquinolone, but it's not asking the drug. It's asking what is the likely mechanism of action of the drug. I am not making this question. This has been asked by the examiner. तो examiner का mindset को समझिएगा आप लोग please. Examiner का mindset अगर बोल रहा है कि what is the likely mechanism, that is going to be fluoroquinolone. Fluoroquinolone is one of the DNA gyrase inhibitor. Fluoroquinolone is one of the DNA gyrase inhibitor. Protein synthesis inhibitor में one of the 30th inhibitor is going to be aminoglycosides. Important side effect that can be asked in pregnancy. Remember, they will be associated with the ototoxicity, nephrotoxicity. This is always going to be contraindicated throughout the pregnancy. Always going to be contraindicated throughout the pregnancy. प्रोटीन सिंथेसिस इनहिबिटर में एक और है जिसका नाम है क्लोरमफेनिकॉल, जो बेबी को कलर कर देता है. क्लोरमफेनिकॉल. क्लोरमफेनिकॉल इज वन ऑफ द 50S inhibitor, peptidyl transferase inhibitor. Peptidyl transferase inhibitor. This chloramphenicol has been associated with a condition that is called your gray baby syndrome. Since they have asked this question under protein synthesis inhibitor, there is another 30S inhibitor that is called your tetracycline, जो teeth वाला problem करता है. That is going to be associated with the teeth staining and bone growth abnormality. Teeth staining sometimes become irreversible here. ठीक है? Very nice, very nice, right? So this was the last question from my side for all of you guys. This was the whole 4 hour, around 20-minute ka session, more or less, but we have covered, I think, around 100 plus question we have covered in this one. And in this 100 question, we have given a lot of coverage from almost every topic. And just to understand the mindset of the examiner, in every question I have also given you that if this question has been asked, what could be the next topic from the same topic, from the same question that can be asked. I wish कि और time होता, बिकॉज मैं अभी भी चाह रहा हूँ 1-2 घंटा और पढ़ा दूँ, लेकिन आप बात समझ सकते हैं, अगर और पढ़ाया तो मैं घर से निकाल दिया जाऊँगा. आप समझ सकते हैं कि बिकॉज मैं 6 बजे से क्या, मैं उसके पहले से ही गायब हूँ, है ना, 5-5:30 बजे से गायब हूँ, बिकॉज सब सेटअप करने में, इन सब में थोड़ा टाइम लगता है. तो इसलिए आप लोग पढ़ाई करिए, एंड वेरी सुन आई विल बी हैविंग मोर कमिंग अप विद मोर सेशन लाइक दिस फॉर ऑल ऑफ यू गाइस. जब तक एग्जाम है आप मुझे यूट्यूब हमेशा देखते रहोगे, थोड़ा थोड़ा समय दीजिएगा, आपको फार्मा में कोई दिक्कत नहीं आएगा. रिमेंबर दैट. थैंक यू वेरी मच डॉक्टर सिन, डॉक्टर अक्की, नेहा, मिश्रा, अर्पित, अभिजीत, प्रेरणा, तस्मीना, ठीक है, all of you guys. ठीक है, चलिए बाय बाय टू ऑल ऑफ यू गाइस, हैव अ गुड नाइट, आई विल सी यू गाइस अराउंड. एंड पढ़ाइए, पढ़िए, रिवीजन करिए, और हमेशा पॉजिटिविटी के साथ रहिए, बिकॉज आपके आसपास हो सकता है बहुत सारी नेगेटिविटी हो, थोड़ा उससे बचिएगा, बिकॉज आपके रिजल्ट का 20 to 25% रोल हमेशा आसपास में जो हो रहा है उसका होता है. आपके आसपास में कई बार आप नोविंगली अननोविंगली बहुत सारी चीज़ों को ग्रैस्प कर रहे होते हो, लोगों की बातें सुन रहे हो, ऑल्दो यू आर नॉट अ पार्ट ऑफ दैट कन्वर्सेशन, बट यू आर including that if you are hearing to those things that is bringing negativity, try to stay away from that. ये मेरा बस एक मैसेज है, मैसेज तो बहुत सारे हैं, बट आज के लिए थैंक यू वेरी मच टू ऑल ऑफ यू गाइस, हैव अ गुड नाइट, बाय बाय टू ऑल ऑफ यू.